So great pleasure to welcome you to our second post-COVID symposium. The first one we had 1.5 years ago. Everybody knows that COVID was a challenge. COVID is still a challenge, a little bit different conditions in these days. Everybody's afraid it will be a future challenge under whatsoever viral change conditions. But a particular change is post-COVID symptoms or post-severe respiratory infection symptoms. We know that we do not know enough. We know it's a multi-system disease, and we know that in particular we, the German Centers for Health Research, have to work together to address this problem in a better way, in a deeper way, in a more helpful way, really to help patients to cope with these problems. So with this I give over.
Thank you very much, Werner. Welcome also from my side. Good morning. Also happy to see you and waiting for those who are still looking for the place outside. It's now my pleasure to start this symposium today. We will have the different DZGs representing their most current results and their advice. And at the end of this day, we will have a panel discussion with patient representatives, which is also maybe very important to talk to those who are suffering from post-COVID syndromes. And we will start this symposium with Veronika von Messling. She is the representative of the BMBF. This is the agency who gives us the money and supports us helpfully. And she is now opening this symposium today. And we are very happy that you could make it today. We know it's a challenging time and a busy time, and maybe not challenging so far for you. And we hope that you also like the day, and we are really happy to welcome you today.
Well, thank you very much. Am I okay if I'm standing here? All right, you tell me. So in fact, first of all, Professor Dimmler, Professor Seeger, I'm delighted to be here today, and I'm really, really glad I actually made it because we were standing on the tarmac waiting and to get off the plane, which is something I'm usually used to from Berlin. But in Frankfurt, apparently, that sometimes is also an issue. Nonetheless, I made it, and so I'm really happy to have the honor or the opportunity to have a brief welcome address to all of you in honor of this wonderful symposium, which deals with a disease that really affects so many of us and of which we understand so little. So I'm working for the newly renamed German Ministry for Research, Technology and Aeronautics. And those of you who are interested in politics may have noticed that with the start of the new legislation on Tuesday, the ministries were a little bit rearranged, and so our ministry gained the aeronautics and lost the school and education part, which has been moved to the Ministry for Families and Women and Society. So bear with me if I'm getting my abbreviations a little mixed up as we go along. So the new abbreviation is BMFTR, and you give me an opportunity to practice a little, and please be kind if I slip and one or the other time. So as Professor Seeger mentioned, a little over 5 years ago it is now, and it feels like it is ages ago, and we've almost forgot about it. The COVID pandemic went across the earth and affected all of us. Fortunately, most of us were able to overcome the disease. I think most of us have been infected by now, one way or the other. There was a huge race and a huge effort, a huge joint effort of actually research, industry, and politics to be able to have vaccines as soon as possible, to really push on developing drugs. And at the end, this huge effort led us to have vaccines, to have some drugs, and to eventually overcome this pandemic and now deal with COVID-19 as a more or less endemic challenge. Nonetheless, one of the many consequences is what we today call long COVID, a disease with many, many phases that affects people often for a very long time, often not immediately after overcoming the acute infection, but rather subsequently, and that really presents in a broad variety of phenotypes that makes it incredibly difficult to offer treatments or any kind of help to those affected and their families. So very early on in the pandemic, when it became apparent that post-infectious complications are arising, we did have a call to entice researchers to investigate this. And building on that, we have started a number of funding calls and initiatives that try to tackle this complex problem from different directions. So usually this is the time where I have my little ad moment and I will read to you all the different funding calls that we have had. I think most of you will be familiar with this. I would like to highlight a few things, one of which is Professor Scheibenbogen's clinical trial initiative that she started at the Charité in Berlin, that many of you may have heard about, where she actually organizes clinical trials to test available therapeutic options for their applicability to people suffering from long COVID, or as it becomes more and more clear, the most severe form of long COVID, which is ME/CFS. So this initiative has been funded now for almost 4 years, I think, and as much as it is frustrating for all of us who wish that answers would come faster, as this goes along, we start seeing first results from small clinical trials coming out and the larger clinical trials actually running, and we are hoping to have results very soon. The challenge of this is that many of these results are actually negative or inconclusive, which really means we still don't really understand the many differences in phenotypes that these people affect, and which literally means we need more research. So we did start last year a funding call for post-infectious diseases, and a number of consortia have been funded and have initiated their work towards the end of last year. And at the same time, we also looked at this the big question, can we actually use all the new and modern methods that we have, particularly with respect to data analysis, to provide new inroads or new hypotheses for this problem? And we had a funding call for actually specific for data analysis of long COVID patient data or clinical data, and that has been a great success with respect to proposals that came in, ideas that were being investigated, and which clearly shows to us that this avenue is one to pursue even more in the future. So taking advantage of the data that are being collected to understand better or to provide answers will certainly, going forward, be a big thing. Coming back to the clinical questions, during the pandemic, this university medicine network was initiated, building on the realization that a lot of the answers that we urgently needed were generated at the university medical centers. However, each of them was acting more or less by itself, and so connecting them And creating this network really potentiated all the efforts that were pursued by really driven individuals and led us now to have this big, by now fairly big, structure that connects all university medical centers in Germany and that actually allows or encourages exchange and collaboration across the different sites, and hopefully in the future also across different disciplines. Another big hope that we have for that university medical center network is to facilitate clinical trial or clinical research in the university realm by connecting the clinical research activities that are already very strong all across Germany and trying to encourage and facilitate working together, bringing the relevant patients together. As I just mentioned earlier, right, that a lot of those early clinical trials are difficult to interpret, because we realize that these patients that on the surface all seem to be the same or similar, and this is why we can actually include them in the clinical trial, turn them out to not be all that similar at the end, and that makes it very difficult to interpret the data. Meaning that as we start to stratify our patient populations more and more, we will have to have access to patients in other sites to actually get our studies filled up in a meaningful way. So all of that brings me to the next point, the big thing about collaboration. So very often in my office, people come and tell me, well, in the US, everything is better. Well, maybe they came until January. And we should strive to emulate all the strong parts of the US research system. And I think that still holds true to this day. Now, the truth is that our health research ecosystem in Germany is different from the one in the US. Not in terms of quality, but in terms of structure. We have a lot of, from the US, smallish university medical centers. And they, again, from a US perspective, are fairly close together geographically, which has many reasons. So the answer for us to emulate what is really, really great about the US research environment isn't necessarily to create these mega centers, but rather to think about how can we smartly connect what we have, all these strong, smaller nuclei that we have, to make them be a big structure, a big being that can quickly respond and act in concert. And so this thing that we always say, oh, we have networks, we have collaborations, sometimes people feel like, oh, it's not really palpable, right? But what it really is we bring together the strengths of the individual centers, but we don't expect them to become a melting pot. We are okay with this being a mosaic. And I'm stealing this image from the Canadians who always say, well, the US is a melting pot and Canada is a mosaic. And I think this is a very nice image for what our health research ecosystem is at its best. A beautiful picture made up by many individual, very strong and competent points. And that leads me on to the DZG, who are today organizing this meeting and who are our poster child for a structure that managed to bring together researchers around a certain research topic all across Germany and led them to become more than the sum of its parts. These DZGs who celebrated last year, I think, their 10th anniversary, they have brought these research communities together in a way that today in these centers Projects are being pursued and programs are being developed that would have never been developed by an individual university medical department or an individual researcher by itself. So collaborating with others, with other researchers in my research area, but also across research areas to tackle important medical problems is one of the big strengths of the DZGs, and that is why we are so grateful that you picked up the baton when the question was, how do we best address this long COVID CFS challenge? And are now really leading the effort in bringing the different expert disciplines together to look at those different aspects of the disease. Let me also point out that the potential of all these networks, the DZG, but also the network of university medical centers, is not just to bring researchers together across disciplines and transdisciplinary, but also, and that is our great hope and expectation, along the value chain, because ultimately what we do matters when it improves patients' lives. So that challenge of moving things as we learn them also to the patients is a formidable one that we will only ever be able to tackle if we work together, not just amongst all of us as academic researchers, but also with partners from industry and other organizations to actually then ultimately have the impact that actually gets most of us probably out of bed in the morning. And so with that, I would like to close. I would like to thank you for being here, for coming together, for talking about the research, for doing what all of you do best, and which is absolutely the basis for anything that comes after and hopefully eventually reaches those who really, really need our help. So thank you very much and a wonderful day.
Thank you very much. Particularly, I like the image of the mosaicism, and I hope that we have a nice picture bringing all the different DZGs together. I think this is particularly important for this topic of today, and it's now my pleasure, together with Philipp Wild, who comes from Mainz, to start this first session, which is particularly focusing on the heart and the vasculature. And who could be better than Valentina Puntmann to start with the first presentation? So Valentina works together with Eike Nagel at the Center for Imaging, focusing on cardiac imaging. And as you all know, COVID had a strong impact and also the vaccinations on the heart. And Valentina and Eike were the first really to image carefully the persons who are suffering from infectious diseases, but also to image now in long term in patients who suffer from long COVID. And she also started a randomized control trial to try to invent, let's say, therapeutic approaches to really treat patients with long COVID. And I'm looking forward to the newest results. I'm not sure whether you can show, but yeah,
not yet.
Let's see. Keep the tension up.
Exactly.
Thank you very much for joining us today.
Thank you very much for this fantastic introduction. I'm absolutely delighted to be able to talk to you about the MyFlame-19 study. I am a cardiologist, physician, and also clinical pharmacologist, and I have joined Professor Eike Nagel a long time ago to not just do the pretty images, but also develop the therapies which can be guided by imaging, perhaps in the earlier stages. It took me a long time to come to the point where I am today. So proud that I can tell you about a clinical study, clinical trial that does exactly that. These are my disclosures. So the study design and rationale, we've published this, it is out in the open, so if you cannot catch everything that I'm going to be talking about today, it's out there. Also for my lovely patients that I know very well, I have done a little bit of a subtitles underneath so that things can be perhaps also in retrospect looked at. So I will come today with a hypothesis, obviously, that we are working on. We understand that the patients are very, very different, individual, needs to be also understood a lot more deeper than just with one biomarker, with one measurement. This is a complex disease. We believe that there is a common denominator in the background, and this is the endothelial dysfunction. So we know, and there are fantastic reviews out there to which I'm guiding you here, that SARS-CoV, not the virus, but the spike protein, so its long arm, internalizes into the cells. And I'm going to focus here on what happens on a level of vessels. So it enters into the endothelial cells and produces inflammation here on the right-hand side. You can see the rise in interleukin-6 MCP1 within hours of being internalized and producing it. So virus does not have to be present anymore. Spike protein does it for it. And by this also not just induces the endothelial cell inflammation, but also in the bottom graph here on the right-hand side, endothelial cell microparticle formation. So I will show you a lot of evidence that comes from other people that ties very nicely with what we do, what we think. Outstanding study from the hands of Harry Heidecker, so very important researcher in our German community, who developed the ELISA autoantibody test that we have already translated into clinical practice, not yet supported by the insurances. However, very useful in understanding this part of vascular autoantibodies. So renin-angiotensin system activation, endothelial dysfunction, vascular antigens presentation then induce subsequently what perpetuates this inflammation, vascular autoantibodies. Again, very targetedly at the level of renin-angiotensin system. So this. Also additional studies, so additional support to this hypothesis from another group, showing the role of these autoantibodies in vasoderegulation, which we often also see with the patients, either high blood pressure or very low blood pressure, so vascular permeability being a real problem. Another study from the Italian parts showing that, yes, it is this inflammation, these processes are sufficient also to produce end organ damage. Again, I'm showing you things on a cardiac level that also happens elsewhere, as in neuro, renal, and so on. So this is not just limited to the heart. But here you can see patients with cardiac dysfunction have also produced own cardiac self-antigens sufficient to, autoimmunity against them, sufficient to cause cardiac dysfunction. When these serums have been introduced into the animal model, they have developed with time cardiac dysfunction, so really validation of this hypothesis. And perhaps the most important for us to translate, what does it mean, vascular dysfunction, endothelial dysfunction leading to vascular dysfunction, that this actually affects patients very, very much physically. Here, an excellent study, only a letter from the lab of Inigo San Millan, a very important sports medicine researcher, comparing patients with metabolic syndrome, so a little bit on a biggish side, people that are active but not athletes, against patients with post-COVID. The red ones, those with comorbidities, the blue ones, those with no comorbidities, which are our patients, but we're going to come to this later. So when we exercise them, we can see that with the, here's my mouse, with the increase, first let's look at the metabolic syndrome and the moderately active, that with increase of exercise, they slowly increase the power output. But also there is a slight rise in lactate, so they can compensate. They move from aerobic zones through the zone where mitochondria still can tolerate lactate, so metabolic flexibility persistent. And then eventually, yes, they do move in zone 3, where lactate rises considerably. But this is not how things are in long COVID. In long COVID, a little bit of exercise pushes lactate sky high. This is what is the background to them being so unwell when we put them on a treadmill, when we push them through spiro-ergo, cardiopulmonary exercise testing. It all comes with a delay, PEM, post-exercise malaise. We push them beyond the capacity for them to tolerate lactate. So I would really like this to be sort of framed in your minds, that exercise in long COVID is actually causing harm. So our hypothesis is post-COVID condition is, at least in part, spike protein-induced renin-angiotensin system activation, which leads to autoimmune endothelial microvascular disease, endothelial dysfunction, hypoxemia, tissue hypoperfusion, leading to mitochondrial dysfunction, cyanosis, COVID fingers, lactate acidosis, PEM. I'm introducing you to the concept of MARFLAME study. MARFLAME is a multi-center randomized, double-blind, controlled clinical trial of 280 patients with long COVID cardiac symptoms, most commonly tachycardia, chest pains, shortness of breath on minimal exertion. They pace themselves. Sometimes the shortness of breath is not so apparent. Who have no pre-existing cardiac conditions, so no structural heart disease. So they are not cardiac patients in classical sense and have not received any medication. Most of them are like that. They undergo baseline cardiac MRI to, again, verify they have not got structural heart disease. If they do, we send them back to our colleagues. And they have MR findings of inflammatory cardiac involvement. Here are our criteria, and I'm going to speak about this in a minute. What does this mean? We treat them for 16 weeks in a double-blind fashion, placebo control. And then they undergo another cardiac MRI to see whether this was in any way effective. 16 weeks is not enough for them to recover. 16 weeks is enough that we can use cardiac MRI to see, to confirm they are on the right track. That's why we go and treat them with the help of our colleagues, GPs, so Hausärzte, for another up to a year, and at that point they are also much better. This study is supported by Bayer, and we are all supported by DZHK. We have concluded our recruitment, and I'm hoping to be able to tell you about the results at the end of the summer. Coming to cardiac MRI, this is our work, previous work, that have been already giving us clues. These patients may not have structural heart disease, yet they have inflammation. For us, these particular images are déjà vu of what our previous studies in autoimmune conditions have shown. Raised T1, raised T2, edema, perimyocardial late gadolinium enhancement, no necrosis, but inflammation, and obviously in the background, microvascular disease. So I will quickly explain what does it mean, no necrosis. Necrosis, scar, myocardial dysfunction, structural heart disease. These are the late substrates that we at the moment are able to see, able to work upon, able to act upon in line with our cardiology guidelines. This is not what we do in MARFLAME study. We are after the early substrates. So here you can see mitochondrial signals stress that translate in osmotic swelling of the mitochondria, intracellular edema. And yes, you do have to have incredibly sensitive methods. This is nothing off the shelf. from Siemens and Philips and GE and so on. These are the methods that we have worked on very, very hard for 15 years, made sure that they perform when we need them. We also are working on translating them, making them available to the hands of many. That is not just where we are today. T1, very sensitive measure of abnormal myocardium. T2, specific for water. When they are up together, as we can see here, I can't see my mouse, here in this context, they tell us about intracellular swelling. This is what we see also in patients with COVID. In conclusion, MARFLAME-19, blueprint of cardioprotection study. No structural heart disease, yes, inflammatory signals, as I've shown you, aiming to prevent development of structural heart disease. In a selected population, we have defined them through phenotype, through cardiac MRI, T1 and T2 mapping, using these highly precise measurements. And we are using existing drugs with good efficacy, a known pathophysiological profile to target what we think is the problem, endothelial dysfunction. With this, I would like to thank you all, and especially patients groups that have been enormously supporting us. Thank you so much again.
Good morning. Thank you very much, Valentina, for a great overview, great talk. So we have time for an urgent question. Is there a question? So I have one. You saw a lot of patients, I know, and with you, based on your experience, sometimes we see this patient with quite some inflammatory signs in the MRI afterwards, but not yet cardiac systems or exercise tolerance. How should we deal with those in your experience?
So with cardiac MRI?
So you see the changes in the cardiac MRI, but from the symptomatology, they are still quite okay, so you would not call it yet cardiac symptoms or exercise, or they don't have experience in exercise intolerance, but you see the lab changes and you see the MRI. How should we deal with those?
So this is the group that is not MARFLAME population. I must say, most patients in MARFLAME have very, very severe symptoms. When the symptoms are mild, first things first, it's not just about drugs, it's also about lifestyle changes. They have to learn everything about pacing, and I'm grateful here to patients' organizations that have also listed what they should do. I will just quickly go back to this one. Please do frame this in mind. How important it is to understand vascular damage, how quickly they can push themselves. This is not about fitness. This is not about trying to increase the mitochondrial capacity. No. This is about getting the vessels not to be damaged by doing too much, by lactate in the aftermath. So pacing is the first measure, drugs as the next, and drugs do work. Thank you.
Thank you very much, Valentina. It was a great talk. And as we heard, thrombo-inflammation is very central in the sequelae of long COVID, and I'm happy to announce the next speaker from Munich, Konstantin, who will present on thrombo-inflammation and COVID-19. Konstantin.
Yeah, thank you for the nice introduction, and we will stay in the cardiovascular field, but I will talk more about mechanistic studies and how they show that thromboinflammation might be something which is involved not only in COVID-19 but also in long COVID. So we have heard that long COVID is heterogeneous, it is a syndrome, and there are multiple clinical manifestations of long COVID which range from neurological to cardiovascular, and I will focus more on the cardiovascular manifestations, but this also, as said, suggests that this is not only heterogeneous from the presentation but also from the mechanisms. So there are numerous potential mechanisms of long COVID, and Probably these are not working in parallel, but these are probably a chain, and these are interconnected, but they might be very different in different patients, which then have different symptoms. What I will focus on is blood clotting and endothelial abnormalities, but this is not isolated. So this is something which is embedded into the other pathologies underlying long COVID, which is autoimmunity and immune dysregulation. And this might even be connected to neurological dysfunction, and I will show you some data on that. So what is thrombo-inflammation? So thrombo-inflammation is a process which is designed as host defense mechanism. So we all know that when a virus attacks us, the immune system gets activated, but this is not the whole story, but also the clotting system and platelets get activated. And this is a mechanism how the body prevents the dissemination of pathogens in the body. And this has a lot of advantages, but it has one disadvantage, and this is that the blood vessels might get blocked, and this causes tissue ischemia, tissue damage. So in the end, there's a tight interplay between coagulation, complement, platelets, innate immunity, which finally results in clot formation. And these clots might not only have an acute effect, but also a long-term effect, which I will go on later. So initially, we had clinical manifestations of COVID, which ranged from mild symptoms to hospitalized patients and very critically ill patients. And interestingly, this is also paralleled by vascular processes. So in the mild disease, we have no evidence of clot formation in the microvasculature, but in the critically ill patients, there was a lot of thrombotic complications, but also microvascular dysfunction. And this is connected by thrombo-inflammation. So the viral hit, which we see here in the computed tomography images we got used to, shows that there's a lot of inflammation going on in the lungs. But also this results in the blockade of blood vessels. And these blood vessels are not only blocked by clots, but these are full of inflammatory cells. And as said, this is not only something happening in the lungs, but this is a systemic process. So we see processes in the lung, but also in the heart and the kidney. So indicating that this is really a systemic effect of activation of thromboinflammation. This is a more detailed scheme on what happens in the body and how this connects the respiratory failure in patients with systemic coagulopathy. So when the virus gets into the body, it activates endothelial cells, activates platelets, neutrophils, and these form then clots in the microvasculature, which then gets apparent as respiratory failure in the patients, but also causes a systemic coagulopathy, which then results in an increased risk of cardiovascular diseases as stroke, myocardial infarction, and pulmonary thromboembolism. So could complement be a target? So what we saw in patient samples is that platelets really form aggregates with antibodies, but especially with complement factors. And I showed you that complement is critical for activating not only platelets, but can also activate the immune system. So it could be a link between inflammation and thrombosis. And from patient samples, we saw that D-dimer levels correlate with activation of the classical complement pathway. So it could be the complement activation is then the bridge to activation of the coagulation system. And we tried this in mice, and we saw that when we block classical complement activation, the formation of these pulmonary thrombi was decreased, going back to non-infected levels. But one has to be cautious because this is data in mice, so this is no evidence in humans, but I will talk about the complement system later on to convince you that this might be something to look into closer. Okay, so this was acute COVID-19. So what is the connection to long COVID? So we know that there's persistent vascular dysfunction in long COVID. There's hypercoagulability, there's not only microvascular but also microvascular thrombosis. And there are different levels of evidence, one from epidemiology, others from biomarkers, and also from experimental studies. And I will guide you through these different evidence levels. So this was a study which I think drew the attention of many cardiovascular researchers, that even though the acute infection was gone in patients, they still had a high risk of thrombotic events within 1 year after COVID infection, even if there was no virus present. However, one has to be careful in this study because this was performed without vaccination very early on in the pandemic on male veterans. But it shows that there are deep results in the cardiovascular system from the acute infection, and that the risk for thrombotic disorders also depends on the initial disease severity. So patients which had a mild disease had a lower risk, but still they were at risk. But especially critically ill patients had a really high risk of cardiovascular events after infection. But there's also experimental evidence for a role of thrombo-inflammation in long COVID and beyond the acute infection phase. So fibrin, as you all know, is central for clot formation, but it also promotes neuroinflammation and neuronal loss after infection and is connected to lung pathology. And this was a study published last year in Nature, and they showed that when they incubated plasma with fibrin strands, as you see here, with infected plasma, the spike protein of SARS-CoV-2 attached tightly to fibrin. And this forms like a toxic combination, causing then, in the end, the deposition of fibrin and spike protein in the vasculature. And this drives systemic thromboinflammation and neuropathology in COVID-19, as they show experimentally, one has to say. So they also used an antibody blocking for this pro-inflammatory effect of fibrin, also in mice, so there's no human data. But they showed that by blocking this, they could attenuate not only lung pathology, but also brain pathology in these mice, showing that thromboinflammation might be a target not only for the acute setting, but also for the long-term sequelae of COVID-19. What are the biomarker evidence levels for thromboinflammation in long COVID? So this is a study also from last year published in Science by another group. And they followed up COVID patients and did a really deep clinical phenotyping, measured a lot of proteins in the serum, and they found that complement and thromboinflammation markers are the top biomarkers for active long COVID. So C5, C7 are parts of the complement system, and von Willebrand factor, LMSTS13, are parts of endothelial activation. So indicating that indeed thromboinflammation might be something to look at. However, as said, they got a little bit deeper into that, and their conclusion is that long COVID is accompanied by a blood signature marked by increased complement activation, as shown here. They showed that there's especially an activation of the terminal complement pathway. They showed that there's ongoing thromboinflammation, including activated platelets, which form aggregates with monocytes, activating the clotting system. And there's also evidence of tissue injury as well as markers of red cell lysis. And this was interestingly also connected to increased response to other viruses like CMV and EBV elevated antibody levels. So this seems to be, as I said, connected to other mechanisms in the body of host defense, which then result in thromboinflammation in the end. What are the implications from that? So I think an early cardiovascular assessment of long COVID patients is necessary to exclude that there's a really obvious cardiovascular disease resulting from COVID infection, as we know that this is a risk factor for cardiovascular diseases. And this is, I think, more speculative, but the authors from this study concluded that antivirals targeting SARS-CoV-2 or even herpes viruses could reduce thromboinflammatory responses, and that complement therapeutics might be a way to affect long COVID. Also, the evidence here is lacking from the study. But this is an idea which might be followed up in the future. So, as I said, there are numerous manifestations of long COVID, and one is dyspnea, breathlessness. And this was another study showing, going into the different phenotypes and how they correlate with blood biomarkers. And one thing which stood up also when they looked into the association of biomarkers with breathlessness and long COVID was the activation of platelet pathways like thromboxane and PDGF receptor beta. So there's, I think, compelling evidence that thromboinflammation might be part of long COVID. Also, we don't know if it's just a part of a chain, just a biomarker, or if it's just a causal link. So to sum up what we know about thromboinflammation in long COVID, thromboinflammation is certainly associated with long COVID, linking several pathomechanisms, but we don't know if it's associated with specific subtypes, if it has a causal role or is just a biomarker or part of a chain of events. If it might even be a therapeutic target, I think there we need more evidence to claim that. But certainly the cardiovascular community needs to be aware of these patients and really has to have a long-term look at them to see how we can help these patients. And with that, I would like to thank you for your attention and the team, which was really interdisciplinary, and it was a great experience to work on this with so many disciplines in the field, and obviously also the DZHK for its support. Thank you.
Thank you very much, Konstantin. Are there questions to the talk? Yes, please.
So maybe from the different thrombo-inflammation, which one would you think would be the most useful to monitor in the clinical setting? I mean, there's some ideas of looking into nets or, of course, microclots related to in plasma poor or depleted from platelets, microclots. What is measurable? What could we measure in the clinic as a biomarker from your perspective?
Yes, well, this is going into the questions about which one is best in the clinics. And this was the study here, and they showed that specific complement factors might be something to look at, as well as markers of endothelial activation. But of course, this is a specific setting, and this is not specific to long COVID. So I think this is the point, that even if we measure these factors, we cannot sure if it's long COVID or if it's just another infectious diseases. But I think it's rather not a single marker, but maybe a biosignature. I think it's more a pattern than a single target.
There is a broad use of anticoagulation, platelet inhibition epidemiologically. Can we learn anything from these data discriminating as to thrombo-inflammatory events?
Yeah, so this is a really good point, because there were also early in the pandemic hopes that targeting coagulation in platelets could be something to prevent the severity of disease, but the evidence is rather low. So that's why I think that just targeting classical complement coagulation in platelets is not the way to go. I think we need to have something targeting thromboinflammation specifically, and their complement might be something to look at. Also, we have to bear in mind that complement inhibition might then affect the immune system, causing immunosuppression. But I think the data for antiplatelet therapy and anticoagulants are rather disappointing.
Just a very quick comment. A lot of patients use nattokinase, which is actually anticoagulation therapy. They perhaps do not necessarily understand that this is, yes, sold as a supplement, but we actually do not have necessarily the safety profile for this drug. Wouldn't it be a good idea that we, as soon as possible, do some sort of a study where we also understand whether these drugs are at all useful, so efficacy as well as safety, and perhaps go into the profile of the anticoagulation drugs that we already have that are licensed for this use? I would much rather, with a clear indication, use rivaroxaban and things that we know very well from the safety perspective than nattokinase, where I don't know what is going to happen. So it would be informative for the patients to know what to do, and obviously also the doctors.
Yeah, so I cannot recommend the plain use of anticoagulants for every patient, but I think that's a question of which subtype of patient. Maybe there are subtypes of patients which have a really strong thrombo-inflammatory activation, and they might actually benefit from that. But as said, the evidence for just using anticoagulants is rather low. And I think that this is because this is something which is going in a chain and not going in parallel, and probably we have to pick the right place in the chain to really disrupt the pathomechanisms mechanisms.
One last question.
So you showed the effects in the acute infection in the beginning. Is there any idea what in the long COVID situation could drive the thrombo-inflammation? After 1 year, would you suggest that there's autoimmunity or still virus there?
Yeah, so probably there's an autoimmune dysregulation, which also comes from reactivation of other immune processes, like to other viruses, and also the persistence of endothelial dysfunction and also fibrin clots in the circulation, which then could be a remnant driving autoimmunity, because we know that coagulation feeds back on autoimmunity and vice versa. And this is probably a vicious circle, and which then results in this, could result in these symptoms. Yeah.
So thank you very much. There in the coffee break we'll have more time to ask questions to Dr. Stark, but for a matter of time I would go ahead. So our next speaker, Carsten Schömer, was unfortunately... Thank you first, thank you. So our next speaker, Carsten Schömer, was unfortunately on sick leave, but he is giving us a talk hybrid online today. Unfortunately, we were not able to manage yet the connection, and this will be likely put after the coffee break, if that works. And I'll hand over now to the next chair, Silke Andrich from the DKTK.
Yeah, good morning from our side. I've been introduced already. I am Silke Andrich. I'm leading this session, Metabolic Disease, together with Professor Alexandra Nitas. Yeah, we have 3 excellent speakers today. Talks are scheduled for 12 minutes, and we have time for questions or discussions. And the first speaker is Professor Alexandra Nitas from Freiburg. She will present findings regarding persistent symptoms 2 years after COVID infection. Please welcome Professor Nitas.
Yeah, thanks, Silke, for the nice introduction. Yeah, I'm standing here on behalf of the EPILOG working group. EPILOG stands for Epidemiology of Long COVID. And our working group consists of clinicians and scientists from the 4 university clinics and universities in the state of Baden-Württemberg, Tübingen, Ulm, Freiburg, Heidelberg, and what did I forget? Heidelberg. Yeah. So we are also working together with the Center for Mental Health in Mannheim. And I'm representing here our work, which was in parts recently published in PLOS Medicine. I have no conflicts of interest, and here is the study design of the EPILOG study. You see also the representing universities on top. And we have initiated our study already in 2020, when we collaborated with the health departments and invited individuals with PCR-confirmed SARS-CoV-2 infection to participate in a survey, in a questionnaire survey. We sent out more than 50,000 questionnaires in the state of Baden-Württemberg, and we received back 11,700. From these questionnaires, we defined our putative long COVID individuals with the following definition. So the people should have had at least one persisting symptom of grade moderate to severe, and they would not have regained full health and full working capacity. And with that definition, we went into the second phase of our study, where we wanted to better clinically look at our individuals which had putative long COVID and controls. So we selected 982 cases from this initial phase and 576 controls with a median of 17.2 months post-infection. We then, in the different university clinics, engaged in comprehensive medical examination, performed cognitive tests. We had a whole battery of standardized questionnaires. We have had biomarker measurements performed, and we completed biobanking. We also have a third phase of that study, which is not content of today's talk. Here are, first of all, the main people involved in this paper, which we just published. And you see here that from phase 1 to phase 2, we had 2/3 of the patients that remained cases. So the majority of cases still remain cases after almost 2 years after the acute infection. We had a few people that improved to the intermediate state or even recovered. And we also had a few people that were initially long COVID-free that developed long COVID, and the predictors were lower educational status and a secondary SARS-CoV-2 infection, whether the predictors of significant improvement were higher education, no medical treatment of acute infection, and some other indicators of a less severe acute infection status. And now I would like to draw your attention to the next slide, where we basically compare the different main symptom categories between phase 1 and phase 2. You see here that also in our study, fatigue, neurocognitive impairments, chest symptoms, smell and taste impairments, and anxiety, depression, or sleep disorders were our main symptoms category. This basically remained very similar in phase 2. However, we see differences. So we see specifically for smell and taste disorder, that's in phase 2, less people were affected, but we do not see much of an improvement with neurocognitive impairment and also anxiety, depression, and sleep disorders. When we excluded from this 1,500 individuals all those that had previous health conditions, and when we excluded people that had another explanation for the persisting symptoms, we basically see very similar findings of our symptom prevalences. So fatigue, neurocognitive impairments being the top symptoms here. And then we looked at quite a number of different standardized questionnaires. And what was very interesting, that in the self-assessed questionnaires, we found a very extreme differentiation between the people that had the worst performance, so the persistent cases, and the stable controls, and the people that improved as cases, and the stable controls that deteriorated were in between. And what was very interesting, that the area under the curve was above 0.9, so we could discriminate these two groups very efficiently by these instruments, which addressed subjective cognitive disturbances, sleep impairment, fatigue, quality of life, and so on. On the other hand, when we applied tests for neurocognitive capabilities, like the MOCA test or the TMTB trail making test, then we could also see significant differences between the persisting cases and the controls. However, the area under the curve was much less pronounced, and was only a little higher than the area under the curve after adjustment for age, sex, study center, and university entrance qualification. So we see this very big differences between the self-assessed and this more maybe objective measures. However, we then had other findings which were significant. Out of time reasons, I skipped them because you can all read them in our publication, which was recently published. But complement activity we could not find in our big study, actually. I can maybe conclude here. And I would now like to take the time to also address the specific subgroup we have investigated, the people with post-exertional malaise. So we had more than 1/3 of the individuals of the persisting cases presenting this exercise intolerance. And we had almost 12% with symptoms compatible with ME/CFS. And we could also find that all the different symptoms, as you see here in this pyramid, were more pronounced among the people with PEM than among the cases without PEM. So you see the dark brownish and the grayish colors were more frequent among these individuals. They had more pain, they had more concentration difficulties, memory disturbances, and obviously also fatigue. And all the different dimensions we looked at with the MOCA test and also grip strength and so on were more severe in these PEM individuals. So this is a very severely affected subgroup of long COVID in our population. Now I would like, because this is a metabolomic session, to give you some first peek into our metabolomic data. I'm very happy that Max von der Linde is here in the group, from the group of Melanie Burrius, who did the analysis, and Professor Uta Merle is the PI of the project, and the measurements were performed in Heidelberg in the lab of Dr. Poschet. And I do not want to go over all the technical parts out of time reason, but I present you now the study population. So we investigated 1,000 individuals, more females than males, more cases than controls. And what you can also see that we had significant differences in the study populations. So we needed to adjust for certain variables to have valid data, because the BMI distribution, the body fat percentage, was much higher among our cases. So here you see what happens to our significant results if we adjust for all these covariates. So not much happened with sex and age because it was a matched study design, but then when you adjust for percentage body fat, you see that there's a drop in significant values from 25 to 8. If you then continue adjustment for smoking and university qualification, only 2 candidates remain in our large study population. I can reveal you now one of our hits quickly, because it's all not published. And we have here the results on the left side, unadjusted or not adjusted for body fat percentage. But if you adjust, then only serotonin and another factor, which I will reveal later when we have published, remain significant in this large study population. And the result is, as you can see here, largely driven by women. We do not see that in the male population here in our data. And what is interesting, that there is quite some further evidence that serotonin depletion has a role in long COVID. This is from a Cell publication last year. They did mouse work, they did organoid work, and also had investigated patient cohorts, and they could also see a depletion of serotonin in the people, not only with acute COVID, but also among those that developed long COVID. And what was very interesting is also that there were several publications now that selective serotonin reuptake inhibitors were inversely associated with long COVID in several studies, like the US National COVID-19 Cohort Collaborative data, where they found a 29% reduction among the people that consumed these or were treated with these drugs. And this was also found basically in a population of people with depressive conditions, so that we believe that there is some real mechanism behind serotonin. And what they proposed is that the viral infection leads actually to a virally induced type 1 interferon induction, and that this leads to low serotonin level, that this drives hypercoagulation and platelet dysfunction, and is also involved in affecting the vagal nerve, which then has some role also in neurological dysfunction, leading eventually to long COVID. And I believe that it's basically not maybe only the virus that here has a role, but it's a strong genetic and epigenetic variability in the serotonin pathways. So we see differences between men and women. Serotonin synthesis rates are lower in women. We have also tryptophan metabolism, where the women are more prone to alterations. The gut microbiome plays here a very important role, and also taurine as one of the supplements that has helped some people with dysbiosis was shown to lead to increased serotonin levels. So we believe that it's interesting to continue with serotonin as a risk factor, and also in our EPILOG study population, we would like to combine this epidemiological metabolomic data with data on the microbiome. We have first data, so this is just a peek into our data, where we see in women with PAM reduced alpha diversity levels. We have whole genome sequencing data, which is now in the process to being analyzed on almost 700 whole genomes. And we have also nice collaboration with Mannheim, and they helped us to derive polygenic risk scores, and we have lots of traits addressed here, and all this data is now available, so we can do combined analysis. And we also want to reach out to the community. I think it's very important that we collaborate here on the national and even on the international level, that we systematically test the promising markers here, also regarding data pooling and meta-analysis. We should team up with all the large initiatives. Many people are here. I have definitely forgotten some of the initiatives which are important, but the NUM-NAPCON, all the initiatives of the DZGs are here to name. The Long Care, the new project which was mentioned this morning, as well as PetNet with the children and young people, and also prospective cohorts, where I have to name the NARCO study as one important source to really get pre-pandemic biosamples, and also patients' organizations, because they know a lot about their disease and they are think to be included. So now I would like to come to an end, showing you the metabolome, the microbiome of many of our patients, so very colorful. And on top of that, all the people that have contributed. I want to thank all the state of Baden-Württemberg for supporting us, and all the different people. Raphael Peters here in the room. I see also Max von der Linde, and I think Claudia Schilling is coming later, and also Herr Kreuslich is here. So we have a lot of people from our study that can help me to answer your questions. Thank you very much.
Thank you, Alexandra, for this interesting presentation. We have one online question. How did you assess depression with PHQ-9? Yes. Okay. Online questions. Now I can see myself. It's a bit after the time on the screen. Yeah, we would like to encourage you to post online questions. At the moment there are none, so maybe in this room, are there any questions from the audience? Yes. You can use the microphone here, but I'll also come to your place.
Dankeschön. I suffered myself from post-COVID and long COVID, and I'm recently working for a program where we did a research on fatigue as well. And my question is how you measure the change in fatigue as a symptom. Maybe you explained it, but I didn't fully understand. So as far as I know, there's no biomarker for fatigue as symptom itself. So how did you measure the change?
One instrument which we used. And we also had, in our questionnaires, we had also questions addressed which were derived from the McPaul questionnaire, the Canadian questionnaire, which was adapted by, I think, Uta Behrens and so on for querying ME/CFS. So this was used here in our study as well. Yeah.
Just another comment. SSRIs, very commonly used in Germany is venlafaxine, which is actually very cardiotoxic. So this is perhaps just a little comment from a cardiovascular clinical pharmacologist that we also need to be very careful with choice of drugs. European Society of Cardiology has a very clear guidance on which are the preferred SSRIs when there is also cardiac disease involved. And the very top of the list comes sertraline. So I hope this is a helpful comment to.
Yeah, thank you very much for this very important comment. And I hope that you do not now see this data I have presented as now argument to take drugs. That's definitely not my interest, but I just wanted to understand the pathway a bit better to support this. So I think dietary supplementation could be here on the tryptophan pathway a much better approach, certainly, than to take these drugs. But I think to understand better our biomarker results, I wanted to mention this big study that have been conducted, but not to now stimulate you to take these drugs without need.
There are some more comments or questions online. I will start with the last one, and then I will hand it over to you, and you will have a look which question you have not already answered to serotonin. The last question is, how does this relate to ME/CFS?
Yeah, actually in ME/CFS, you mean the data on serotonin? There have been some, I think, clinical trials which were not successful. This is what I read, but I'm also not an expert in that field, so maybe there are other people that can more competently answer that question. But certainly what we want to do is also look at our subgroup of PEM. So far, I think, Max, you can later comment on that maybe in the coffee break, but the PEM data did not reflect so much the serotonin finding. Am I correct? Yeah. So that maybe is a subgroup, the PEM people, that where the serotonin was not the most important metabolite which we identified, but it's not published yet. That's why I didn't present it today.
Okay, so maybe you have a look, and we have time for one last question online.
There was another one, how about treating post-COVID with SSRI, so I mentioned that already. Is that related to serotonin or the serotonin autoantibodies that were found at the University Hospital Tübingen? Actually, I don't know if that is related to that. Maybe somebody's here from Tübingen can answer. And then I think, are there future plans? Yeah, the future plans are to bring all these data sets together, to reach out to the community, to get larger data set, to be able then to hopefully get more light into this mystery of long COVID ME/CFS.
Okay. So thank you very much again. Our next speaker is Professor Stefan Bornstein from Gießen. And he will discuss the link or interplay between diabetes and post-infectious syndromes.
Thank you for having me for this wonderful meeting here. I think it's exactly what we need, this interdisciplinary approach. So thanks for Stephanie and Werner for organizing this. I think it's a fantastic topic also for young scientists and young doctors to focus on, because it's really interdisciplinary. And I would like to go one step back and start a little bit provocative by saying, is there a co-evolution of diabetes and these post-infectious syndromes? I like to speak about post-infectious, not so much long COVID, because we have seen that and we see it also after other infection. It may also be a post-influenza syndrome.
And how can we understand the dimension of this crosstalk, specifically now with metabolic disease and infections? And what is the role of metabolic and endocrine diseases in infection, post-infectious syndromes? And then, most importantly, we have these patients still coming to us. What can we offer our patients? Because in the end, that's what we have to address. So all of us know that this crosstalk with virus has been going on for millions of years, and not only to our disadvantages, you know. Some of our intelligence has been transferred to us by virus, by viral information, and there are many books and quite interesting philosophical aspects about this. And this, of course, relates also if bacteria and virus is driving our evolution. It's using, interestingly, a lot of endocrine pathways. So like the SARS-CoV-2 was using an endocrine receptor as an entry, like AC2. Hormones are key messengers, of course, in driving evolutions. And virus and bacteria, in fact, have learned to target these metabolic endocrine pathways. And this is not only related, again, to negative aspects. If you think about the interaction with pathogen receptors, it's training our immune system, as we all know. It's adapting to stress, hormonal metabolic hemostasis. There's an endocrine virome that we realize, not only microbiome, but it's also interesting that recent data have shown that certain forms of virus can produce insulin-like factors, and that's something that shows how important this metabolic or endocrine virology is. But of course, if this gets out of range, then endocrine cell death, metabolic organ failure, chronic inflammation, dysmetabolism, eventually also in severe forms, then contributing to sepsis. If you have adrenal failure, you go into shock. And these viral-like peptides, insulin-like form, can also produce some effects on hyper or hypoglycemia. But lo and behold, what we have to understand is that this interaction of metabolism and viral infection is also, they depend on each other. It's also a form of symbiosis. Viral infections, of course, contribute, as we will see, to metabolic disease, but also inducing insulin resistance and other factors. It seems that it induces our defense, like, for example, the interferon system. And then, of course, infections have learned to hide in our body, and infection may persist for a long time in human tissue. We've just shown that by looking into fat cells, adipose tissue, and the storage of SARS-CoV-2. But that's known for mycobacteria, for herpes, for many other viruses that have a long-term existence within our body. And why have virus and bacteria chosen to target these particular adipose or metabolic tissues? Of course, this reservoir of our fat tissue is a very nice place if you were a virus or bacteria to go into, because it's immunoprotected. They can't catch you there, so it's a good place to stay in. And why endocrine cells, like beta cells? Because they have a machinery, and this machinery is necessary for the virus. They're producing rapidly insulin proteins. They have a replicative machinery. See this amount of SER or RAR, of rough endoplasmatic reticulum, so they can use these cells for their own propagation. And of course, diabetic patients that we treat every day, they have an enormous interaction, and it's an enormous dimension of diabetes and viral bacterial infections, but also parasites and fungals. And they contribute dramatically, and probably we are still underestimating this, to the cardiovascular neurodegenerative complications of our patients. And also, we know that this group of diabetic patients is a challenge in many ways. It has a reduced compliance, so the most prominent, or the group of patients that is most vulnerable is the one that is less or least interested in getting their vaccinations, and they also had, during the pandemic, an enhanced rate of breakthrough infections. Why is this? Probably because metabolic disease is a mild form of immune deficiency, as we know. So we have started a large consortium. I'm very thankful to the German Research Foundation and an international research training grant with the ETH and with the University of Zurich, training young people, or closely PhDs, but also clinicians, in a broad way on these mechanisms of clinical relevance of bidirectional relationship with viral infections and metabolic disease. And what have we learned? We have learned from the lessons from the pandemic, especially in the beginning. It was striking when the first data, you remember, came out from Italy, northern Italy, that a large part of those patients, the severely affected, those patients that initially died, were patients with some forms of metabolic syndrome, diabetes, pre-diabetes, or they had hypertension, obesity. The first patients I remember that came in and that died rapidly was younger patients below the age of 50. Was a young lady that was really morbidly obese, and that was going on in a very rapid way, so like a cytokine shock. And that striking overlap, if you look into the maps, as you know, of those patients that died from COVID-19 and diabetes, and the distribution of obesity and diabetes is quite overlapping. And that, of course, may have also some relevance for the next pandemic or for the interaction on the basis of this evolutionary drive. But it's not limited to SARS-CoV-2, long COVID or COVID. It's also related to other diseases. We have increased risk in influenza and many bacterial infections, also in malaria or parasitic infections. So the pandemic has caused a significant increase, we have realized that over those years for various reasons, in metabolic disease, and that seems to be ongoing. It's a long-term effect that we have realized that's happening here. And we also learned that well-controlled blood glucose levels was kind of a prevention, was a protective for the outcome of these patients in the acute phase, but also in the chronic phase. And it is interesting to see that apparently this is also now translated to therapy. There are indeed more and more drugs, antiviral drugs, drugs that we use to treat, to target infections, that seem to have an effect, a good effect on metabolism. Some early data showing that even the progression from islet destruction and then type 1 diabetes, type 1 can be prevented by certain forms of antiviral drugs. On the other hand, even more importantly, many of our metabolic drugs that we use to treat high cholesterol or that we use to treat high blood sugar seem to be positive for preventing or keeping infections low, but also for preventing post-COVID. That may be related in statins to lowering lipids. We don't know why metformin was such an important factor in preventing or reducing long COVID occurrence. Viral infiltration of pancreatic islets has been shown, so there is something even in not highly severe diseases of COVID-19 and with symptoms, it was but milder infections, an infection of pancreatic islets, and this was apparently related to some increase over the years epidemiologically of diabetes type 1 incidence also in children. Yeah, and this is not only again related to the islets, to the insulin-producing cells, but also other endocrine metabolically relevant organs, like, for example, we looked into adrenals, adrenal regulation, and it was interesting to see that although the patients, some of them entered into a complete adrenal failure, mostly it was some milder form of infections that could be seen on these pathological slides. And it was also, if you do this in vitro, in cell lines, in primary cells, it's interesting that if you are under stress, if I stress you or you are stressed for external or internal stimuli, and the HPA axis is activated, you see that there is, in fact, an increased uptake, a susceptibility, vulnerability of viral, of SARS-CoV-2 uptake into these adrenal cells, which then leads to dysfunction of cortisol, of HPA axis, may then again contribute to metabolic and endocrine disease. And it's also interesting, we were looking into this, and I had quite a number of patients, that adrenal insufficiency, adrenal fatigue, some people talk about adrenal chronic fatigue, post-COVID syndromes, they're very overlapping. Not the same, definitely not the same, but if the patient, the way the patients are presenting is strikingly overlapping. And if we had about 2,000 COVID patients, about 200 on intensive care, many of those severely treated had glucocorticoids for much longer time than only these 10 days that was recommended in recovery. So I had many patients that just had been abruptly stopped on glucocorticoids. If you are abruptly stopped on glucocorticoids, you are also chronically fatigued. So something always to be ruled out. But these post-COVID symptoms, of course, are not identical with just adrenal insufficiency. They have many other aspects, and we've heard, I think it was very nicely summarized by Professor von Messling today. It is a heterogeneous group. I mean, we have to admit that this group is very heterogeneous, and if you see these patients, you realize that, and this makes it so difficult to find clinical trials that will have, well, in the end, evidence-based significant outcomes. What is interesting that many meta-analyses indeed showed that not only for COVID, for the acute infections, but also for the post-infectious syndromes, clearly if you have diabetes, metabolic disease, the risk was increased sometimes in some of these studies 4 or 5 times. And that was also related to obesity, to lipid disorders, so it seems maybe some of these viruses, probably some of these viruses need lipids for their metabolism, for their action, for their interaction with the receptors, for their mere survival. So reducing lipids could be a strategy. And this is something we are quite interested in looking into. And of course, metformin has been, and that has been published in a number of journals recently in the Lancet Infectious Diseases. If patients were or have been on metformin, that was a reduction of the incidence of long COVID by 40%. Why metformin would be this Wundermittel gegen long COVID? The mechanisms are unclear, but it's a medication, of course, that has many aspects in addition to lowering glucose load, dysglycemia. It also has effects that relate to oxidative stress and anti-inflammation. So we have the largest center in my clinic for lipid apheresis, probably worldwide. We treat 200 patients on lipid apheresis every week, 10,000 apheresis treatments per year. Those are patients 30 years, sometimes 20 years, 15 years on chronic lipid apheresis treatments every week, just because they have familial hypercholesterolemia. They have forms of not only homozygous, but very high lipoprotein little a levels. They would be dead, or there's patients that are 30, 35, sometimes 45, had their first stroke, had a heart attack, and they would probably have been not able to survive without being on these machines for a long time. And so it came clearly that, and I'm just finishing, that the question came up when we were overwhelmed by patients that had long COVID, if this apheresis has some advantage. We see that lipids are dramatically reduced. We also see that, of course, the standard, that neurotransmitters could be reduced, inflammatory cytokines, and rheology could be improved. You know that long COVID and therapeutic apheresis, there have been a couple of studies, mostly cohort studies, smaller studies, with some prominent patients, as you know. And then Professor Scheibenbogen, others have shown some improvement in smaller studies, like what we have seen. Recently, there's one controlled trial that has no effect. We can discuss, I was reviewing that, why we believe that this doesn't show much. But it shows, again, a heterogeneous group. How would you get a significant result from that. We are waiting for 3 further randomized trials on these apheresis studies. I think we do need better criteria, selection of the patients, updated biomarkers, optimal apheresis filters, targeting what we've heard also this morning, thrombo-inflammation, targeting, in fact, also maybe some of those factors related to netosis that we see play a major role, to microclots. And just to finish up, there are filters now in these apheresis that have been developed that can remove these thrombo-inflammatory factors, netosis. This is a patient I have been discussing also with Werner Seeger that had probably long COVID and some form of pulmonary fibrosis with a very bad oxygen consumption rate, and with treatment of apheresis dramatically improving. We don't know the mechanisms. It could be reduced of these microblots significantly. And we have one of those patients who was, in fact, with long COVID, neuroinflammation, almost paralyzed, and after some treatments could then at least get some of his life back and walk around in my office. So we need more research, definitely. We need a panel. As Dr. Stark said, we're probably a panel of markers to decide who will benefit from these treatments. And the take-home message is understanding the evolutionary context and looking in the follow-up, in a long-term follow-up of metabolic and endocrine factors, and also always rule out, if it's not an adrenal insufficiency, and protocols for randomized clinical trials. Thank you to the funding bodies, and I think we have this brain fog in science, but if we walk up a little bit higher in the mountains, we can get a clearer picture, but we need to work together. Thank you.
Thank you, Professor Bornstein, for these important insights, for showing us so many results and evidence. We were asked to keep an eye on the time, so I can only allow one question to your presentation. I would like to ask you, are there any questions in the audience? Or is there any question in the chat? Okay, we noticed one comment in the chat and that we have audio problems, so maybe you could check on this. No problems anymore, okay. And one question?
Yeah, wonderful talk. I was wondering if you had a diabetes person in front of you, so what would you recommend the most? It's more lifestyle changes or metformin or statins or whatever. So just are they aware of that also by changing maybe their microbiome, by changing diet, doing more sports, they could maybe improve on their prognosis?
Are you talking about, in general, patients that have already long COVID, that are...
No, the ones that are diabetic people.
Yeah. No, absolutely. Throughout the pandemic and through all infections, definitely it seems that metformin, lowering lipids, and definitely not getting off antihypertensive drugs, and physical activity is positive for prevention of that.
Again, thank you very much. Our final speaker is Klaus Knoch von Dresden, addressing the role of SARS-CoV-2 NSP1 from a molecular perspective on metabolic pathology, I guess.
Hello everyone, and thank you to the organizer that we can present some data about SARS-CoV and type 1 diabetes. We heard a lot from Professor Bornstein about infection, post-COVID syndrome and diabetes in common. Here we want to focus a little bit more on type 1, and I want you present some data from the lab. So it will not be some patients' data. You will see more, or let's dive into the cell and look what the SARS-CoV is doing into the cell. Actually, I can waste this slide because you saw it already from Professor Bornstein. Relatively early after the start of the pandemic, it was clear that the SARS-CoV can also infect beta cells, although we have to say the beta cell is not really a cell which expresses the ACE2 very high. It's low, but still there are a virus in the beta cell, and also there is a relationship between autoantibodies against SARS-CoV and the development of autoimmune antibodies against the pancreatic beta cell. Interestingly, I want to introduce also this study from our colleagues in Munich, where you clearly can see they looked for over 1,000 babies, and they clearly show that the risk to develop autoantibodies against the beta cell is 5-fold more in the babies, babies up to 1.5 years. So, and now the question is, how can the SARS-CoV, the virus, actually change the beta cell that it leads then to a mistake in the immune response? That's why, you know, this is a scheme of the virus. The SARS-CoV virus is actually a very, very complex virus with a lot of proteins. And at first we checked the different proteins, how they affect insulin biosynthesis and beta cell function. And as you can see here, only this NSP1, this non-structural protein 1, actually reduces insulin, and also all other granule proteins. Are here a pointer? Yes. Here?
This one. There.
Okay. Yeah. Okay. We see here the other tested non-structural proteins didn't show any effect. And you see we lose insulin dramatically. Also the granule proteins which form the insulin-containing granule. And you see also here the beta cell is not any longer able to answer to glucose stimulation, and the secretion is also reduced. And I make it short. Then we ask on which stage of the biosynthesis of the secretory granule proteins is this inhibition. And as you can see here in the control cells, you see actually the biosynthesis of the insulin starts in the ER, and after labeling, after half an hour, you have the insulin trafficking to the Golgi, and after 90 minutes, you see the insulin in the granules. I hope you see these dots. This you see also with the NSP1 as our control, but if you overexpress this NSP1, you don't see any longer any labeling of insulin, meaning the block of the insulin biosynthesis must be before the endoplasmatic reticulum, must be directly at the ribosomes. And this is clear if you look deeper into the function of this NSP1. The main function of this NSP1 is the blocking of the ribosomes. No host mRNA can go any longer to the translation pathway. And this actually is the reason why also insulin mRNA translation is blocked and the other ones. But surprisingly, what we found, the biosynthesis of the HLA or the MHC-class I molecules, which present the peptides on the surface, is not blocked. As you can see, you stimulate with interferon gamma the biosynthesis of this MHC-class I molecules, the beta-2 microglobulin and the H2. This is a HLA molecule of the mouse. And you see NSP1 is not able to block it. And this is really surprisingly because NSP1 is known to block the total translation of a host cell. You see also the distribution of the MHC-class I molecule is not changed. You see nicely a surface staining. So now we have to go a little bit deeper into the theory. Usually if translation is blocked, usually also the viral translation should be blocked. But this is not the case because the virus has on the mRNA, of its own mRNA, this little stem loop, and this stem loop is recognized by the NST1, then it opens the ribosome and it can be translated. And this is actually, to make the story short, also the case for our MHC-class I molecules. We did a reporter gene assay. If you want to know more, we can discuss this in during the coffee break. You see the MST1 overexpression is not able to reduce the translation of our reporter gene, but if you look to the insulin and also to the ICF12, this is a islet autoantigen 2, is strongly reduced. Meaning our MHC class I molecules should also form these stem loops. And if you block this stem loop formation with antisense oligos, you can also reduce again the translation. Meaning, parallel, we also see got a very strange effect. The NST1, usually if you go through the pathway, secretion pathway from the ER to the Golgi, to the granules, you have a reduction of pH. And this is important also for the MHC class I loading. You know the MHC class I molecules are loaded in the ER, then the pH is reduced. In the Golgi, you see it here in blue, and then the peptides can be changed, replaced, and only the strong binder stay on the MHC class I molecules and can go to the surface and then be presented. And this is not any longer the case if we have this NSP1 overexpression. Then we checked the immunopeptidome of our cells, and as you can see here in the result in blue, this is an isolated immunopeptidome of our control cells. Nicely, we have the peptides against insulin, ICF12 against our granular markers, and these are actually lost in the group of the NSP1. Meaning, we lose actually the identity of our cell. If the immune system now is coming to the infected cell, we will not any longer detect these peptides. And on the other hand, you see here this chromogranin A, this protein, we found also here, but here we find other peptides. Meaning it's not only that we lose peptides in the infected cells, we have also new or other peptides on the surface. And this, we think, is actually the way how the immune system can make mistake, because it's not any longer recognizing the beta cell as a beta cell. Here you see again the MHC class I in the scheme with this hairpin, this stem loop. It's translated, goes to the ER, to the Golgi, to the surface, is loaded with peptides, but these peptides are different and actually are less peptides. And not any longer any peptide for insulin, ICF12 and our secretary granulomarkers. And with this I want to thank you, our group, and Maria and Martin and Matthias in Munich for the help. Thank you.
Thank you very much for this informative presentation, showing us these interesting results. Are there any questions from the audience? Yeah.
Hi. Wonderful talk. So I guess I had a couple of questions. You saw this really interesting change. You saw this interesting change in the capacity for insulin to be, I guess, made, and MHC, however, 1 is still being manufactured. Do you also see a change in things like PD1, PDL1, so that like a CD8 T cell might have an increased likelihood to target these beta cells?
It's hard to understand you.
Yeah, so you see the change in a decrease in insulin 1, or in insulin being made. And MHC1, however, can still be generated. Do you see changes in PD-1 or PD-L1 that might allow CD8 T cells to be more likely to target these beta cells?
We haven't checked this yet.
Hi. Is there any precedence for this hijacking of the Golgi apparatus? So has this been shown to occur in other infectious diseases or maybe a precursor of COVID-19 such as MERS?
Actually, I'm coming from, as a type 1 researcher, from the enteroviruses. Enteroviruses play are much more important in type 1 diabetes and the triggering of the autoimmunity. And also there, we see a change in the pH. It's different to the SARS-CoV, but yeah, we see it. Interestingly, you don't see so much Golgi stress if you measure. The Golgi looks somehow normal, I have to say.
And do you know if this...
Also, the pH is different.
Yeah.
And what we now have to check, or what a student is checking, if the change in the pH changes the glycosylation of the receptor for the SARS-CoV, because this, in theory, it could be a mechanism how the SARS-CoV sees other virus are swimming around. I'm already in the cell, because it's known from the glycosylation of ACE2 that wrong glycosylated ACE2 has reduced binding to the virus. So this could be or I don't know, is this answering your question?
Yeah. Thank you so much.
Yeah, good.
I encourage more questions in the coffee break. I would like to close this session. We would like to thank all speakers for their excellent contributions, and thanks to you, to the audience, for your engaging questions. We will have this coffee break now and then continue at 11:15. Please enjoy the rest of the symposium at this very beautiful place.
From the DZNE, the German Center for Neurodegenerative Diseases, where we put together a panel of our projects. I'm leading this session together with Marc Beyer. My name is Anna Aschenbrenner. We are both group leaders at the Systems Medicine Department at the DZNE in Bonn. And together with our colleague Omid Shivani, who's an MD and clinician scientist in our department, training neurologist, we will showcase some of our projects here. Omid will start with introducing our NeuroCoV study. And please.
My name is Omid Shivani. I'm a clinician scientist from the University Clinic of Bonn, also working at the DZNE. I'm very happy to present today some preliminary data on an observational study that we are currently conducting in the context of our international NeuroCoV project. So NeuroCoV is an international project that is conducted across several countries in Europe plus Israel. And there are many scientists involved, especially from our center, the DZNE, that is currently doing the lead by Professor Schulze. And I'm talking here on behalf of the clinicians and neuropsychologists that are currently conducting the prospective and controlled observational study on patients with neurological kind of post-COVID at the Department of Vascular Neurology in Bonn and at the Department of Neurology and Experimental Neurology at the Charité. What are our inclusion and exclusion criteria? So we are currently including patients from 18 years with long-lasting symptoms after the infection, including subjective cognitive decline, and all of them have to present with an initial confirmation of the infection itself. For controls, it's necessary that they have no long-lasting symptoms after the infection. We have a few exclusion criteria. They shouldn't have a COVID-19 disease within the last 4 weeks, shouldn't be pregnant or breastfeeding. They should be sufficient in German because the neuropsychological testing that we are doing is in German. No one should participate in any other clinical drug studies. And for patients, this is very important for us, they shouldn't have any differential diagnosis that is currently explaining the symptoms. Our study runs for 12 months for each participant with 3 visits. The first visit at baseline, so that's the visit where we include our patients into our studies and also the healthy controls. We basically record data on the course of the infection. We record demographic and other clinical data of our patients, such as medication and past medical history. We do a neurological examination. We do a very comprehensive test battery of neuropsychological testings. This usually lasts 2 to 3 hours. And we provide our patients with self-report questionnaires asking for instance, general health aspects, symptoms of depression, and many other important symptoms in this cohort. We are also collecting blood samples, and if consent is given, we also do a spinal tap test. After 3 months, we see our participants again, collect again symptoms, medication, and blood samples. And after 12 months, we do the same, plus again a neuropsychological testing, and we provide them again with the self-report questionnaires. So this is preliminary data that I'm showing now. We have by now included 200 participants at Bonn in Berlin. And what you see is that in average, our patients are around 45 years old. And this is very much in keeping with the current literature on patients with long-lasting symptoms, neurological long-lasting symptoms after COVID. What you see is that the majority of our patients is female, and interestingly, there is a significant difference of premorbid conditions between both groups. So as you see, 36% or 37% of our patients had psychiatric conditions in the past, and chronic pulmonary diseases at the day of inclusion. I'm going to show you now some symptoms that they have had during the infection and that they had at the day of admission to our hospital. During infection, patients report of having more symptoms, but this could be biased because they are still affected by those symptoms, and that's why they may memorize those symptoms better than controls do. Looking at the current symptoms, you see that in average our patients are reporting of having 7 symptoms, and they are mainly pain, such as headache, muscle ache, joint pain. They are also reporting of sensory disturbances. Another word for it is paresthesia. It's a tingling feeling on the skin. And they also have, in more than 90% of cases, fatigue, and this is not surprising, cognitive deficits. This is one of the inclusion criteria, and what they apparently demonstrate the most often is subjective concentration deficits, memory deficits, and speech difficulties. Now let's have a look on the neuropsychological test results. 1/3 of our patients, they demonstrate an impairment of cognition. And how is this defined in our study? We have different neuropsychological tests, and as soon as there are 2 tests with a 1.5 standard deviation below the mean of the corresponding same cognitive domain, we define this domain to be impaired. The majority of our patients is having a single domain impairment, and this especially affects attention. But there are also deficits in executive function, memory, and language. Comparing now those results with our controls, we see that there are 3 tests positive yet. One test is the test for alertness, in other words, reaction time. The other one is sustained attention, in other words, concentration. And both tests correspond to the cognitive domain of attention. And then the third one is the delayed verbal recall, in other words, memory. And this is also in keeping with the current literature on those patients because they apparently are suffering a lot in those two domains. So attention and memory difficulties are a highly prevalent symptom in post-COVID patients. We have two tests to assess attention in patients, at least in our study. One is the TMT, it's a paper-pencil test, it's a tray-making test, and the other one is the test battery for attention assessment, and that is computerized. The first one is a very simple one, so basically you ask your patient to link letters or numbers in chronological order and you stop the time. The second one is a bit more complex. Your patient, they see certain patterns or hear a certain sound and then they have to push the mouse pad. And you basically measure the number of omissions or the reaction time. And we wanted to know which test is more appropriate for our patients and checked how they classify our participants. And even though there's no significant difference, we see a tendency for the TAP test, and we think it's not significant yet due to the sample size of our group. We continue to analyze the association of fatigue, which is a very prominent symptom in patients, with the TAP test and depression. The TAP subtest of sustained attention, so you must know that the TAP test is divided into different subtests, and one of them is the sustained attention test. The sustained attention test was very interesting for us because we did not only see that patients are presenting with a higher rate of omissions and reaction time, but also the increase of omissions and reaction time over a period of 15 minutes was higher in those patients than in controls. And this was indicating that fatigue plays an important role here. Looking at correlation analysis, we see that the fatigue severity scale, we heard today results on the Shelder fatigue scale. There's also the fatigue severity scale, and it basically assesses the severity of pathological tiredness in patients. This was moderately and significantly correlated to the subtest of sustained attention. And in conclusion, we would say that the TAP test is more appropriate for patients due to different advantages. First of all, it's capturing fatigue. It might have a higher discriminatory power. It's inclusive for analphabetic individuals. And the best advantage is here, especially for our very severely affected patients that are bedridden. It can be done from home. Another very interesting finding from this correlation analysis was that the BDI-2, it's a self-report questionnaire that is assessing the burden of depressive symptoms, was highly and significantly correlated to the fatigue severity scale. Looking into the BDI-2, you see that more than 50% of our patients are suffering from at least mild symptoms of depression. 10% are even severely affected by symptoms of depression, including suicide thoughts. We then went to our colleagues from the Department of Psychiatry and asked to have a look at results of neuropsychological testings in patients with major depression. And this was basically the distribution of cognitive deficits in patients with major depression. So as you can see, they are mainly affected in attention, memory, and executive function. They unfortunately didn't measure the other cognitive domains. And then we wanted to compare the distribution of pathological findings in our patients in regards to those domains with patients with depression. So in other words, this is the distribution of depressed patients. And now I'm going to show you the distribution in post-COVID patients. And what you see, it's almost identical. This is in general leading us to a very important question. And as you know, I'm affiliated to the DZNE, and the DZNE is focused on neurodegenerative diseases. What we know is that depression precedes neurodegenerative diseases decades before the diagnosis is given. This is well known in Parkinson's patients, and this is also known in patients with Alzheimer's disease. Those are the 14 modifiable risk factors for Alzheimer's disease, and one of them is depression, and it usually occurs during the midlife. And there's also on the other side this debate whether psychiatric diseases or psychosomatic diseases may be caused by antigen exposure, of course, beside of many other kind of etiologies. And I want to leave you basically with two open questions. One is, how is antigen exposure, or in other words, infections, linked to mental disorders, cognitive decline, which is, by the way, well known in patients with depression. We call it pseudodementia. And decades later, neurodegenerative diseases. And could it be that patients with very similar phenotypes, such as post-Lyme disease, ME/CSF, post-COVID, and many others, depression, could it be that some of them are also suffering from a post-viral disease? So, in summary, the majority of our patients is female, around 45 years old and well educated. They primarily suffer from pain, sleep and sensory disturbances, fatigue, depression and cognitive decline, mainly inattention and memory. The TAP test serves as an efficient diagnostic tool that could be even done from home. The open questions that we want to basically answer is, could it be a potential risk factor for neurodegenerative diseases? And the complexity of symptoms, and this is really important because they are not only suffering from cognitive decline but also from psychiatric symptoms, pain, and many other things, needs an interdisciplinary and multimodal therapeutic approach. So thank you very much for your attention, and I'm happy to take your questions.
Yeah, Omid, thanks so much. Are there questions? So I have one question from online, which is basically there's a question asking about what test you're using to evaluate depression, and if you're using the PHQ-9 test, and if so, that could have a bias. So that could you comment on that?
So we are currently using the BDI-2. Yeah.
So
it's not the other one. Yeah.
Okay.
Just out of curiosity, many of in the study you showed that it's females and above 45, and of course this could be postmenopausal women as well.
Yeah.
Do you have a comparison cohort with postmenopausal women with similar symptoms maybe, and then see whether they share same signatures, or is this even overlapping?
That's a very important question. Thank you very much, and it was just recently also raised up at the DZHK. We have not particularly checked for signatures now as a comparison in women with postmenopausal symptoms. But of course, we have to keep this in mind, and we are currently discussing strategies. And possibly some of the symptoms could be explained by postmenopausal different changes in the body of women. However, as we see, there are also younger women affected, plus men. This must be something that is not primarily driven by postmenopausal changes, but of course we have to take this into consideration, and it's very important. Yeah.
Could be a subgroup.
Could be. Yes, you're right. Yeah.
Hi, thank you very much. I was wondering how you stratify this huge group of patients you're looking at. So do you actually look at post-exertional malaise or at ME/CFS patients? And I think if I didn't understand it wrong, you said that the cognitive tests tend to take up to 4 hours?
Yes, 2 to 3 hours, and we know. Yeah.
So are you aware that you might be missing many patients that are not able to perform those
Yes,
tests?
definitely. That's one of the limitations of our observational study. We are currently excluding those who are not able to get to an outpatient clinic for those kind of very exhausting testings. You're absolutely right. We have some strategies to help here. So what we offer is we have several breaks, or to do it within several days. But of course, this is a neglected subgroup of patients that we are not currently including into our study. Yes.
I think it would be very important to also clearly mention this when presenting your results and making it clear.
Yeah.
Thank you.
By the way, this is why we are emphasizing the necessity of tests that can also be done remotely. So something like the TAP test could be done remotely from home and wouldn't need any more to get to an outpatient clinic.
Okay. Maybe Ovid, you can try to see what you can make of this question.
Which one?
The last one.
What is depression if not neuroinflammation in a subset, especially in long COVID? Why do we prescribe CBT instead of trying to prevent development of, e.g., cognitive decline after antigen exposure? I think you must know this is a huge question. So, I mean, in general, psychiatric, psychosomatic diseases need to be addressed by different kind of strategies, such as psychotherapy, and in some cases also medication. And what we are currently asking is the question if there could be a link to an antigen exposure, and what would be the appropriate therapy here? Is it psychotherapy? Is it a drug? And I think the most important, or one of the very important aspects that we are going to see in the next future is the biomarker profile of our patients. And this might help us also to stratify who could benefit the most from different strategy for therapy.
All right, for the sake of time, we will continue now with the next talk. Thank you, Omid, once again. Marc Beyer will now show a few further insights into our NeuroCoV study, which will follow on the samples, as well as mention some of our other projects in the DZNE.
Yeah, Anna, thanks so much for the kind introduction, and thanks a lot for having the opportunity today here to present, on the one hand, some of the molecular aspects that we try to address in the study Omid has just introduced, and at the same time also highlight what basically DZNE has been trying to do over the last few years concerning long COVID research. And we've been involved in multiple studies now over the last few years, which also Anna, to some degree, afterwards will show. So we've been working in a large network across different study centers in Germany to collect blood transcriptomes and to identify blood-based biomarker for post-COVID. We've been also looking both in a DFG consortium as well as in a BMBF-funded consortium on the single-cell level, on deviations in the cellular composition and the molecular phenotypes within in blood cell types in post-COVID patients. We are also part of the biomarker platform of the National Clinical Study Group that has been introduced, that's led by Carmen Scheibenbogen. And lastly, we are leading this European consortium, this NeuroCoV consortium, where Omid has introduced, in principle, the German arm of the clinical study we're running there. And for the National Clinical Study Group that's led by Carmen Scheibenbogen, there are, in principle, 5 clinical trials that are using currently available therapeutic options, and in a double-blinded fashion, or at least for 4 of them, we're assessing, in principle, whether these treatments would benefit patients. And the primary readout there, of course, is physical activity, so whether that improves, but we are complementing this on the other side with biomarkers. And these studies, on the one hand, the first 2 here at the top are basically using immunoabsorption. I mean, we heard about that already today for ME/CFS patients. And the third one is using prednisolone as an immune modulator to also establish whether treatment with prednisolone would also benefit individual patients with cognitive deficits and post-COVID-19 syndrome. And in the very long study, vericiguat is given to individual patients, and the last one is in principle using hyperbaric oxygen treatment. And on the clinical side, I'm currently not yet able to comment on these, as the studies are just being completed or in the process of being completed during this year. So this has taken quite some time, that really these studies are now at their final stage. And in the biomarker platform, which is headed by Birgit Sawicki from Berlin, we will be looking now in peripheral blood monocytes that are going to, or are being collected as we speak, before treatment and then after basically completion of the treatment, and we'll be looking at cell composition changes using flow cytometry and CyTOF. That's being done also by Birgit. That's basically mainly being done by Birgit's group, and we will be using single-cell RNA-seq in combination with antibody stainings to identify gene signatures that are potentially indicative, on the one hand, of individuals that benefit from the therapies, or also that we could identify patient subcohorts that would be suitable for specific treatment arms in this study, or also develop biomarkers which will predict treatment responses. And this work, I hope we will finish until end of the year, early next year, so that we then can also report on the outcome from the findings of this study. But for the moment being, this is just a look into the future that we hope to see here, really for these therapeutic, potentially therapeutic options that we want to see here also on the molecular level. What changes, and really is this potentially indicative of patient subgroups and treatment options. And for the NeuroCOV consortium or the study we're running there that Omid introduced, this is in principle a European study which is led by us, the DZNE, which is composed of 10 international sites. And the idea here is that we want to investigate the neurological and neuropsychological complications due to COVID-19, and want to understand on the molecular level what is actually driving this. And the first main aim of this is to characterize the cognitive and neurodegenerative complications resulting from post-COVID-19. So that was what basically Omid has introduced, and the German study in Bonn and Berlin is complemented on the other side with a study in Italy where we're recruiting the same number of patients and are doing exactly the same or almost the same clinical as well as molecular tests. We then want to also define the cellular and molecular mechanisms underlying neuro-COVID disease trajectories. So from our specialty, we will be doing this on the single-cell omics level, looking at PBMCs, so blood-based assessments of cellular composition and molecular changes. And this is complemented on the other side by the colleagues from Italy, which are generating iPSC cells from these individuals, are then generating brain organoids and will be stimulating these brain organoids and reading out then also changes on the neuronal and potentially also glial response towards COVID. The aims are complemented then by the idea to develop AI-based predictive models to assess the risk of developing neuro-COVID, and as the last step, to identify also drug candidates and laying the foundation for neuro-COVID personalized therapies. Now, the work is in principle is subgrouped into different work packages. In the work package I'm going to talk about today is the work that we're performing with the samples from the two clinical studies, the one in Germany and the one in Italy, where we're performing genotyping of them, collection of blood, and then performing single-cell RNA-seq at the time of recruitment, but also at the time point of 12 months after recruitment to really see what also changes in the individual trajectories of the individuals. And at the same time, colleagues in Milano are reprogramming some of the PBMCs towards iPSCs and are generating organoids and stimulating them. So that we at the end hope to really be able to stratify patients and be able also to understand on a molecular level what effects COVID infection has on the brain and how the cognitive symptoms that Omid just introduced you to are caused, and to potentially then also identify potential therapeutic options. So for the data I'm going to present to you today, so this is still running these trials, so we currently have not yet assessed the full group of individuals, but I'm just going to show to you the first 92 donors that we have now analyzed, and these have been recruited both in Germany and Italy, and as you can see here from the overview of the metadata of the patients, so this is not yet well distributed, so we do have some sites which have more or less equally recruited healthy controls and patients, some others have not yet, but over the time that we've now recruited, so we're now at approximately 400 of patients that have been recruited, this is certainly more balanced as this first batch of samples that we processed. The processing that we're doing in the lab, so this is done by 3 very talented PhD students that you've also seen already in the slides from Omid. They're in principle processing these samples in small subsets of samples, are then running single-cell omics looking both at transcriptome, antibody, surface antibodies of cells, the T-cell receptor and the B-cell receptors. We're also performing flow cytometry and are complementing this with plasma proteomics using 2 complementary technologies, so the Alamar technology as well as Luminex. And what you already can see from this very initial data analysis from this first batch of samples, that we can see trends in the frequencies of cell types in neuro-COVID patients. So we see clearly, or at least trends towards lower numbers of frequencies of monocytes, more CD4 T cells, and also less NK cells, clearly showing that over time and over the number of patients we're recruiting, we will be able to validate these findings, and then could also, based on this already, give some thoughts on what changes really in the individuals having now neuro-COVID. For the single cell sampling and processing, so we were quite happy to see that we could recover now from the first 92 samples approximately 500,000 cells. We're also super happy to see that even that we're recruiting from 4 different sites, we in principle can nicely integrate the data so that we have in the end, and can expect to have at the end, a data set of approximately 600 individuals really that we can analyze together, and can annotate the cell types nicely using the antibodies so that we can see all the major blood immune cell types, and can start to now dig into this data and start to analyze and understand if there are really changes in not only cell type composition, but really also in the molecular profile of these cells. And what you can already see here from this very first interim analysis, that we see changes in gene expression within the different immune cell subtypes, so that we see changes in monocytes and T cells. And when we then further look into this data, I'm just going to flip through this a little bit. So you see when we look at the one side which has recruited in principle homogeneously, so that's Bonn at the moment, then you can see here that you see changes in gene expression between healthy donors and neuro-COVID patients. And when we now try to functionally link this, we see that in the monocytes you see changes in gene expression terms associated with the response to virus, type 2 interferon cytokine production. So clearly immune-associated terms that are changed in patients with post-COVID syndrome with neurological symptoms. And very similarly also for the T-cell compartment, CD4 T-cell compartment that is also changed in frequencies, we also see very similar changes that you see here also, that in principle within the downregulated genes you see terms that are associated with T-cell activation and proliferation. And you can also see that if you look at NK cells, so when you look there, again, focusing on now one of the recruitment sites, we can see functionally terms associated with NK cell functionality, so cytotoxicity, but also then translation regulation, so that we can say very clearly also here, we expect from this data to see at the end a dysfunctional or proportionally altered NK cell phenotype similar to T cells and monocytes. And we're complementing this, and this is just, we didn't yet go into this, but we're complementing this, of course, with the analysis of the T-cell receptor and the B-cell receptors to then be at the able to say, and that's also an aspect we discussed already this morning, that if there is an enrichment of specific T-cell or B-cell receptor subtypes, receptor clones, we should be able to see this. Particularly important, I would say, would be here to look at also the second time point to really see what are the changes in the clonotypes. And I'm already seeing that I have to hurry up, so it's just the second to last slide. For the NULISA also, or for the biomarker plasma level measurements, we started to look into this. This is for the first 96 donors already done, but here again, this data need more, in principle, more analysis and more individuals to really come to a conclusion of what is changed, but we expect nice data from this. So in summary, the Institute is focused particularly on understanding the neurological and cognitive deficits in post-COVID-19 syndrome. We try to identify single-cell signatures of therapy response and patient stratifications in the National Clinical Study Group, and define cellular or molecular mechanisms underlying neuro-COVID disease trajectories in the NeuroCov consortium. And we see already changes in frequencies and gene expression modules. And with that, I'm at the end. I thank, of course, all the people who are doing the work, the colleagues from the Charité and the NKSG, and of course the consortium, the NeuroCov consortium, and you for your attention. I'm happy to take questions.
Thank you, Marc. Are there questions from the audience in the room?
Hi, Klaus Debertin from DZHK. Actually, concerning the single-cell omics analysis in NK cells, did you compare this, or do you have a comparison to other viral infections? And in addition to the age, because NK, also some other myeloid-derived suppressor cells, etc., they changed with age.
So for age, we try to, as best as we can, try to harmonize. We still have, in that first data set, some bias towards younger individuals for the controls. For that question of can we link it or can we compare it to other viral diseases, or that's as an aspect where Anna Aschenbrenner will talk about later. So we do have data for this. So we're currently, and will at the end also try to bring these data sets together. I think that should be possible. We're currently also, and that's another aspect, we have focused initially on PCS with neurological symptoms. We're currently recruiting additional patients, PCS patients without neurological symptoms, to also be able to address these questions. Are there specific changes in the cell compartments for neuro-COVID, or is this just a general observation we have, and that the distinction between COVID, post-COVID and neuro-COVID, we would do only on the neurological assessments?
one short question, then we need to move on.
Yeah, thanks for this nice talk. I was wondering, you also consider CMV infection in these patients so that you have, because it's so influential for the immune system and T-cell responses and so on?
So we have not done, I don't think we look at seropositivity for CMV. I mean, with the T-cell receptors, we're able to see it because we see the relevant CMV clones, so that's something, but I think we should consider it. I agree. Not yet. So now it's my pleasure to hand over to Anna Aschenbrenner from the DZNE, who is co-chairing the session with me, and I'm very much looking forward to your talk. Thanks a lot.
Thanks, Marc. I will finish up this session. By highlighting two more studies where we also looked in the circulating immune cells, as we intend to do and are starting to do for the NeuroCov project. These were actually started even earlier when it was still unclear if you could even, at least for me also coming from studying acute COVID and having a background in immunology and looking at blood transcriptomes, if we could even see something there. As we know, there are so many various symptoms, and the question is the source of the disease actually in the blood or somewhere else in the tissues? But we know that the blood sample and of course stratifying patients or monitoring disease and treatment outcomes could really benefit if we see signals in the blood. So the first study I want to mention was conducted together with Carmen Scheibenbogen from the Charité, as well as Leif Erik Sander and our large team from the DZNE Systems Medicine Department that we have already mentioned. Since we mentioned already also today that the post-COVID patients are very heterogeneous, and considering that we didn't know what signal to expect, we tried to design a cohort that was as similar as possible concerning the patient characteristics. The patients we focused on first here all had only mild to moderate COVID-19, so they were never hospitalized. And developed symptoms later on. We sampled them 5 to 12 months after the acute infection, and are looking here at 40 post-COVID syndrome patients and 20 recovered individuals. From those, we took their blood samples, isolated PBMCs, and performed single-cell transcriptomics. In this data set that we generated here, showing you around 230,000 cells, we identified all the cell types as expected. We have a large lymphocyte population in orange to red, myeloid compartment in green, and B cells in purple. And the first question is, of course, if you overlay this now with cells coming from the post-COVID patients and those from recovered, if we see in this low dimensionality reduction shifts in the transcriptomes as indicated but not well mixing of these dots. And we could see this in the monocyte compartment as well for the NK cells. So when we zoomed into these cell types a bit further, now for the monocytes, we can do something called subclustering, so identifying within a cell type certain transcriptional states or programs, and overlaying this again with the disease groups, so the red dots coming from the post-COVID patients, the blue ones from the healthy controls or recovered controls. You can see these shifts, and if you then look into these different substates, you can also quantify that. So we clearly found substates that are either associated with the post-COVID patients or the recovered patients. Another way how to look at this transcriptome data would be by just taking all the monocytes in general and making a differentially gene expression call, and also here on that level we see signatures that can identify these patients compared to recovered controls. The other cell type that showed these shifts on the global UMAP were the NK cells. Also here we saw these shifts. We called the different substates as we did for the monocytes, and when looking at the distributions we certainly find substates that are associated with either of the groups. So in summary, really showing that we can use the circulating immune system to identify these patients. The second project I want to highlight is actually on ME/CFS in general, because one of the major questions we of course have is this now specific to a SARS-CoV-2 infection and post-COVID syndrome, or are the potential other triggering infections postulated for ME/CFS giving a different phenotype or similar signatures? So in this cohort, which we looked at in the consortium of IMI, a BMBF-funded project, also together with the Charité again, and these analyses have been performed by my PhD student Francesco. We have a cohort of 46 female donors who all have different initial infection events, such as EBV, flu, severe infection, one with MISC, and again, some of our post-COVID patients as well. So the ones with the other infection have been sampled previous to the pandemic. When we look at this data, we have produced here roughly 125,000 cells. Again, we can see our cell types that we expect. And concerning now the question on the infection type, we actually see that there are no global shifts concerning our groups when we call them to the infection trigger, meaning that it does not drive clear, evident endotypes in the immune compartment that we assess in the blood. But when we zoom in into different cell types, and I just want to highlight here also the NK cells, we see actually something similar to the previous project, that also here, when we look at the different substates, our healthy controls here in blue have different amounts of one of these substates that we also saw elevated in the other study. So first, confirming across different studies that we see similar things. And again, not huge differences between the viral infection triggers. What we did then is, since now the viral infection did not stratify our patients, we asked the transcriptome data itself, so we made a differentially expression call between all of our ME/CFS patients compared to the recovered controls in each cell type, and made now a heat map of the union of these differentially expressed genes. And what we saw then is that actually all of our patients here indicated on the left side, and the healthy controls have this gray bar here, or the blue one down here, fall into two subgroups. Stratified by the transcriptome. And this is true for each cell type. So if we do this grouping, of course, individually for each cell type based on their differentially gene expression calls, there's not much fluctuation. So they fall in the same group in each cell type that we look. And if we now, I'll try to start this again. If we now take this grouping that was given to us by the transcriptome, and compare the other clinical metadata, what we saw was that actually these subgroups are kind of separated by severity based on the PEM score and the Bell score, and the one subgroup with the slightly more severe patients had a longer disease duration, and age didn't make a huge difference. So I think these two projects also highlight very nicely that blood transcriptomes can show the immune deviations in long COVID after mild forms of acute COVID. We also see similar effects in ME/CFS patients, especially in the monocyte and NK cell compartment. The potential infection trigger does not seem to drive these transcriptome-based disease endotypes, but we do see substratification of the cohort with differing in average Bell score. So we are really positive also in context of the NKSG that Marc mentioned and the other trials, that we can find a basis also bringing these different studies together that help us to understand how we can stratify patients from the blood and use this then in connection to the clinical trials and see if we can see these endotypes also in the trial cohorts and correlate that to therapy response and outcome. With this, I want to thank you. Of course, this is a huge team effort of our whole department in Bonn and together with our collaborators, mainly in Berlin. And a big thank you to all the funders, especially the BMBF or BMFTR now, and the EU. Thank you for your attention.
Anna, thanks so much. Are there questions from the audience? Yes.
Yeah, thank you very much. Really an interesting approach. I mean, at the end, you may come up with specific profiles for specific patient groups that can be used either to predict outcome or course. Are you already there, or are you planning? What are your plans concerning these profiles that you will get when you do this?
Well, right now, we have started with the different study cohorts and the different projects. First of all, we will try to bring it all together and see how much overlap we have, because we do have post-COVID in several projects, of course, with different inclusion criteria. And I think the nice profiles from the first study I showed, where we really looked at those with a mild acute infection, and then that had, I didn't mention that, they were diagnosed by the Canadian consensus ME/CFS criteria, so a very specific group without having those that were on the ICU and had severe complications. Those are, of course, very different inclusion criteria to the one we have in NeuroCovid now. First of all, trying to bring that together and see how much overlap we have, either coming up with something common or taking the signature then to the data that we will produce from the clinical trials that Marc mentioned and correlate that to therapy outcome. So if there are these endotypes also there, that might show different responses. Because, for instance, in the prednisolone therapy trial, maybe we find those with higher inflammation or not, and those are the ones who respond, and those who don't, that won't benefit.
In the DZHK, one of the main research area is immunity and development of the immune system during aging. And we will also have a program that combines genetically defined immunodeficiency, endotyping common autoimmune disorders. And it might be relevant that one sees in multi-omics approach signaling pathways and deficiencies that are then reflected also in other disease entities not caused by a genetic aberration. So it might be interesting at the end, if you have your cohort together and we have our cohort together, to come up with a combination.
Yeah, very nice.
Maybe just also one comment to what we're doing concerning analysis with the second time point. So we just chatted before that we have currently for that NeuroCovid trial only, I think, for 60 patients for both sides now reached that second time point, and have not done any of the analysis yet. But from a clinical perspective, impression, gut feeling is that there is changes. To what degree? That's something that we have to certainly evaluate there. But that's something, of course, we want to look at.
So, hello everyone. My name, are we ready? Are we already broadcasted? Yes? Okay, good. My name is Martin Walter. I'm one of the 6 speakers of the newly funded DZPG. I'm speaking for the site Jena, Halle, Magdeburg, and together with Claudia Schilling, I will be moderating the next session that addresses contributions from the DZPG. Being one of the 2 new kids on the block, so to speak, in the group of the German health centers, together with the Child Center, we had a little bit of limitations, mainly funding-wise, which meant we had to be a bit more moderate or modest in what we can do. But one big opportunity was that we were funded, or we were selected in 2021, which means the evolution of our center basically happened in parallel to the pandemic and to the definition or the concept of the post-COVID syndrome. And that might have some advantages also that helped us to strengthen certain research foci or research tools that we actually strengthened in their priority in our research agenda. And I think this is what helped us a little bit to already bring in some first evidence results, but also we will report on studies where we engage as a center to also acquire for additional third-party funding, but bring in the potential and the possibility of a German research center. So it's my big pleasure to introduce our first speaker, Dr. Tarek Jabrini from the Munich site, Munich-Augsburg. To be more precisely, Tarek Jabrini is a medical doctor working with Christina Adoyan and he will be presenting one particular focus of post-COVID research which really addresses the care, the translation aspect towards patient service. And it's my big pleasure, I don't see Dr. Gebrini, I see him now. Please give us our first lecture.
Thank you very much.
Sorry, I need to use this microphone.
If it's okay, I would use it. So this should work. Thank you very much for the warm introduction. My name is Dr. Tarek Gebrini. I'm a postdoctoral researcher at Deutsches Zentrum für Psychische Gesundheit in Munich, Augsburg, and I'm a psychiatry resident at the LMU Munich, and I have the pleasure today to present you our data of the interdisciplinary post-COVID study, and with a focus on ability to work. So we jump a bit back to... So I have nothing to disclose. Just briefly where our data comes from, we have an interdisciplinary outpatient clinic which works intersectional. And the key focus, we have consultations. We get our patients from screening of our primary healthcare network. And we, of course, work with different specialized departments, like the cardiology, but of course the psychiatry where I'm based. And we focus mainly on healthcare service research. So very briefly here in an overview, the top 25 symptoms of our patients. And this is basically in line with the previous presentations. We see fatigue as being one of the most prevalent symptoms, as well as memory impairment, and of course on the psychiatric side, anxiety and depression with prevalence between 27 and 30%. Also in line with the previous presentation, we see that the majority or the biggest group of all patients are between 18 and 45 and female, which of course could be related to the comment before. Here you see the top 25 symptoms by stratified by different groups, age and sex groups, and you see the lighter the color is, the more frequent the symptom is. So you see fatigue was the most prevalent symptom above all groups, but especially prevalent in patients with female sex. We also tried to stratify this in a correspondence analysis, and you can see basically the points which are more connected to each other are more likely to occur together. So we also see that fatigue and depressive symptoms are generally occur across the different patient groups. So I think we lost the Zoom connection, but I will just continue. Okay. 1 second, I have to put this aside. Okay. So basically regarding our diagnostic procedures and results, you see an overview here, and you can see that the laboratory results in our clinical everyday practice were around a fifth of the parts abnormal. With the ECG diagnostic, it was definitely less frequent, and we see, especially regarding the neuropsychological testing, that we have quite a lot of abnormal results. We do not see many normal results, but a lot of borderline results, which is also in line with the prevent. Sorry, there's something with the Zoom. Yeah, I think it should work now. Just popped up. Sorry for that. So to jump directly to the key study, the ability to work study, we tried to predict ability to work or inability to work 12 months after baseline. And basically to do that, we included the data of 295 patients, and basically basically, you see here the comparison of the baseline parameters. You see that there was a significant difference between the quality of life between the two groups, between the depression rates, and also regarding the lipid profile and the inflammation profile. And Perfect. Here you see the slide which you should see, and taken together, we managed to predict the outcome of workability 12 months after baseline using a random forest tree model, in which we trained the model with 147 patients for the training data set, and the validation with 73 patients, and we selected 9 clinical parameters, which were the hospitalization during acute infection, the WHO severity of acute infection, so the symptoms at baseline, the prevalence of somatic comorbidities, the prevalence of psychiatric comorbidities, the age, the height, the width, and the Karnofsky index. And just to make sure, a random forest tree model is basically a multiple decision tree. This has nothing to do with a neural network. And so we did see quite encouraging results for our outcome prediction. We saw that the model had predicted the outcome with an accuracy of 0.75 and an area under the curve, which is basically the parameter of evaluating this model, of 0.756, which you see in the blue curve on the right. The most important key predictor was the Karnofsky index, which is basically a parameter for functional impairment. So this is very important to point out. We also tried to assess the perception and of the patients as well as the clinical stuff. So we compared the severity of disease regarding general health, mental health, and physical health. And you see patients rated their disease as more severe and rather attribute the severeness towards physical health, while internists overall rate the severity of disease as being less severe and rather as being psychiatric, while psychiatrists usually would rate them as being rather somatic than the internist colleagues. Similar patterns we see for the severity and the perception of pain. We did also conduct a comparison of neurocognitive impairment with standardized tests like the D2 concentration test, and there we saw, which was in line with the presentation before, that working memory, attention, and concentration was mostly affected, but pathologic cutoffs were only exceeded in a few cases, and severe neurocognitive impairment was associated with depression, fatigue, and reduced quality of life, as well as a higher prevalence of psychiatric illness. So, to sum up, prolonged work inability we were able to predict prolonged work inability by clinical parameters. Subjective functional impairment did play a key role and should specifically be addressed in treatment. And overall, we saw diverse symptoms, often without a clear somatic correlate. And overall, we saw a few pathologic somatic findings, frequent but slight decrease of objective neurocognitive test performances, and a big difference, actually a substantial difference in the perception between severity, perception, and neurocognitive impairment as a subjectivity and objectivity gap. And overall, a high prevalence of comorbid psychiatric diagnosis, which really underlines the importance of dual assessment for somatic and psychiatric treatment. With that, I want to thank the team a lot of the post-COVID ambulance, Dr. Christina Dojan and Johannes Burger, and of course Hans Stube, and thank you very much for your attention, and I'm happy for discussion and questions.
I think we're now offline, which gives us even a bit more time to discuss questions from the audience. Thank you very much for the interesting presentation. Are there already questions that Dr. Jabrini can answer? We still have time up to 3 minutes. I may start then. I was seeing your impressive findings, and I was also reminded by one of the first talks today where participating in a rehabilitation program was actually a negative predictor of outcome. And I was wondering, given that you have these large data, did you have the opportunity to also include this factor in the patients? Because I think your patients come to a post-COVID center and they should come there regularly.
Thank you very much for this important remark. We usually see our patients in an out-clinic setting, so usually our patients would be seen before being actually referred to a secondary hospital. So usually our patients were in line before that, but this would be definitely an important aspect to include in the estimation. But usually our patients have not been in this treatment yet. So, but I think this is really, there's probably a strong correspondence to the everyday impairment which we assess using the Kanofsky index, which we see is a very, very strong predictor for work inability.
Thank you very much. Are there more questions from the audience? This does not seem to be the case, so I think we are in the position to make up some time. Thank you very much for a nice presentation. Then it's my great pleasure and honor to introduce my co-chair, Dr. Claudia Schilling from our site in Mannheim. So it's Mannheim, Heidelberg, Ulm, as we call our DZHK sites by the full name of all participating universities. Dr. Schilling is a psychiatrist and a sleep expert, and you will also focus a little bit on the mechanistic component of our research agenda, and you will be today talking about a project that was also co-funded or actually applied for with a little bit of support from the DZPG. Claudia, we're looking forward to your talk.
Thank you, Martin, for the kind introduction. I'm happy to present to you today our currently just starting joint project, which has been funded in the round by the BMBF call about ME-CFS pathomechanisms. So we are focusing on sleep, contribution of sleep-related biomarkers to the pathophysiology of ME-CFS. So why sleep? First, as we already heard a couple of times, sleep is one of the most prevalent symptoms within post-COVID condition. Here we have two epidemiologic studies. One is the ICOS study, a multi-center European study, and here you see that insomnia is a very prevalent symptom, with half of the subjects having post-COVID presenting insomnia symptoms. And we also see there in this ICOS study that it's not only about insomnia, but also we have different kinds of sleep phenotypes. Here we have excessive daytime sleepiness with more than 30% of prevalence. And in the EPILOG study, of which we already heard this morning, we also see a similar picture regarding insomnia prevalence. We also see about half of the subjects having insomnia symptoms. And in this study, we have been in the position to differentiate between previously already existing insomnia symptoms before the infection and newly occurring symptoms. And as insomnia, of course, is a very prevalent symptom or a condition in the general population, we see that it already has existed in a lot of patients before the infection, but still we see that most of this high prevalence of insomnia morbidity within the post-COVID group has been newly occurring, more newly occurring than previously existing insomnia. Now again, why sleep? Sleep serves a lot of very important functions. It's important for regeneration of the brain, of course. It's very important for cognitive processes and, of course, also for the immunological balance. But here in our study, we focus on a different aspect of sleep. We see sleep as a tool, sort of, to use it as a window to brain function. Why that? I want to focus here on two networks, which in my opinion are interesting, especially with regard to post-COVID or to ME-CFS also. That is a thalamocortical network, of which sleep spindles and oscillatory EEG activity is it's a very prominent EEG pattern in sleep, and that is the substrate of this pattern is a thalamocortical network. And it has a very important role in sleep stabilization and also in memory consolidation. And this network during waking has an important role in sensory stimulus processing. And on the other side, the brainstem offers a couple of phenotypes during sleep, which are also interesting to look at, because we have sleep-related breathing regulation, which is often impaired in post-COVID and ME-CFS. And we have very often autonomic nervous system control dysregulations, which we all know is a very often observable symptom in post-COVID, and we have arousal regulation, for which the brainstem is important. So we see that here we have two networks which are related to symptoms which play an important role in this syndrome, this condition. So what about sleep? What do we know about sleep phenotypes in post-COVID or after COVID in general? We have a couple of polysomnographic studies already. Lots of them focus on sleep-related breathing disorders. But we, until now, already have a couple of others which saw different kinds of phenotypes, also hypersomnia symptoms, which are not so very prevalent in the general population, but here we see them a little bit more often. And we sometimes have reports about REM sleep without atonia. And if you see the whole picture, we have a high prevalence of sleep-related breathing disorders, a high prevalence of insomnia, and quite high prevalence regarded with respect to the general population with hypersomnia syndromes. And in our own study with 40 patients and 40 controls investigated with polysomnography in our sleep lab, we saw, regarding the diagnosis of sleep pathology, we saw also a picture of heterogeneous phenotypes. We had as an inclusion criterion that the subjects did not have to have, they were not allowed to have sleep-related complaints before the infection, and there had to be absence of psychopharmacological medication. So we saw, as reported, a high prevalence of insomnia again, and a high prevalence of sleep-related breathing disorders, and also hypersomnia syndromes and a little bit of restless leg syndrome. We then wanted to investigate into this relevant networks with a focus on sleep spindles, and we saw a significant difference in sleep spindle density with less sleep spindles in the post-COVID group compared to controls. This spindle deficit correlated with cognitive functioning in a test battery, and it also correlated with an endothelial marker of oxidative stress. This was MDA, malondialdehyde, which you see here in the graph. That is preliminary data. And regarding this MDA, we also saw group differences, and our spindle deficit also correlated with ACE2 antibodies. So, and now in our currently starting study, we want to follow this path and look deeper into the sleep phenotypes, also into the sleep-related breathing phenotypes, and then relate these sleep-related findings first to relevant clinical outcomes, and then on the other hand to pathophysiological investigation. And with that, we focus on the hypothesis of vascular mechanisms. And in our previous study, a subgroup of these patients, which I reported already regarding sleep, a subgroup of them was also investigated with MRI, with magnetic resonance spectroscopy, phosphospectroscopy, and there's the same background that we have the hypothesis that there's a damage to the microvascular system and endothelial cells, and then coming to tissue hypoxia and mitochondrial dysfunction in the end. And in this study, we looked at 27 post-COVID patients and 23 healthy controls. They were all after mild acute infection and had a Bell score of around 50. And what we saw here is a significant difference in the ATP level in a very big cluster around the cingulate gyrus in patients compared to controls. So the hypothesis of probable mitochondrial dysfunction with deficit in high energy phosphate metabolism was supported by this data. And this deficit in ATP correlated with cognitive functions. Here I showed you the MOCA results, and it also correlated in the TMTB results. So we, in our currently starting study, we want to do that also, but with 7 Tesla. And in addition to that, we do vascular imaging with ASL, that in 3 Tesla, and we combine this phenotyping of the sleep phenotypes with this imaging, and then with blood-derived vascular biomarkers and with polygenic risk architecture investigation for vascular morbidity. We are going to do this in 75 patients with ME/CFS and 75 controls, and we complement our adult cohort with a pediatric cohort, and that is important for several reasons. One is that the pediatric cohorts and also the severely affected cohorts are often neglected, and we wanted to not do that. And we have the possibility to work with a group of inpatients from a pediatric hospital, which are really severely affected, around Bell scores between 20-30 on average. And the pediatric cohort has another advantage. They are, as they are young people, they have less morbidity regarding COVID-independent vascular diseases, and so as we want to investigate into vascular mechanisms, it is good to have a group of patients which are healthy with respect to this kind of mechanisms outside of COVID. And as they are heavily, severely affected, we needed to find a solution to investigate them. We also make a longitudinal aspect. Also, after years, they are investigated again. And in the first baseline investigation, they are in hospital. But then later on, we wanted to investigate them at home because they would not be able to come into a sleep lab. And so we are working together with the Fraunhofer Institute, and they provide us with a mobile EEG assessment possibility. And the cognitive assessment can also be done remotely. So our aims from this SLEEP-NEURO-PATH study are to relate the sleep-related phenotypes to relevant clinical aspects, relevant health outcomes, like cognitive dysfunction and fatigue, also central nervous system outcomes, and then to investigate possible underlying neurobiological mechanisms. And this aligns with key pathological concepts of endothelial dysfunction and mitochondrial dysfunction with the background of microvessel pathology in ME/CFS. And with that, we want to contribute to a better understanding of the pathophysiology of ME/CFS and with respect to the sleep changes seen very often in ME/CFS, and see how this relates into relevant health outcomes, and maybe whether we can see clinical phenotypes as subgroups in ME/CFS which may be related to different sleep phenotypes. Okay, and with this I'm at the end. I here show you the partner sites with who we are going to do that. That is the University Hospital Schleswig-Holstein Campus Kiel, and we at the CIMH, and the Children's Clinic is a Marine Hospital in Wesel, North Rhine-Westphalia, and then the Fraunhofer Institute in Oldenburg, which provides the mobile EEG technology. And then I thank you for your attention, and of course also the many patients without whom that would all not be possible, and for the funding by the BMBF. And I'm happy to take questions.
This is funny, I can't see myself on the video. So obviously I'm a vampire to the audience. I hope I will be seen in a moment. Well, thank you very much for the very interesting presentation. As we don't have hands raised in the audience at the moment, I would like to start with questions from the online participants. Past CFS studies found increased slow wave sleep and microarousals and decreased infra-slow power. Did you see the same considering trialing baclofen, gabapentoids, clonidine to fix changes in sleep architecture?
Okay. The latter part of the question related to medication. If I got that right, I cannot answer that because in our group they all have been without any psychopharmacological medication. But left that apart, we did not see raw sleep architecture changes if we take out all those who have sleep-related breathing disorders or restless legs, periodic limb movements in sleep. If we only take the pure others, then we did not see sleep EEG changes except our spindle deficit and except hypopneas. We did see quite a lot of hypopneas even in those who did not have sleep-related breathing disorders, and we do see them also in lean female patients, so in those who are not the typical risk profile group of sleep-related breathing disorders. And that's, we want to look into that more deeply because we suspect that that might be a central nervous origin problem.
I hope this answers the question. Thank you very much. Is there another question from the audience? I would have a related question. I mean, how representative is the sample that you're investigating, considering that you're not looking at any medicated patients, particularly considering sleep? I would imagine also in your post-COVID center you observe a lot of patients who have at least tried sleep-improving medications before. So is that like a small group that are really unmedicated?
No, not really. Quite a lot of patients did try a medication before and then left it again. So it's not difficult to get this sample.
More currently unmedicated.
Yeah.
Okay. Good. Then we are still able to make up some time. Thank you very much again for the nice discussion. And then I hand over to Claudia Schnelling as the chair for my last talk.
Continue with Martin Walter.
Yeah, thank you very much. I've introduced myself already. I think I can use this microphone. And yes, I will present another study that is basically run and applied for by the DZPG together with colleagues. I already mentioned that we could confine our research areas during the institution or the setting up of the DZPG, and we brought in some, I would say, complementary expertise which are genuine to the research of mental health that of course start from mental physical interactions, brain process particularly, not only imaging but also imaging the modification of brain processes, and very importantly social stress research, which is the basic foundation also for mental health. And in the field of mental health research, passive observables such as wearables, but also ecological momentary assessments play an important role. So they have already been part of our research portfolio, so to speak, but they also put up us in a position to really investigate post-COVID related changes. In our last meeting in Berlin, which was I think the first DZG post-COVID meeting, I presented to you the brain imaging data in addition to what Claudia Schilling has presented today. But today I would like to emphasize another modality which we realized that the research really could make a difference from a mere scientific investigation to something which has a lot of translational potential. This is the wearable or digital mental health assessments you see here in the lower part, because here we feel that in the patient population these tools are well known, heavily used and discussed, but we quite seldom see it that a patient goes to the primary care physician with his smartwatch or with the Garmin body battery symptoms, and the doctor could really talk to the patients. So here patients currently bring in a lot of information which currently is not used in clinical care, although they may bear important information. That's why we set up a consortium consisting of partners from the DZPG and additional partners, which I will introduce in a moment, in the BMBF data call in 23, and we got funded. And here our aim was to create and develop longitudinal profiles of post-COVID patients, and also to identify disease-specific markers. And here our focus is also relating to Claudia's talk on sleep, heart rate, and physical activity, because there can be nicely passively assessed, and also bring in then the combination with subjective patient assessments such as stress or perceived fatigue. How would we like to do this? Well, here we plan to integrate extensive epidemiological databases. The call was on existing data, so it was not the purpose to generate new data, but of course bringing together post-COVID centers that are co-harmonized by the German Center of Mental Health. We have it easy to also use data exchange infrastructures from the DZPG for exchanging or pooling data. We also had data from non-clinical stress conditions, also BMBF funded. We have, of course, a large set of psychiatric cohorts. That's very important, because in the field of post-COVID, there is always the big question, how much of the post-COVID is actually related to genuine psychiatric diseases, or is it just a comorbid spectrum. So here we bring in, I think, a central competence to say this is really a depression or this is a depressive symptom as part of a non-depressive post-COVID condition. And we also were lucky to bring in health app data from more than 5,000 patients who download those apps because they suffer from fatigue symptoms, and then they track their everyday fatigue symptoms, for example. Then we combine this with use of self-learning AI methods, which are developed in parallel at the DZPG, and the big aim is to use those particularly for long, high-resolution time series, which really allow us to create clinical subgroups on the level of dynamic markers. So this is, I think, something methodologically speaking innovative, and also then to use those markers because we have those long time series of up to 2 years of data, high-frequency data, also to test for prognostic value. This all should serve the purpose to develop variables as a new clinical data modality, which particularly for post-COVID, but also I think in many other psychiatric conditions would be something new. We are aware that in, for example, cardiology, first FDA-approved smart devices are already making the progress towards translation, but for us, and I think also for post-COVID, this would be really a game changer. And of course, this whole initiative also should test how an interface between the German Health Center and other scientific initiatives outside the German Health Center could actually work. What's the methodological innovation? We, I've already mentioned this, feel that we can really collect and make usable data that is currently in the system but not really used. We have the big problem of data quality. So as soon as you go to real world, science normally ends where real life starts, and this is something which we have to overcome. Really adding to the translational purpose, we have to make use of best quality data, particularly from sensor data or from sleep data, Claudia has shown, and then bring them into a format which is compatible to what we observe normally in large data cohorts with a lower granularity normally. And here we introduced the the service of generative models which can generate low-level or low-quality data, which is based on observations which come from high-granular data, for example, from PSG polysomnography to start with. We also were happy that we can introduce patient-centered information, particularly from the subjective dimension from EMA, which are collected already, also part of approved DIGA tools, and then also take this information outside the group that considers themselves as patients toward a more general populations. And you probably are aware of the data donation app, the Datenspende app, which was very successful and collect a lot of data over years from patients. Here we're talking of data in the dimension of up to 500,000 individuals who collected for longer time periods not only their heart rate or their subjective experience, but also many of them also handed in the test that they did when they did the COVID test. When the test was positive, we can actually then look at the evolution of those observables after the individual positive COVID event. So how is the project designed? We bring together multidisciplinary expertise from the different DZPG sites. So here from the psychological and psychiatric dimension, this has a strong focus in sub-project number 1 with Malik Bashbush and Annette Rose from Berlin, where they also bring in NUM-generated data from the Kolpan consortium, which is, I think, can you stop it? I think I forgot to reset it. All right, now my timer has stopped and I can give a good talk. I will run through the other sub-projects very quickly. We also rely on expertise on sleep, basically particularly by Claudia Schilling, who then connects with other post-COVID experts from Munich, Christina Adoyan, for which Tarek Jabrini has presented data today, and then connect this clinical expertise with more data science expertise, both on the level of how do we orchestrate multi-center or federated analysis of data, and also what types of methods do we apply. And here in project number 4, we do have experts on dynamical systems reconstructions, particularly for normative forecasting. I will go into detail in a moment. Basically, the task here is to develop an NFO. This is a neural flow operator method to basically generate models that then can produce data which resembles the data that we observe in clinical reality. And then, luckily, we could team up as the DZPG with Dirk Brockmann from Dresden to then bring these observations into real-world data outside the clinical world. Yeah, how do these projects look like? In project 1, I mentioned we are looking at data that come from psychiatric patients. Here we consider depression not as one disease, but already depression itself is a set of different entities, and we rely heavily on EMA that monitor stress or affect parameters in their dynamic evolution over time. And this method, which is already developed and implemented outside post-COVID, which is basically prone to detect subgroups of patients based on dynamical profiles, we feel is very helpful also to discern post-COVID patients who have depressive symptoms, but are not depressive patients by definition, also from those which happen to have depression as a true diagnosis in addition to a post-COVID condition. This is why we feel this is important. I basically step over the presentation of SLEEP project number 2 because it's very closely to what Claudia has already shown. In sub-project number 3, the idea is to really improve the fairization of data or make data most available not only within the consortium but also towards other consortia. This is something that's an ongoing effort which needs to be also specified for the specific data modalities of variables. And here we can also bring in some strengths of the DZPG, for example, the cohort mapping or the meta-cohort mapping that's part of one dedicated infrastructure. We have a dedicated infrastructure on federated cohort mapping. And here, if you go to the DZPG, you can really look in such databases, you can first see, I want to see all studies which use smartphone or wearable-based data, and then this mapping gives you the name of the cohort, the type of diagnosis these data were collected, and at which sites you can find how many data sets or studies related to this entity. So we feel this is helpful, but in addition to the DZPG located data, we also brought in data from outside the DZPG, namely those BMBF-funded unhealthy participants, such as from the Cello Consortium, a lot of DFG and EU-funded studies on people with psychiatric disorders. As I said, this is important for differential diagnosis, but then also a lot of data from people with actual long COVID symptoms. Most importantly, also here you see quite big numbers from FEMO Health on self-diagnosed post-COVID. And then, importantly, going big data in really large data sets where we want to see how many of these descriptors would identify individuals in a population which initially was not clinical. Here then, sub-project 4 would actually develop normative models based on sleep data, but also on brain data. These normative models are normally designed cross-sectionally, so at the different time points you look at changes of certain parameters, but importantly here, the big methods development would be to generate dynamic systems reconstruction for normative forecasting, which means that instead of a one time point assessment, you learn the underlying dynamics in a certain modality, which is then characterized by a numerical representation of a model that then generates behavior that resembles the true observation. And importantly, this cannot only be done in one modality, but currently there are efforts to generate multimodal generative models that actually produce so to speak, digital twins of the real world, but also allow us for forecasting possibilities of dynamical properties that we can then investigate in patients in greater detail. This is something which adds to something that already works. So going really large data, here 500,000 individuals that track, for example, their heart rate or their steps, and also give us information about when they received a positive COVID test. We already see that in principle there is a lot to gain from these data. So here, having large data, you can also be quite picky. So from 500,000, you go down to individuals that either were COVID positive or COVID negative. So within those 8,000 individuals, you can still then, based on their EMA criteria, say if they were actually COVID positive or post-COVID positive or negative, and then you can even select those subjects which have the best data quality, in this case more than 100 heart rate measures subsequently to look for ongoing dynamics. And then for non-post-COVID, post-infected versus post-COVID, post-infected individuals, you can compare, for example, the heart rate after the infection. But you can also see, for example, for a non-affected individual where the step count returns to normal after at least 6 weeks, where there seems to be a change in step count for the post-COVID assessed individuals in parallel. And this might look a little bit counterintuitive that, for example, the heart rate looks down if you look at individual data, but you can also, of course, group the data, and then you see an increased heart rate, not only after the COVID infection, but interestingly also before. And here we are very interested to see how the dynamic exploitation of this data will lead to further insights. So to sum up, the DZPG can bring in some expertise that helps to quickly exploit existing data and connect databases for greater analysis, or connect expertise from different areas to exploit it in one data set. We also are able, based on the clinical sites that are setting up the DZPG, we bring in about 250,000 patients in our clinical entities that can be investigated by broad consent solutions. And I think quite helpful is the decision of the DZPG to distribute the responsibility for a number of infrastructures that then can step in at a moment for specific new questions that arise, such as it was the case for this BMBF data call. So thank you very much for your attention. Looking forward to your questions.
Thank you, Martin, for this nice talk. Are there any questions from the audience?
No? No? Yes, there's a question. There's a microphone.
This might not be a typical question for the colleagues here today. I'm the father of a ME/CFS patient. My daughter is 26 years old, and the biggest problem we have right now is coordinating day-to-day life for her because of her sleep rhythm. I've heard a lot about the research you've done, and I find it wonderful that it's being studied. Do you have any light at the end of the tunnel with regard to treatment and therapies that could be implemented starting now, perhaps even in the form of taking part in a study? You mentioned medication that stabilizes the sleep aspect. Everything you guys discussed and showed today, she has. I've been able to observe it in the last 7 or 8 years. I'd love an answer to my question, if you have one, please.
Okay. You are speaking about sleep problems, not ME/CFS in general. One of them, yeah. Okay. Okay, we do have working treatment strategies for most of these sleep problems, but we don't know yet whether the treatment works as well as in these conditions outside of COVID. For example, insomnia, we have a very well working treatment. Cognitive behavioral therapy for insomnia is a first-line treatment, and also medication, second-line treatment then. But we do not know whether this kind of insomnia within post-COVID, which newly started in post-COVID, if it reacts in the same way as outside of post-COVID. There are studies running right now. There's a study about CBTI in the US. I'm a little bit hesitating about doing CBTI in insomnia within post-COVID, but there's no data where we can rely on that. We need to study that. Yeah. Mm-hmm. And with other disorders, that's the same. Like with hypersomnia, we do treat symptomatically with stimulants. If there are no more questions, then we can catch up with some time and start our lunch break.
So, at best, all the juniors queue up here. I prefer to queue up there, okay. In order to be really quick, we have only 3 minutes, you know the rules, and there won't be questions, or questions will be reserved for the break, but it's just a quick view of the best junior science. So we had several applications, so we had to bring it down to now these juniors who are queuing up here, and we go right ahead. And the first one is Julian Wagner from Frankfurt, cardiac fibrosis and innovation in long COVID, the role of pre-existing cardiovascular disease. Julian.
Thanks so much for the introduction, also for the opportunity to present my research, or our research here. And I would like to point out that this is a joint project which is done together with Julian Liebertsheimer, who couldn't be here because of clinician services. And it's also a cooperation between Gießen and Frankfurt. So I would like to rule out that there's a strong link between cardiovascular diseases and also SARS-CoV-2 infections. And during the pandemic, it was shown that SARS-CoV-2 basically favors or contributes to the existence or development of cardiovascular diseases, while people having pre-existing cardiovascular diseases were then more prone to SARS-CoV-2 infections and also suffered from more severe infection types. So within the list of cardiovascular dysfunctions, what is quite obvious is that arrhythmias occurred after a SARS-CoV-2 infection or during the infection. And cardiac arrhythmias are also known to be developed because inflammations or cytokines can drive actual fibrosis of the heart and also alter the electrical stability of cardiomyocytes, resulting in arrhythmias. However, a growing body of evidence has showed that also autonomic nervous system showed dysregulations and dysfunctions after COVID infections, which happened in the post-COVID scenario. So the question that we actually were working on is, what is the mechanism underlying autonomic dysfunction in the post-COVID-19 syndrome? To answer these questions, we teamed up with Herold from Gießen to perform mouse studies. What we did here is to use first wild-type mice, healthy wild-type mice, receiving the mouse-modified SARS-CoV-2 strain MA10, and the mice were then just recovered for 28 days. As a second model, we used mice having pre-existing cardiovascular dysfunctions. In this case, we used LDL receptor knockout mice receiving high-fat diet before getting infected to develop atherosclerosis in these animals. After 28 days after infection, we collected the organs and performed histological assessments, and we found surprisingly that in the wild-type mice we don't see that much of an effect. But when it comes to the cardiac autonomic nervous system, so the sympathetic innervation of these left ventricles, we found that specifically on the right-hand side, cardiac innervation was robustly and significantly reduced in the left ventricles of the mice having pre-existing atherosclerosis after infection. Not only innervation was disturbed, also fibrosis was enhanced in these mice having pre-existing atherosclerosis, while the healthy mice that were healthy beforehand showed no fibrosis. To get a full panel, actually, we also assessed by using flow cytometry the immune cell makeup of the hearts of the LDL receptor knockout mice. We found that the recruited myeloid cells were not changed. However, we found a drop in the tissue-resident macrophages. The use of single-nucleus RNA sequencing data on these mouse hearts revealed then, and specifically look at the overall population of macrophages, that when the most top downregulated growth terms of the macrophages after infection, we found axon guidance and nervous fiber growth terms to be downregulated. So this suggests, is our hypothesis, that tissue-resident macrophages might stabilize the cardiac innervation in the heart, and after the post-COVID or like after infection, we have a loss or a reduction in the tissue-resident macrophages, leading maybe to a reduction also in the autonomic nervous system. With this, I would like to acknowledge not only the partner site in Frankfurt, so the institute from Stephanie Dimler, but also the institute from Sonja Herold, who developed the mouse model, and my funding partners, and would like to take any questions after then the panel discussion.
Thank you very much. Please come ahead. Next one is also from Gießen, also keeping the topic on cardiac and ventilatory inefficiency. Please, Dr. Oruqaj.
So thank you for the introduction. I'm honored to present here the data from our study insight from the PULVAS core study, specifically focused on ventilatory inefficiency and low cardiac preload in post-COVID associated dyspnea. As we all here mentioned many times, as a post-COVID syndrome is an heterogeneous condition affecting many organs. Specifically, we are focused here on cardiorespiratory symptoms, heart and lung, especially in dyspnea associated post-COVID. The aim of the study was the investigation of cardiopulmonary factors which are associated with post-COVID related dyspnea and exercise limitation, stratification of subgroups according to exercise limitation, and generation of subgroup-specific treatment approaches. The method in this study, this is a multi-center cross-sectional study including 4 main centers in Gießen, Berlin, Hanover, and Munich. We studied the 86 patients in the study involved, post-COVID patients and 12 controls, and we conducted a deep phenotyping by using different analyses like questionnaires, blood gas analysis, CPAT, 3D echocardiography, vascucist, as well as then right heart catheterization in a subgroup of patients. The results, the post-COVID patients exhibit ventilatory inefficiency and impaired cardiac feeling, showing by the increased dyspnea index, lower performance, and lower ventilation, decreased PET CO2 levels, and increased ventilation equivalence for CO2 associated with reduced right heart, right atrium and systolic area index, and right ventricle and diastolic area index, with the right, so reduced size of the right atrium and ventricle, and the lower oxygen uptake. In addition, the association of the key functional markers like with the breathing frequency and forced expiratory volume, and right atrium and systolic area index as well, with the decreased size of the right atrium and the right ventricle. The mechanism is that the fast breathing at exercise, low lung volumes, and low preload lead to dyspnea
a low ventilation, a low aerobic capacity to reduce exercise capacity. So to summarize, post-COVID dyspnea and exercise limitations is a combination of factors, including ventilation limitation and preload insufficiency with subsequent tachycardia, and the phenotyping and grouping of these patients is very important, as was already mentioned, for the personalized targeted therapy, where we found the 3 different groups where with one group with the bronchial and left ventricular limitation, the first, the hypercirculation, the second, and the third, which was interesting with the VQ mismatch, low blood pressure, hyperventilation, and low aerobic capacity. By phenotyping these patients, post-COVID patients, it might lead to personalized strategic therapies according to the symptoms. And in the end, I would like to thank all collaborators who contributed, the whole centers in Berlin, Hanover, München, Marburg, ILH, and thank you for your attention.
Thank you very much. The next talk is by Georg Fritz Kurze from Dresden on parasympathetic inflexibility versus a potential central factor in post-COVID syndrome.
Yeah, first of all, I want to say thank you for the opportunity to speak here today. My name is Georg Fritz Kurze. I'm from Dresden. We are biopsychologists, a youth research group, and we focus on stress and exhaustion symptoms. That's why we want to understand the development and persistence of exhaustion symptoms following COVID. Our idea was to operize the neurovisual integration model, which proposes that the vagal control and therefore the parasympathetic nervous system plays a key role in the regulation and the reaction of an acute stressor or acute infection. Therefore, there's one clear hypothesis for us. We do believe that the parasympathetic inflexibility may impair recovery and amplify exhaustion symptoms after SARS-CoV infection. So in other words, we believe that it's not only about the intensity of the viral load or the viral infection, but it's also about the way our body and the parasympathetic nervous system regulates the reaction of this intensity. How are we testing this hypothesis in the study? So the COVIC study is short for COVID exhaustion study. As I said, we are psychobiologists, so we want to understand the perception of exhaustion and development of this perception, and therefore we are tracking the symptom trajectories over 1 year, starting in the acute phase after the infection with our participants, and then with 2 follow-up dates after 6 and 12 months. What are we assessing? We are assessing a battery of psychological questionnaires, including perceived stress, perceived exhaustion, MHC-class I, but as well physiological data in form of a 72-hour ECG, heart rate variability included there, as well as hand grip strength, hair cortisol, and other factors. We do hope or do believe that this is the best way to understand this really crucial point in time where the acute symptoms go persistent over time in this exhaustion. There's another study which I want to give a quick outlook because of the time. It's a complementary insight. We did conduct 10 years ago the Dresdner burnout study, so we do have a sample pre-pandemic, and we do have frozen blood samples and ECG before the pandemic arises or started, and we are reassessing the sample in October 2025, and we do believe that this multimodal approach with a retrospective and prospective view can help us understand development of exhaustion symptoms as of the view and the perception of the people who have the symptoms. Yeah, thank you. We are right now in the second wave, so preparing in June to start the 6-month assessment. So if you have any great ideas, we're open to it. Thank you.
Good afternoon, everyone. I would like to thank you for this opportunity.
Just wanted to introduce you, but go ahead.
Okay, sorry.
So this is Giovanni Vardiero from Tübingen, and go ahead, please.
Yes. Yes, I would like to present these ongoing studies on transcutaneous vagus nerve stimulation for improved recovery after exertion. As we all know, and we are here, yes, long COVID is a complex non-monolithic multi-system disease, and fatigue is one of the main symptoms present in long COVID patients. And very interestingly, also severity of symptoms is associated also, of fatigue is associated as well with severity of depressive symptoms and also autonomic dysregulation. And this autonomic dysregulation could also due to vagus nerve dysfunction, and it has been shown also there are morphological changes happening in long COVID patients, and there have been also pilot studies running transcutaneous vagus nerve stimulations and yielding promising results on ameliorating symptoms of fatigue. However, there is no established treatment yet, and there is a need for a well-powered and well-designed random clinical trial. And for this reason, we are currently running a single-blinded randomized crossover designing with 120 participants that encompasses a baseline assessment with blood draws, questionnaires, and a motivation task. And after 6 weeks and 12 weeks of either high intensity or low intensity transcutaneous vagus nerve stimulation or treatment as usual, also we're gonna run the same sessions. And then during these periods of the intervention phase, we are going to ask the participant to apply transcutaneous vagus nerve stimulation on up to 4 hours daily, while we track also physiological signals and also mood changes with the ecological momentary assessment. And with this design, we are able to assess stimulation-induced changes on motivation, fatigue, and depression, with the aim to investigate the effectiveness of TVNS as a self-administered treatment at home to promote recovery. And in order to also investigate how the motivation works, participants are conducting the effort allocation task, where they have to raise the ball by pressing the bottom as fast as possible, and they need to bring the ball up on the above the red line, and when the ball is above the lines, also for each seconds the points are summed, and then we will compensate with a monetary compensation. And at the end of each trial, we also ask how much did they excite themselves and how much did they want the reward. As a baseline preliminary results, we saw that indeed participants are showing fatigue symptoms from mild to severe, and they are also highly correlated with depressive symptoms. And in order also to better visualize how this fatigue also interacts with the motivation, we divided this group in 2 subgroups, in higher and lower fatigue. And when we look at the performance of the AIT task, we can see that the participants with higher fatigue group, they do have an invigoration towards goal-directed behavior, which is much lower than the lower fatigue group. And also when compared to their subjective wanting of a reward. So to conclude, I would like to say that the effort allocation task is a useful behavioral tool to assess motivation-related mechanisms, underlying core symptoms of long COVID, and that we hoped with this single-blind randomized clinical trials to shed light on the potential of vagal afferent stimulation to facilitate recovery. Thank you.
Thank you. And the next one is Rieke Baumkötter from Mainz. Risk tools for predicting long-term sequelae based on symptom profile after known and undetected SARS-CoV-2 infections in the population.
Thank you very much. I'm very happy to present the data of this project. First of all, I would like to point out that this project is funded by our several partners. Since there is still no diagnostic test or biomarker available, post-COVID remains a diagnosis of exclusion, requiring extensive efforts of patients and physicians. Therefore, the aim was to generate and prospectively validate data-driven scores for the risk and diagnostic assessment of post-COVID syndrome. For this, we use data from the Gutenberg COVID-19 study. This is a large population-based cohort study, and here SARS-CoV-2 infections were screened systematically, so we could identify unknown infections, and individuals with but also without SARS-CoV-2 received a standardized assessment on long-term symptoms based on the WHO post-COVID catalog. With machine learning techniques, we generated 2 scores, one prognostic score to predict the probability of developing long-term sequelae based on the symptom profile during the acute infection, and a diagnostic test to exclude post-COVID based on symptoms that discriminate between cases and controls. And due to the time, I will now only refer to the diagnostic test. In total, 21 symptoms were selected that discriminate most between individuals with and without a previous SARS-CoV-2 infection, with a cross-validated AOC of 0.66. Taste disturbances, brain fog, and dyspnea were more common in individuals with a previous SARS-CoV-2 infection, whereas mood swings, sleep disturbances, and headache were more common in controls. The test has a high sensitivity of 95% and a negative predictive value of 99%, so it's suitable to rule out the presence of post-COVID. We were able to prospectively validate the score in an independent cohort of around 20,000 participants in Rhineland-Palatinate, also during a time period in which newer variants of SARS-CoV-2 were dominant. So in conclusion, the test is quick and easy to use, especially in the initial management of potential post-COVID patients, as only self-reported symptoms are needed. The test is highly sensitive, so it's suitable to rule out the presence of post-COVID and to guide further diagnostics. However, it is not suitable to diagnose post-COVID as symptoms alone are not sufficient for a diagnosis. And lastly, the scores will be made available to healthcare professionals via a web-based application. Thank you very much.
Thank you very much. And we come to the last presentation, which is given by Dr. Khatami from Mainz, Proteomic Atlas of Post-COVID Sequelae. Please.
Good afternoon, everyone, and I want to thank you for giving me the chance to be here. I'm going to present a result of a study that me and my colleagues in the EPIC-AI consortium did. So post-COVID syndrome affected around 30 to 50% of survivors. However, its biological mechanisms are poorly understood. So we we measured the 3,000 protein from the 500 SARS-CoV-2 survivor and analyzed the result with cutting-edge machine learning method. Our key findings are we found that 235 proteins tied to 15 symptoms. Majority are unique, but some of them are linked to several symptoms like interleukin-1 alpha. Also, we found that distinct cluster of the symptoms correlate with a specific protein profile, and the symptoms with similar protein profiles often co-occurred in the patients, for example, fatigue and shortness of the breath. Also, we found that protein signatures were associated with objective clinical tests, suggesting the diagnostic potential of this protein, including the cognitive test for memory symptoms. Also, we found that a pre-existing condition or risk factor may influence the development of the specific post-COVID symptoms, such as diabetes and the memory issue. And finally, we found that genetic predisposition also linked to the certain symptoms, for example, the cholesterol and fatigue. With that, we showed that the post-COVID sequelae or syndrome is manifest as a discrete symptoms cluster, each with its unique molecular signature, which show us to breaking it into a cluster could improve the understanding, the treatment, which this may pave the way for target therapies and personal medicine for post-COVID patients, which is our ultimate goal in our EPIC-AI consortium. With that, I want to thank you, everyone, and happy to answer now or later any questions. Thank you.
So a big applause for all the young investigators. Maybe you come once in the front of the screen that we can also make a photo, and thank you very much. So I think you deserve the photo. Thank you very much. It was a wonderful talks, and good luck with your research. And we have time in the coffee breaks for questions. So, and I hand over now to Susanne.
But I don't want to enter the photo. All right. So, okay, thank you. Now we are going to continue with the lung part of today's meeting with the DZL presentations, and I'm happy to welcome Natascha Sommer from the Gießen side of the DZL, presenting data on the Gießen and also whole DZL Pulmonary cohort. Please, everyone, stick to the 10 minutes talk time now, because now these talks will be a bit shorter than the previous presentations, because we have 4 talks in that session, something like 8+2 or so. And Natascha, again, thank you and welcome.
Yeah, thanks, Susanne. I'm happy to now start with the presentations for the lung area, which of course is one of the most important areas, because COVID is a lung disease. And I'm also happy that Gani already gives some introduction into our pulmonary cohort, so it will be easier probably for me to keep the 10 minutes. So now we have seen today a lot about symptoms, and I mean it's clear that post-COVID has lots of symptoms, and I'm focusing today on dyspnea or exercise limitation. We know that this is a very frequent symptom, although also fatigue is very frequent, and I will not talk today about this special form of fatigue, which is this post-exertional malaise-related fatigue, but try to focus really on dyspnea. And we as a pulmonologist department saw in the beginning lots of different patients which all complained about dyspnea and exercise limitations. And it became quite clear pretty early that these are all different patients and it's a very heterogeneous group. And I tried to kind of categorize it a little bit. So we have these patients with coughing, with chest pain, which is potentially primary respiratory symptoms, maybe with severe COVID. Then there were patients coming mainly with tachycardia, which limited them, and patients with these neurological symptoms or with more psychiatric symptoms. And our aim in our study was to figure out if in this really heterogeneous cohort there's a common denominator, so which limits all these patients similarly, or if we can define subgroups, which was like clinically a little bit evident, where we have also specific treatment approaches. And to do this, you first have to think for a minute about how is dyspnea caused, and it's for some reason not that trivial for many also young physicians that dyspnea is not only hypoxemia. I mean, this is one component in the chemoreceptors, but dyspnea is mainly sensed by receptors, vagal receptors. We already heard a lot about the vagus today, and mechanoreceptors in the chest wall, which just sense that the mechanical stress does not fit to the brain input. Furthermore, we have to keep into account that as a cardiac impairment can cause dyspnea via receptors in the lung that sense the dilatation of the veins, and also baroreceptors. And there's also connection from the muscles to dyspnea sensation via the sympathetic nerves. So we tried to look in a more holistic approach on all these different factors. There's a lot published like on single factors, for example, like the diaphragmal weakness, but we try to integrate this somehow and try to understand which patients are caused, have the cause of dyspnea of which component. And Gani already showed you that we did this in this so-called PUNVASC study. It's a multi-center study with different centers in Germany, DZL centers, and we had a cohort of patients, a small control group, different methods, and by this we wanted to measure all these potential causes for dyspnea, which I just have showed you. And this is now something that also overlaps a little bit with Gani's presentation. Sorry for that, but he was selected for an abstract, so he presented this already. So what we found is first we looked what kind of features does this cohort have. And what we found was that they have quite low PET-CO2 in the CPET, and high EQ CO2, so it's a kind of ventilatory inefficiency. It's a very unspecific sign, can be due to hyperventilation, can be due to increased dead space, but it's a kind of objective parameter that somehow the ventilation is not efficient and efficiently coupled to the circulation. This was quite nice to see because it has been described before. So there are several publications that show that there's a ventilatory inefficiency for whatever reason. Then a second point, and there we were more surprised, was we did a deep phenotyping of the heart, especially of the right heart. Our center focuses on pulmonary hypertension and has established methods for subtle measurements of right heart dysfunction. So we thought if the right heart or pulmonary vasculature is involved in the dyspnea, we would be able to detect it by 3D echocardiography, stress echocardiography. And our initial hypothesis was that there may be an increased stress on the right heart. However, what we found surprisingly was that the right atrium and the right ventricle in our cohort with patients was relatively small compared to published normal values, but also compared to our control group. The oxygen uptake was also decreased, but this is nothing I would like to focus today. So I would like to focus on this relatively small right heart, which we thought, well, is this relevant or not? And then we did correlations to dyspnea. So because a lot is published, a lot of observations has been published, but often this is not correlated really to the symptoms of the patients. And what we saw here, this just depicts the findings with the most relevant correlations. And what we found was at first that dyspnea in our cohort, so this is the PCS, is higher if the exercise capacity is lower. So this is kind of intuitive. We found also that the dyspnea is somehow, high dyspnea is related to low lung volumes and a high peak breathing frequency. And it was also related to the size of the right heart. So here, this is the right atrium, this is the right ventricle. So this gave another hint that this may really be relevant for the patients. We also found that dyspnea was correlated to diastolic dysfunction. Or not, it's not a dysfunction really, it's diastolic function. So the better the diastolic function, the less dyspnea. And interestingly, this was also true in the controls. So this seems to be a general feature that you can better work under exercise if your diastolic function is better. Another factor that is related to this is this so-called aortic impedance index, which gives a measure for the stiffness of the vessels. Everything was related to heart rate, so dyspnea, the more dyspnea, the higher the heart rate. This was an observation we had made. Then when we did multivariate correlations, we found that the size of the right heart is still correlated to dyspnea. So obviously there is a parameter that seems to correlate, although only weakness, but to dyspnea. So I will not go focus today due to sake of time on the lung ventilation, but this is another component which may cause dyspnea. And this right heart or right atrial size, again, was correlated. So what patients are these with this small heart or small right atrium? They have a high heart frequency and they have high VQ mismatch. So this seems to be a phenotype which is described when we go to literature as preload insufficiency. Preload insufficiency means that during exercise you can't fill your right heart, you can't give enough volume to your heart, basically. We had some invasive measurements which were confirming this. This is only a small number, but we did not too many invasive measurements in patients. But we saw in the patients exactly what we anticipated, that under exercise the right atrial pressure does not increase. Obviously the preload is not sufficient. And this syndrome has been described in this nice paper as a reason for unexplained dyspnea. And it fits to our observations with this kind of VQ mismatch, what they have, positional VQ mismatch especially, and we found also some lung hyperinflation. So we believe that this preload insufficiency may be one component observed in all post-COVID patients, which contributes to their symptoms. And there are different diseases which are related to this. Then we did a subgroup analysis to see, because the correlations were quite weak, of course, but I think this is intuitive because there are these heterogeneous patients. And we thought, could we find more subgroups? And here I just want to focus on two subgroups we identified. And so there are two subgroups which have even more pronounced this kind of preload insufficiency, and they are characterized by a pronounced VQ mismatch, low blood pressure, and hyperventilation. And then there's an opposite group, which is more characterized by their dyspnea correlating to bronchial limitations. So these were like ex-smokers often. They had a high resistance of the bronchial system. And it was correlated to a pretty low diastolic function. So we believe by further subgrouping these patients, we can find distinct additional features which limit them in their exercise capacity. So we propose this kind of multifactorial causes for dyspnea and exercise limitation post-COVID, with one feature being this preload insufficiency and potentially subsequent tachycardia. Additional features in specific groups are bronchial and left ventricle limitations, so this I would call the comorbid phenotype or the endothelial dysfunction phenotype. We already heard a lot about that today. Then we have this phenotype which is more going in this direction of low blood pressure, and I would call it a POTS-like phenotype. And there is a phenotype which having hypercirculation very prominent. And for them, of course, specific treatment options would be useful. And this is what we heard a lot about today. So what would integrate some of these alterations is an autonomic dysfunction. And here in a sub-study, we found that the sympathetic drive in these patients, in selected patients, was also increased. With that, I will probably not show where to go because now the time is gone. But I think we need to confirm this now in a second cohort, and probably even go multidisciplinary and multi-center to get a toolbox how to phenotype these patients over several centers, and then see if we really can confirm these phenotypes and treat them specifically. And there are treatment options. Finally, I think it's the aim what many of us have, that then from these phenotypes we can define endotypes and pathomechanisms to go deeper into treatment approaches. So with that, I would like to thank all of the collaboration partners and the BMBF for funding this study, of course.
Thank you very much, Natascha. I guess I have to be here, right?
Yes.
Are there questions from the audience? I actually have a question regarding the small right heart that you identified. So you already said that it's hard to correlate to something at this point, but can you speculate on what is the pathophysiological relevance of this? What are causes or consequences in that regard?
Yes. So, it depends if you have a real preload insufficiency where you also have this tachycardia, which limits the patients a lot, or if this leads to some diffusion disturbance and activation of baroreceptors, which may initiate a flat and fast ventilation. So I think it's connected via baroreceptors to ventilation and thereby to dyspnea sensation. It's it's also a cause for the low DLCO we see in the patients. So in many patients, and this is a very persistent thing, we see low diffusion capacity. And I did in the beginning a lot of ventilation, scans or CTs to figure out the low DLCO, and there was nothing. There were no lung embolism, no CTED. So this may be because the volume of the pulmonary vasculature is low, so just the blood volume is low, and this then may lead to DLCO.
Right.
Yeah. So this may be the consequences of that.
Okay, thank you. I think there are no further questions, so thank you again, and I'm happy to introduce the next speaker to you, which is Herbert Schiller from the DZL Munich site. Herbert is going to present data on autoantibodies related to post-viral syndromes. The stage is yours.
All right. Thank you, Susanne, for the introduction. I'm happy to be here to talk about one of the methods we developed in the lab. So in my lab, we focus on regenerative mechanisms in the human lung. We use kind of the experimental systems biology toolbox to look at cellular and molecular processes in lung regeneration, how that fails or changes in the aging process and in chronic lung diseases. And of course, the immune system is very important in tissue repair processes. And I will mainly touch on one method that we use to look at autoantibody profiles. So today in the morning we heard a lot about how autoimmunity seems to be really associated with post-COVID, post-viral infections in general. So this is now very well known, as shown in this very large meta-study here. After COVID-19, it was quite clear that all kinds of autoimmune diseases are increased in the after COVID-19. And in general, the risk of developing post-viral sequelae, so these syndromes like ME/CFS, they have been known before, but now the pandemic gives us the chance to study them in larger patient cohorts. And this will also be very important for maybe future pandemics. So early in the pandemic already, there were lots of reports about autoantibodies. So for instance, autoantibodies against type 1 interferons have been associated with more severe outcomes. Then there are other reports about protective roles of these autoantibodies. So it's quite unclear, but there were lots of reports. And more recently, there are first, you have correlation and causation, and there are first attempts now, first evidence, where when you transfer antibodies from patients with specific, we have heard about different endotypes of the long COVID. So patients that had more myopathy type symptoms or neurological symptoms, some of these symptoms were phenocopied in the mice when they received antibodies. So in my lab, we do a lot of tissue slice cultures, so maybe there is a chance to also study functionally some of these autoantibodies in human tissue slice cultures as an outlook. So now I will talk about what we did in terms of profiling. This was in acute COVID setting, and we teamed up with Scott Badinger at Northwestern University in Chicago. They had an ongoing study where they for a long time already studied influenza patients. So here we have very good controls because we want to know what is specific to COVID versus influenza. And we also had the bacterial pneumonia patients here as a control. And we used mass spectrometry to look at the bronchoalveolar lavage of the patients when they get intubated in the ICU. They got lavaged, and then we followed over time. So this is a longitudinal study, and also had the matched serum from these patients. And as you can see in these heat maps, those are blocks of proteins that correlate very highly over patient groups and time points. You can find groups of proteins that are very highly specific for either influenza or COVID or bacterial pneumonias, both in the lavage fluids and in the serum of the patients. And here's one example of something that you would maybe expect. This is a group of proteins that was very much enriched in the bacterial pneumonias already. So here you see two different time points from time of intubation. Oh, is that my time? No? Okay. And so you can see that this protein profile here correlates with neutrophil degranulation. So these are all proteins that are probably involved with neutrophil degranulation, and they correlate with the number of neutrophils. And here on the right side, I'm showing you one example of a group of proteins that was very much enriched in the COVID patients, and it also persisted into the later time points. And those were all kinds of antibodies. Of course, you could find antibodies that diffused from the blood into the lung when you have a barrier leakage. And we made use of the fact that we have both modalities, or both body fluids measured. So here the serum on the y-axis versus the lavage fluid, the local fluid. And you can see proteins that highly correlate. So those are serum proteins going into the lung. But then you can see proteins that are highly enriched locally in the lung. They're also detected in blood, but we interpret this as a local production of these proteins. And this includes many antibodies. So specifically here, you can look in these red triangles. You have all these different V segments marking different antibody repertoires. And many of them are actually highly specific for COVID-19, and especially those local ones. So the blue ones, the non-local ones from the blood, they were actually shared across all the different pneumonia entities. So this suggests there's a local pool of specific variable domains of specific antibodies, B-cell clones that are specifically induced by COVID-19. We went to other independent studies where you have a VDGR profiling of the B cells and asked whether the same V segments, so the same type of antibody rearrangements, are associated with severe outcomes, which was indeed the case. So in our case, it's a very severe group of patients. And so this means there is a specific repertoire of the antibodies in severe COVID-19, and we could ask, okay, are these autoreactive antibodies? And we have previously developed this method where we capture antibodies from patient blood. Here in the first publication, we applied this to lung fibrosis cases. We capture the antibodies, and then we incubate the antibodies with a natively extracted protein extract from human lungs in this case, and then use mass spec to quantify the binding profiles. So you can identify autoreactive bindings. So this was validated with the clinically approved or clinically used ELISA test for, in this case, scleroderma autoantigen. These patients all had a clinically diagnosed autoimmunity, and that's the antigen. And we had almost 100% sensitivity and specificity using mass spec to arrive at the same result. But then you can appreciate in this volcano plot, we can detect all kinds of autoantigens, and it's kind of a multiplexed, unbiased experiment. Applying this to the COVID cohort here, again, same grouping, and we also measured antibody profiles at different time points. Same method, and also here we have kind of a proof of concept example. Some patients received tocilizumab, which is a therapeutic antibody against anti-IL-6R, and only in these patients we pull out IL-6R because these therapeutic antibodies bind to our beads, and then this was a good proof of concept that we are measuring the right thing. Then, of course, we can identify different autoreactivities. So here shown for two different comparisons. In the first cohort against bacterial pneumonias and against influenza. So those are the COVID-specific putative auto-antibody reactivities that are shown here. And we did the same for a cohort from Munich. And I should point out there's a very high heterogeneity, which is, I guess, problematic. However, there is some consistency. So we find many shared antigens in both cohorts, some of them immunomodulatory, some of them against complement proteins that we have heard earlier today. And many of these very significantly correlate with some of the clinical features. So this is, of course, way too complicated, but there's some interesting associations, as I'm showing here as example cases with the clinical outcome scores or some of the different blood parameters. So we have, generally we have autoreactivities that are associated with a more severe or less or more detrimental outcome. And we also have cases where this seems to be the other way around. Having the antibody seems to be protective. So this is, of course, now the tricky part to interpret and to make use of these things. So as a summary, I have shown you that there is a persistent presence of a specific B-cell repertoire and associated autoreactive antibodies in severe COVID-19. We can use a mass spectrometry-based profiling for unbiased and highly multiplexed characterization of autoantibody profiles in long COVID. So going forward, I think that the application of this method may improve endotyping. So we have heard that some clinical trials didn't give the right results. I think it would be interesting to have this as an additional modality in some of the deep phenotyping efforts in the larger cohorts. And with this, thank you for your attention. I thank all the funders and happy to take questions.
Thank you, Herbert. I guess there are questions. If not now, I will start with one. So you find a lot of antibodies that are reactive with tissue, right? And tissue surfaces. Mm-hmm. Did you also find anti-cytokine antibodies, or was that included in your screen? First question, because many studies done on that find anti-interferon and anti-interleukin.
So by definition, everything is included what is in our pool of proteins that we extracted from basically the human tissue in this case. So in theory, we are offering a human proteome, which also has all the PTMs that may be needed for the antibody binding. Most of the proteins we find are intracellular, but there are cell surface receptors and in rare cases also some cytokines included. Yeah?
And maybe a second question in that regard, how are you moving on now? Are you trying to identify which of those autoantibodies are really binding antigen or eventually even neutralizing receptor activity or something? Like how functional are they?
Yeah, so by definition they are binding because that's how we measure them. We don't know about affinity and all these things, and of course we don't know which ones are causal in terms of exacerbating the disease, for instance. So in our ILD study we have found that autoantibodies against thrombospondin 1 in 2 independent cohorts were significantly associated with survival. Right. So that there could be some of these antigens also be associated with some clinical features. Okay, but thank you. Currently it's only correlation. Yeah.
There are a few further questions. Christina.
Thank you very much. Very nice data, and you very nicely showed the different potential antigens. My question is, you showed it in different diseases. Do you have an idea whether healthy individuals might also have a prevalence for clinically not relevant autoantibodies, so that it's a secondary event that the infection then drives them, or whether it's a de novo event that gives sort of a new autoantibody repertoire?
Yeah, that's a great question. So in the LD case, our controls were healthy age-matched individuals. So the assay is defined by the difference to these people. But then within the control cohort, of course, you can find outliers that have very strong bindings, and this could be subclinical in a way. Yeah.
Yeah, really cool. From the autoantigens that you showed, do you think that they're presented, or that it's molecular mimicry, so that the antigens, proteins you see, the autoantigens, are really presented on MHC, or that it's just antibodies binding random, semi-random?
Yeah, that's a great point. I guess at this point we don't know. It's hard to say. So I guess in a tissue injury and repair context, the appearance of low affinity autoreactivities, even without a classical immune presentation, are possible. So I don't know. Yeah.
Time for one last very quick question.
Also a question regarding autoantibodies you may find in healthy volunteers. Did you find any signal regarding G protein-coupled receptor antibodies?
Yeah, unfortunately, mass spec is that's one of the limitations, that GPCRs often have lots of transmembrane domains, so they're a little bit harder to detect, and they are underrepresented in our analysis. So I think there could be great synergy between such assay with a more targeted assay for GPCRs. Yeah.
All right, thank you again, Herbert. And I'm handing over to Remberg Kotzila.
Thank you, Susanne. So it's a great pleasure to guide you through the second part of the session. And we now focus on lung imaging. And I ask Professor Vogel-Claussen from Hanover to come to the stage. Thank you for being here.
Yeah, thank you for the opportunity to present here. And the work we're presenting, there are like three main studies we did. Is interdisciplinary work. But as I'm a radiologist, you're hearing this through the radiologist eye. And I would like to introduce to you two technologies which we sort of established and partly invented in Hanover as part of the DZL funding, and we're very grateful for that, because without the DZL funding we wouldn't have been ready with that technology to image the lung function in the COVID pandemic. So I think this is great. So we have been really prepared and could roll out this technology. So what did we do? This is called pre-fall. With MRI, there's very little signal in the lung, and the lung looks dark, like here. But if you image over a minute and then go into the frequency space of the breathing and reconstruct a whole breathing cycle, you can see regional ventilation. And what you see here is inspiration and expiration. And you even see the trachea. Do you know why you see the trachea? There's only air in the trachea, you shouldn't see. But the trachea is moving, right, with the breathing, and that's why you see it. And then if you go in the frequency of the pulse of the heart, you can see during the cardiac cycle how the pulse wave, right, goes from the center to the periphery in the lung and backward. So what we're actually seeing here is not truly perfusion, it's the pulse wave, it's the fresh blood flowing in, and we reconstruct the whole cardiac cycle. And with that, I hope you're all researchers, a lot of lights go on and you can measure a lot of things. And this is what we did, and this technology, I have to disclose, gets productized by a large imaging vendor. And so we collaborated with them and brought the technology to Erlangen, where they had a brand new low Tesla MRI and tried this out, and they got very surprising results. They had 9 healthy controls, 29 patients with COVID, so kids, they were like around 11 years old, who recovered, and 25 with long COVID. So all more than 12 weeks out, 12 weeks to a year and a half. And they saw a lot of perfusion defects and ventilation defects here in even the recovered ones, right, as well as in the long COVID ones. And both were more severe than that. And they put all the two groups together because it was very new. Nothing much was known about that at that time. And they saw that even if it's out longer from COVID, these are the days, right? You still see ventilation problems, perfusion problems, but these are the two groups mixed to each other. Is it just from normal, right, longer period of recovery, or is it something else? I can tell you one I know for sure as a radiologist is a shift, because they did a low Tesla MRI and they had more noise. You see the healthy ones having a VDP of more than 10%. This is due to the noise. So you have to deduct 10% from all the data. Then you're probably right. There's a bias in there. But you can see here, even after a year, right, you see a VQ mismatch. So gee, we thought we have kids in Hanover as well. And we will do this diligently with a 1.5 Tesla, and we had a matched healthy control, age and sex matched, and we had a matched post-COVID condition cohort. They're around 14 years old. And the median was 30 weeks after a positive COVID test. And we could pick up, right, so some mild ventilation heterogeneity, but in the post-COVID syndrome, there was really a striking lower perfusion signal than in the healthy volunteers. And this was also in the numbers, right? This is the dynamic flow volume loop, because if you depict the whole ventilation cycle, you have a flow volume loop with each voxel, right? As you know from lung function tests, it's only tidal breathing though. It's not a forced expiratory volume. And you see it, and the cross correlation should be 1 in normals, and you see the heterogeneity here, but in the 27 it wasn't significant. But we had this very strong signal in the perfusion, right? We quantify it in milliliter per minute per 100 milliliter of lung, and you see this is normal here, 80, and it was close to half, right? In those post-COVID condition patients. And the heterogeneity was also affected. And then we said, gee, maybe this correlates to the symptoms. And the pneumologist had the BELT score and the symptom severity, and indeed, only the quantitative perfusion signal was related to severity of symptoms. And in the publication by Pöhler et al., we showed this, right? The BELT score goes down, the perfusion goes down. The second method I would like to introduce you in the short time is hyperpolarized xenon. With the first technology, you can do it. You can collaborate with us. We give you the app, and you're good to go. Here, you need a little bit more. You need a hyperpolarizer, and you need a dedicated coil. So it's more costly. But what it can do is that the gas doesn't only go into the alveolar space, it goes into the membrane and it goes into the blood. And due to the frequency shift, we can see and tease out the different compartments of the xenon in the alveolar space, in the membrane, and in the blood. And this is from our post-COVID cohort. We did a post-COVID cohort after hospital discharge, when they were negative with a negative COVID test. And then 7 weeks later, and then about 30 weeks later. And you can see here, this is the red blood cell signal, right? You can see that gradually the red blood cell signal becomes more. Here you see that, here's discharge, and this even baseline, this is about 12 weeks after symptoms, this is 38 weeks after symptoms. You see even an improvement here, while lung function test was not changed. And alveolar membrane function is improvement. The perfusion heterogeneity is going down in the capillaries. So this methodology, because it goes into the alveolar membrane, it specifically measures the capillaries. And the capillary blood velocity increased logically if you have increased, if you have less inflammation increase. And you have a worse membrane function 12 weeks out after if it's more critical or if you're in ICU. And it seems to be also having a T-cell signature, which is different if you're having a critical ICU stay or a non-ICU stay. And imaging correlates, the membrane function correlates with these cells, with CT imaging with the ground glass opacities and the DCLO. So summing up, we're very grateful for the DZL, that we had the technology ready, pre-full MRI and xenon MRI. If you're interested after the talk, come talk to us. The post-COVID condition in children, 30 weeks out, and the symptom severity correlated with a microvascular capillary perfusion signal, and alveolar membrane function and pulmonary blood flow recovery depends on the severity of symptoms in the initial phase, whether you had a severe course in the ICU or not. In general, that showed our xenon data, pulmonary blood flow, and that's the good news, and regional lung function are back to pre-COVID conditions if you have a normal course within 38 weeks. But we know, all of us who are sitting here, that long COVID is complex, and we need to study the long-term effects on morbidity and mortality, not only in the lung, but everywhere else, and that's why we're sitting here. Thank you.
I think we have time for one short question.
So the perfusion decrease in the children, was this homogeneously distributed or was this patchy? So is it more a general decrease of flow?
It was more general, in general. It was a little bit more patchy, but in general, the whole, and I didn't disclose, the children with the post-COVID condition had a higher heart rate to probably make up for it.
So
it was significantly higher.
Would fit to this preload insufficiency that we also found with having a lower blood volume in,
yes,
in the lungs.
I think so. And the filling, someone said earlier today, is probably impaired in them. So it'll be very interesting, based on these data, to do larger scale studies. And this technology I showed you first, you can do at your hospital, and we're more than willing to help you.
Great, thanks.
Was there a gender difference?
Sorry?
A gender difference?
There were too few. We couldn't do that, unfortunately.
Thank you very much. So it's a great pleasure to introduce the last session. And he will present long-term outcomes on the COVIDome study. So, Jan, it's a pleasure that you're here.
Yeah, thank you very much for the kind invitation and also introduction. We still had an issue here with the presentation. So we need to, Vorträge, ist das hier irgendwo? Please excuse the delay. So thank you very much for the kind introduction, also for the opportunity to speak here. So on behalf of my colleagues that worked on the COVIDome and the COVIDome Plus study during the last years, I'm happy to present at least the concept of our study. It's an ongoing study, and we are in the middle of the analysis, and there's also some associated studies that are part and complementary of COVIDome and COVIDome Plus. So where did we start? We started actually in the year 2020 as part of the NUM Netzwerk Universitätsmedizin studies, the NAPCON studies. We had several layers of intensity of disease. So we had critically ill patients and also patients that were patients but did not have a severe disease, which then would be the COVIDome study. And we started to think about this early in 2020, or I have to say my colleague Thomas Barmer and Stefan Schreiber and others from this network started thinking about what may happen following COVID. So they designed this study without knowing that a syndrome called post-COVID syndrome would exist. So this also explains the approach a little bit. And so we started with this in Kiel, Würzburg, and Berlin, recruiting patients following COVID infection, and ended up with approximately 3,600 individuals. And I will not call them patients because it's a population-based approach. So all these individuals were contacted following an infection via the health authorities. So they were not patients presenting themselves in the clinic. And this was then also embedded in the NUM and NAPCON technical setting with a lot of infrastructures, also regarding data management and other infrastructures as well. So there are several publications that already came out of this in the past, and I will try to focus on our findings that are also the basis for the molecular analysis that is currently ongoing. So what were the aims of this COVIDome study in 2020? Actually, we wanted to identify and characterize phenotypes of post-COVID syndrome also with the question, is there such a phenomenon in 2020, since the first patient was recruited in November 2020. So this was really within the first waves of COVID, where we were still struggling about talking about what is COVID, what is the disease, how about a vaccine, for example, and so on. And then also one aim was to identify potential molecular markers and also to characterize the microbiome of potential post-COVID syndrome patients, and to identify long-term consequences of COVID-19 in general. So as you will see, we're still recruiting or having the follow-up of the study, not recruiting patients. So this is the basic organization of the study. So following the infection, at least 6 months after the infection, which was PCR proven, we then planned several follow-up visits until the beginning of 2025. And now we are lucky because we received funding by the BMG to continue follow-up for another 2 years at least, and we will be able to then have a follow-up of sometimes of 7 years, where we have a deep phenotyping of these patients coming from all of these 3 study sites. So I will mention my colleague Thomas here again, because he had a very, very heavy workload in organizing this, also within the pandemic, which was going on when while the study was happening. And we have this infrastructure now in Kiel, where we have this modular approach where each module represents one organ, so to say. So this lung organ, the heart organ, the otorhinol organ, and so on, where we then had specific phenotypic assessments, also neurology, for example, and the total duration of one assessment took 4 to 5 hours in general. So the first step was to develop a so-called PCS score, where we looked at the self-reported symptoms and subsymptoms, also with a lot of scorings and paperwork that the patients or the individuals had to do. And then we tried to actually derive, based upon these self-reported symptoms, a score that would also have the ability to graduate the severity of hypothetical post-COVID syndromes. And you can see here that the most frequent symptom was neurological fatigue, sleeping disturbances, where we also heard today the study that will start only now, where we are also involved, and exercise intolerance, and pulmonary symptoms were rather infrequent, comparably infrequent. This was then the distribution of the identification cohort from Kiel, what we call the Kiel 1 cohort, and you can see that, and then the following cohorts from Würzburg and Kiel 2 as well, and you can see that there is a frequency of between 15 and 20% of severe post-COVID syndrome symptoms, or what we think could be correlated with post-COVID in general. And there were also patients that had either no symptoms at all or mild to moderate. And with this score, we are now having the basis to then analyze all the molecular samples that we have. So we're now looking into transcriptional, cellular immunology, the microbiome, and other markers as well, also in collaboration with a lot of colleagues in Germany and mostly in Kiel, of course. And there was also another hypothesis, because if we now identified a post-COVID syndrome in general, which we are all working on here as well in a lot of cases, is there also a different post-infectious syndrome in influenza, for example, also having this as a control group, and we received funding to have the exact same approach for post-influenza as well, and we are starting to follow up these patients, and we're now able to recruit around 200 individuals, and now the health authorities are sending out letters to a lot of patients or ex-patients in Schleswig-Holstein now again, and this will also feed again into the agenda of Covidom Plus, where we will continue the follow-up. In terms of pulmonary function and dyspnea, we also had the opportunity to have lung function testing, diffusion gas measurements, impulse oscillometry, FeNO measurements, and also we had, of course, the symptom-based scores. And this is only a teaser because the manuscript is being prepared right now. But I can already say that we did not observe a lot of impairment, pulmonary impairment, also in the group of severe, PCS severe patients. We had only quite impressive signal in the oscillometry data, and we will now characterize that in depth. I cannot tell you too much about this, but it's quite interesting also to look at the small airway impairment then, and we are also trying to match that with the ongoing transcriptional analysis, which we will hopefully present maybe next year. We just published a GWAS based upon this cohort. Although it's a small cohort for a GWAS, we still were able to identify a few polymorphisms that were correlated with PCS severity, and one that is also associated with inflammation, with gamma interferon. And we're now trying to further characterize that and put that also into the context of the transcriptional and cellular immunology that we are analyzing right now. So, as I said, this is ongoing, and we're happy to have the opportunity to have the follow-up of another 2 years, and then I think in 1 or 2 years we will be then able to present data of a 7-year follow-up to see what kind of consequences COVID infection had, maybe also in correlation with historic cohorts before COVID in general. And with that, I would like to thank you for listening, also thank the collaborators from the different sites, and in general all the people being involved. And here I would also like to thank Leonard Reinke, who is also deeply involved in the organization, and my partners Philipp Rosenstiel and Stefan Schreiber in Kiel. Thank you very much.
Thank you, Jan. Other questions from the audience? So I start. Have you seen differences at your 3 inclusion points? So difference in Berlin compared to Kiel or Würzburg?
There were differences, but they were not significant. So there was no bias based upon the selection site, no. Not really, nothing that it was really significant there. We had quite a few issues with the echocardiography that I have to admit, and the standardization process, and so I saw the data that was just presented. That would be very nice to take a look at that as well, but that is kind of difficult right now.
Are there questions in the chat? Okay. So you mentioned the oscillometry. So you did it with every visit? Or?
Yes. So one of the questions that we're trying to answer right now is also how is the resilience of the individuals, also in the context of the subjectiveness of the PCS in general. And another thing is, of course, the reversibility of these findings through time. So longitudinally, and the oscillometry findings were quite robust so far, and they could maybe correlate with disease severity in the beginning, which at least pulmonary involvement.
It means your interpretation is that there's something happening in the small areas.
Yeah. We're lacking radiology, unfortunately, in a lot of cases, so that is not perfect. It's not the perfect cohort still, but that may be an explanation.
Okay.
Thank you very much. Very interesting study. Do you also have the linked sequences of the viruses for each of these patients? Would be interesting to know.
No, that is a question that was arising quite a few times. Thank you, Nico. Most of these patients were recruited during the first 2 to 3 waves of infection, but we don't have the actual PCR because they received the letters from the health authorities after being reported. So that sample was not available, unfortunately.
Thanks. So I think we are quite on time. So thank you for your audience. Thank you, the speakers, for perfect talks. And thank you to the DZL for hosting this session. Thank you very much.
Welcome to the next session. My name is Hans-Georg Kreuslich from Heidelberg University, and I'm here on behalf of the German Center for Infection Research. As the name of the center says, obviously there was a lot of refocusing in the COVID pandemic, and there's still a lot of ongoing post-COVID research, and we have 3 interesting and exciting talks given the time frame. I'm not going to take any time away from Maria. The title is already here, so I won't read it. Maria Fereschild, not very far off. She can walk over here from Frankfurt University Hospital. Looking forward to your presentation.
Yes, so this is quite a special day for trials in post-COVID syndrome. You will see why in a couple of minutes. And my task is to explain the challenges to you that come up when you do such a trial. So in short, we have a lot of challenges when we talk about post-COVID syndrome. I think most of you are aware of this. We have high numbers of patients who fulfill the WHO definition, but that doesn't mean necessarily we are totally sure they have post-COVID because the pathophysiology is not fully understood, and we don't have validated biomarkers for its diagnosis. So mainly due to that, we also have no curative treatments so far that are based on scientific evidence, and evidence keeps on emerging very dynamically and has to be integrated into the clinical trials that we are trying to put together. So normally a clinical trial is something that needs a lot of time for planning, a lot of money, and it's extremely rigid. You can't change a lot once you have submitted it to the authorities. That's how it's going to be. And so what we established to change this a bit and to take the emerging evidence into account is a clinical platform trial that adapts to the emerging evidence. What does that mean? It means I have a concept where I can include new sub-protocols to include new drugs that are emerging, and I can also change the randomization ratio of the different arms in my protocol after interim analyses if I see that a certain arm seems to be more successful than another arm. This is the short overview on how this works, but you can already see it's a bit more complex than a normal trial. And at the moment, we are running the Rapid Revive sub-protocol as one sub-protocol attached to our master adaptive platform trial protocol. And we have submitted an application for the second sub-protocol, which will be called ELAPS. And all of this is within the Netzwerk Universitätsmedizin, and here below you can see all the different entities that are contributing to it. This is an immensely complex trial, and you will further see why. So the main objectives are for all the sub-protocols. We want to assess the impact of different durations of antiviral PCS treatment or any other PCS treatment on the overall physical function, and we want to identify biomarkers that will help us to identify patients early that will respond to medical treatment. And in the first protocol, we tried to take the current state of evidence into account, and you are all aware of the fact that there are different pathophysiological hypotheses that are currently supported, and all these different hypotheses have one thing in common. They cause inflammation or they maintain inflammation. So if you can somehow target inflammation, we thought that would be a good thing in this kind of trial. So for different reasons, I stumbled over this drug here, vidofludimus calcium. I had already been PI in a study for acute COVID infection, and there this drug was used, and we had some preliminary data on it, so I was aware of it, and then I understood that it was not only active against SARS-CoV-2, but also against a broad range of other viruses, because it's not a very specific drug. It blocks the viral replication per se. It's from the class of the dehydroorotate dehydrogenase inhibitors, and it also acts with the pyrimidine use of the cells, and that is also how the viral replication is inhibited. It also inhibits lymphocyte activation and cytokine release by that way, and that way it also has a broad anti-inflammatory activity. It's also currently used in a study against multiple sclerosis, and there, in the interim analysis, some nice effects are seen. And this kind of fits because, as you know, multiple sclerosis is also an inflammation-based disease. So the first subprotocol is very simple: 2 arms, randomized, placebo-controlled. Patients are treated for 56 days with a drug and then followed up until day 84, and the physical function is assessed at day 56 for the primary endpoint. Now, what are the challenges? The challenges are exactly what I already presented. There are many hypotheses why people could develop post-COVID. So we are suspecting that really there are different types of post-COVID syndrome, and we are trying to address all these different types with one intervention. And maybe that is not really very realistic, but that's the thing we could do at the time we were planning this trial. And we need to be more differentiated in the future, probably. I hope that from this trial we can learn something that helps us to be that differentiated and pick those patients who will specifically profit. And the same is, of course, true for the endpoint. If I don't really know what the mechanism is and which are the best patients, it's extremely hard to define a good endpoint. Another thing, not very biological, more bureaucratic, contracting times for clinical trials in Germany are quite long compared to other countries. This analysis is not very new, but I'm afraid it hasn't changed much yet. So we have the longest times for setting up contracts for clinical trials. And if you look at the data structure of this adaptive platform trial, I'm not going to explain it to you, but I would think that you agree that it is not entirely simple. And based on this data structure, we have this contract structure. And you can imagine with all these university hospitals, companies involved, it did take a bit of time to establish the framework and then all the subcontracts. So that really cost us a lot of time in the beginning. But once all of these were signed and everything was ready, the recruitment went really well. So the blue curve is what we extrapolated should be happening, and the green curve is what really happened. And you can see that especially in this year, people really caught up to what they were supposed to do. And today we have 149 patients. Maybe in this moment we can include the 150th patients. We don't know. So we will soon have the first interim analysis results. So that also shows us, I mean, this curve that I showed before, this is quite unusual. If you're doing clinical trials, normally your curves are like get this, and you're kind of sad because you expected something else. So it's not very common that you have more patients who actually fit the slots that you can offer than you have staff to take care of these patients. So we were really overwhelmed with suitable candidates. In Frankfurt alone, we had over 400 requests from patients who wanted to participate in the trial, and we don't really have resources to talk to all of them, and this is problematic because you want to have a good institution-patient relationship, and you don't want to not respond to all these calls for help. So we put up a website, we put up emails, every site was mentioned on the website, people could see when they would fit in the study or not, so we tried to give out as much information as possible, but maybe in the future something like a like a patient registry would be helpful that can then be used when a new trial comes up to pre-sort the people that could fit into this trial, because then we can focus more on actually carrying out the trial than trying to talk to interested patients. Another challenge were the sensory devices. We included 2 types of sensory devices because previous studies have shown that this very granular data can help to identify post-COVID syndrome. And we also had questionnaires for patient-reported outcome measures in an app, but it was not as easy as we had thought. So even though all these devices were CE certified, we realized that it's something else when you want to contribute something to a clinical trial that is placebo-controlled and randomized, and that most companies are not aware that this is an entirely different challenge than just putting out a CE-marked device. That is much easier. So we had to discuss a lot how the blinding can be maintained when there is a technical problem and so on. So the first uses were a bit difficult, connections didn't work all the time, and in the end I felt that we were paying a very high price for something that worked only moderately well. So next time I would be extremely careful when picking these companies and really check whether they have some previous experience with clinical trials. So in summary, to not overextend my time, we were successful in implementing the first adaptive platform trial for post-COVID syndrome in Germany in the context of the network University Medicine. We could start and are now successfully completing the first sub-protocol. We requested funding for a continuance with a second sub-protocol that will focus more on fatigue syndromes. And we encountered a series of challenges that I think some of the information we will get from this trial will help to resolve, but that we really have to take into account more when we set up the next sub-protocol. But I think especially for the data safety and the contracting, we now have everything in place, so this will be much faster next time because we can use the same framework. And and also about the patient management, I think we now have learned how to better approach this. This is all from me at this point. I'm very happy to take your questions. And also I wanted to thank all the involved sites and the ZKS Göttingen, which are supporting the quality management of the trial, and all the laboratories, well, all these many people who have made this possible.
Thank you so much, Maria, for giving us an overview of the challenges and how you managed to slowly overcome them with some improvement. Questions from the audience? Just come up. Otherwise, I would have bridged it, but Go ahead.
Thank you for this nice presentation, and I think it's a great success, so congratulations from my side. You just speculated on this register for patients. I think this is a very great idea. Could you speculate a little bit where this could be connected to, because you need an ethical vote for that and so on. So have you some ideas in mind which you could share with us?
Yeah, I do have an idea, but I haven't asked the responsible persons. Maybe a bit unfair. So I know that Oliver Corneli in Cologne, he runs not a patient registry, but a volunteer registry that was initially intended for vaccination trials. But when I thought about it, we would actually need something like that, but with patients, and they could enter their post-COVID syndrome symptoms, and then as investigators we would be able to kind of pre-filter these people and then contact them. I think the main obstacle is probably data protection questions, but I would think that if people consent in a written form to being recontacted and contributing this data, it should probably work.
Yeah, thank you.
Good.
Hi, yeah, thank you very much. I was wondering, with these second sub-protocols, are these different versions of the protocol you already have with the same drug, or does this concern new drugs that will be tested?
That's going to be a new drug, but you could also change something in the protocol that is ongoing. Like in theory, both is possible.
And do you think you will be able to, if you say you keep the same infrastructure, does this mean that you will also keep the same patients, or will it be just easier for you to recruit new patients?
Oh, that's a good question. In theory, the same patients could participate again if they are not feeling better, which I would regret. Yeah, but I think also new patients would come in. It's not necessary to take the same people. It's more about using the same infrastructure and the same sites again, because they now have a routine in performing these trials.
Thanks very much. I think in the interest of time, we would continue. Thank you, Maria. With all the difficulties and challenges of defining post-COVID and pathophysiology, I think most people would agree, or everybody would agree, that immunological aspects do play a role in this and probably play an important role. So we're very happy to have Christine Falk from Hanover here today to talk about immunological aspects of long COVID, depending on initial infection severity before vaccination.
Yes, exactly. So thank you very much for the invitation, and we did this together with the outpatient unit that Tobias Welte started very early in 2020, and I would like to dedicate this talk to Tobias Welte. And Isabel Pink and Nora Drick were the two clinicians who really started the outpatient unit at MHH. The reason we're in the DZIF session is that we started this project with the DZIF funding and also COFONI and NUM, and this was also the starting point to become a member of DZL, which is really wonderful because we're also working in the lung. I would just want to emphasize that the patients defined that there is a long COVID kind of problem and disease, and there are the different phases that we're all aware of. But I would like to emphasize here that the study that we did started really before the vaccination came along, and I think it does just make a difference whether the patients have been exposed to the virus before Omicron and before vaccination. So everything I'm talking about today is about patients who were in the first phase, pre-Omicron and pre-vaccination, and this is something I think it should be considered for the different kind of studies. You all are aware this entire day on the difficulty to define the symptoms, and our clinicians have really done a great job, and I'll show you later on how they try to clinically catch the momentum of long or post-COVID. I would like to talk briefly about the initial severity, which might have a difference immunologically. I would like to then refer on what you've heard today also before, that there's a sustained immune dysregulation, and on autoantibodies that Herbert Schiller was also referring to, just to give you an idea how we try to identify how the immune system is dysregulated in these patients. I just would like to highlight two recent papers. This is from Kiko Iwasaki. What's nice here is that she showed again that there is a dysregulation in lymphoid and myeloid compartments that there are not only high antibodies against SARS-CoV-2, but also other viruses. And I think it's important to mention that many of the post-COVID patients experience reactivation of persistent herpes viruses, and that might be sort of a combinatorial effect. And this is also something that she has seen there, and this is also something that a recent study from Fasin Mashregi from Andreas Radbruch's Institute has seen in children with MIS-C, so the multisystem inflammatory syndrome, because they have seen that TGF-beta is one of the key cytokines that we missed, by the way, to measure. But the important thing is that they propose that in these children, the reason why there is an EBV reactivation is simultaneously the effect of TGF-beta suppressing T cells and at the same time to provoke viral reactivation. And I think we should really consider that SARS-CoV-2 is not alone. Persistent viruses really might have a strong impact on what's happening there. So in our cohorts, we started together with Tobias Welte in the outpatient unit to discriminate between patients with long COVID symptoms who had been hospitalized before in ICU and the mild cases. We also had a transplant cohort and a cancer cohort and a vaccine cohort just to compare the different cohorts. What I'm telling you today is a bit of a glimpse of what we are looking at with these all cohorts of long post-COVID syndromes. Non-hospitalized were the mild cases, hospitalized and the formerly severe ICU patients. And you see here already BMI and other parameters have been different already, so that the patient groups might really differ depending on the original disease, and this is what I would like to highlight here. This is the overview of the outpatient unit with Isabel Pink and Nora Drick, and Tobias Welte really had a strong impact on how this is designed in terms of the evaluation of the clinical status plus the fatigue score, the LRS score, which is then also available in concordance with our blood samples. And we started 6 to 8 weeks ago after the acute infection, which was determined by PCR positivity, and then the 9-12 months follow-up for these patients. So this was again the very early phase, which gave us the chance to really look at them for quite some time, at least 1 year. So I mentioned, and I will just briefly go into this, that there are differences in these three groups. And we realized that there seems to be a dysregulation at the T cell level that has been published also with other groups, so that the naive or the mild cases had more naive T cells compared to the others, which shifts the T cell repertoire towards a memory compartment. And if you look at this graph here, especially the T cell, but also other, especially the myeloid compartments as well, discriminate in immune patterns that are really distinct between these patients, and they are like enriched with the mild cases here seen in gray and orange, and those cases that were more severe, and the formerly ICU patients that you see down in red and here in blue and green. So what we really see is that there is an impact. It's compared to healthy individuals pre-pandemic, and there is a sustained dysregulation at the cellular level. Just briefly to go into more detail, we were focusing here for this talk on the formerly ICU individuals because we had a chance to monitor them and to include the clinical parameters of their long COVID outpatient unit, like lung function, the 6-minute walk test, and the fatigue score, to see whether we find any ideas whether immune parameters would correlate with that. If you look at the unexposed, this is our little cohort, pre-pandemic, non-vaccinated, so zero contact to the virus or vaccination before, and the ICU phase, which was the acute phase, and then those patients, we call them re-ICU, and you see here already that the immune phenotypes are different, and especially the plasma proteins, which is primarily cytokines and chemokines, and I'll show you in a minute what these factors are, but here we correlated them to the lung function as well as to the LAS score. And what you see here is that there are some chemokines and also metabolic or cardiac markers that seem to correlate rather with the lung function. What we did not find from all of these more than 500 individual markers, we did not find one that did correlate with the LRS score, which at least gives me sort of one of the explanations why it might be difficult to correlate immune phenotypes with the fatigue score. What are the immune phenotypes at the cells? Well, we have here an enrichment and in the long post-COVID cohort of those patients who had been in ICU before of sort of have less naive T cells, so the T cell receptor repertoire or the T cell repertoire is not recovering, and then enrichment of terminally differentiated CD8 T cells. We see that also with the acquisition of the sort of late memory marker CD57, so that we really seem to have here a T cell memory-driven phenotype, and with the B cells, I don't show you all of these raw data, it's opposite, they are more naive B cells. So this seems to be a dysregulation in terms of a memory-driven T cell versus a more naive B cell compartment. These are the soluble factors. We looked at more than 100 of those. You see again that the PCA nicely and also the unsupervised clustering separates them. And what do we see here? We do have sustained like chronic inflammation that many of you have seen also in your cohorts, driven by cytokines and chemokines. But in addition, and this is what we have published for the ICU patients in the first phase, they also had a endothelial dysregulation and endothelial injury, and this is something that adds onto the immune profiles. And so we have a sustained pro-inflammatory and also an endothelial injury pattern in these patients that holds on for 9 months at least. So it's really hard to recover, obviously, after intensive care unit stay of COVID. We looked also at autoantibodies, but on a targeted approach. So we wanted to look at autoantibodies against cytokines and nuclear antigens like DNA or nuclear proteins or cytoplasmic proteins. We are missing good targeted assays for the GPCR receptors, which I would love to do because I truly think we should have a look at those. But at least if someone has a good assay, please let me know. And then we wanted to know whether there's any hint of cross-reactivity, and that's what I'm going to show you today. So in these formerly ICU patients, we find that 25% of them have anticentromeric protein autoantibodies and again other antibodies, including anti-IL-1 alpha and anti-BAFF antibodies. And here in blue, you see those patients at their time at intensive care unit. And you see here in purple and pink that there is a follow-up time. And you see that these autoantibodies were there already at ICU and they did not disappear with very few exceptions, meaning that we have no clue whether the autoantibodies have been before they acquired severe COVID, but they were there and then they were obviously not disappearing by themselves. Did they correlate to the lung function? And at least there are some that seems to like the centromeric protein autoantibodies. The numbers are small. We know the limitations are really strong here, but at least we have an idea that this might be the case, that some autoantibodies are associated with lung function, but again, not with the LRS score. So we did find, and we have control cohorts, of course, we did find some subgroups of patients with autoantibodies. And then we wanted to know whether they could be cross-reactive. So this is a subset of patients where we decided to look at that. We have here the patients, and you see here those, and these are the numbers. We tested 40 as a subgroup. At the moment, we are completing the entire group. So 40 patients, and then you see the numbers here of those who have autoantibodies if you test them directly. And then we developed an assay where we just catch the spike and N autoantibodies in the first place and then run the autoantibody assay again, meaning that if they would be cross-reactive, the levels of the autoantibodies should go down because they were captured by the spike or the N protein. And what you see here in this example of proteinase 3 autoantibodies, you see that for 10 of 11 patients, these autoantibodies really go down and only one stays the same. And to me, this is the first idea that we created, that there might be cross-reactive autoantibodies that recognize both spike or N and the autoantigen, which gives probably a link between those targeted autoantibodies. And then we had a control cohort, of course, where we were looking at pre-pandemic individuals, and we had only few with these autoantibodies. And here you see in this example, there are some individuals who do have cross-reactive autoantibodies. And this is the idea that probably there are individuals before the pandemic who had autoantibodies in the first place, and by chance they'd also recognized spike or N. And if so, this would then provoke the sort of autoantigen-driven expansion if you get infected and or vaccinated, because this would be like a second activation of these autoantibodies. So I think we should really try to investigate that. I won't go into detail, but in our hospital there were 3 post-COVID individuals who were sort of trying to figure out what's going on here, and we identified that 2 of them had an infection by N antibodies. But again, with these patients, you see that very nicely here. The autoantibodies are cross-reactive with spike and or N, and you can nicely see that some of these autoantibodies actually are going down after the capture assay. So again, this is very small groups, but there might be a hint that some individuals have cross-reactive autoantibodies. And Maria has nicely shown this figure, which I really like. The reference was just missing by Davis in Nature Microbiology 2023. I really like it because it shows there might be subgroups, and this is sort of my basic message. I'm not sure about the persistence of the virus. It might be, but I would say it's rather rare, but the dysregulation of the immune response is something that many of us have seen. I know that Anna Aschenbrenner was also referring to that. There might be viral reactivation, and I think this is something we should really take into account, that other viruses might come into play. Autoantibodies is something I would love to see subgroups of patients according to their autoantibodies, and again, the neuronal autoantibodies against GPCR are top on my priority list because they would fit to a lot of symptoms, including vascular and endothelial and also energy deficit symptoms and the neurological dysfunction. And with that, this was just a tour de force through our little approach to try to understand long post-COVID. This is my wonderful PhD student, Luisa Ruhl, who did most of the work. I would like to dedicate and remind again to Tobias Welte, and here's Marius Hüper, Isabel Pink, and Nora Drick. And with that, I'd like to thank you for your attention, and I'm happy to take questions as far as my voice is holding that. Thank you so much.
We won't keep it too long, Christine, so the voice will make it. We won't keep you up for another hour, so it should be okay.
That's good.
Go ahead, Susanne.
Thank you. This was really impressive. My question is about the T memory cells that you see in this re-ICU admitted patient group. So did you check whether the memory function is correlated with readmission, or is there any function on this like memory phenotype, or is that just on quantitative level?
So we try to combine that with ICRA assays, so interferon gamma release assays against spike. And there's no direct correlation, which is not surprising. I would not propose that these are the specific ones only, but it just tells us there's also lymphopenic events. So it's not only an increase, these were the proportions. We have the raw cell numbers. So there is still some kind of lymphopenia, and then rather an enrichment of the late memory cells and a disappearance of the naive ones, where we have no idea where they're going and why they're not coming back. So I think we really always need cell numbers, because otherwise you would argue for an increase, which is actually just they stay and the others disappear. Yeah.
Thank you.
Good.
Yeah, excellent talk. I have a question relating to the beginning of your talk. If there is virus reactivation, chronic reactivation, would you speculate, should one derive any clinical action consequences from that?
This is something where I would refer that to the clinicians. It's an observation that many of the long post-COVID individuals have herpes virus, HSV, EBV, sometimes CMV, and sometimes all of them. And you see IgM, which is the hallmark for reactivation. I'm not sure whether I would go into a clinical setting. I would ask Susanne or the clinicians in the room, but it's just something where you could have an added impact on other viruses that might contribute to the symptoms. And if you just focus on SARS-CoV-2, you may not really hit the causative agent. And I would not go more far into detail, because I would love to see that there would be probably studies needed, but I would at least consider that.
Klaus Michael, last question.
Christina, thank you. Short question. In contrast to the adults, children, and we know from our study and that of others, produce a stronger B-cell response with more sustained antibodies, yet the autoantibody phenomena are less prominent.
Yeah, and you know what I think, Klaus Michael? My hypothesis, which I cannot prove, that it's all related to the repertoire. that you have a broad naive repertoire in children that gives a strong response, but it also keeps the balance. And there are work from Fritz Melchers and Harald von Böhmer that there's a feedback loop on autoantibodies. And my hypothesis is it works better in children with their broad repertoire, and the older you get, you have not the naive repertoire, you rely on your old repertoire, and then these are probably more sort of, they have a history, and that makes them more clinically relevant, but this is just an hypothesis. I don't know whether that's true.
Thanks so much, Christine, again, and best wishes for your voice.
Ja, danke.
We continue with immunological aspects and have as a third very exciting presentation from Clara Lehmann from the University Hospital in Cologne, and move from the periphery into the tissue resident compartment.
Yes, thank you. So I'm happy to be here, and really I'm impressed today, all the talks. I think it's a great meeting, and we should really continue in this direction. As already mentioned, there are different mechanisms discussed, and possible mechanisms include autoimmunity, we already heard about it, inflammation, of course, a lot, reactivation of EBV, permanent organ damage, but also viral persistence in tissue reservoir. I think all the different mechanisms are not exclusive, but maybe they are also complementary. And we have to see how we can understand this. And I would like to continue on the topic of the viral persistence. So it is not a new phenomenon. We know from other RNA viruses that there is persistence after acute illness. Especially there have been some RNA identified in different tissues months and also years after infections. For example, for Ebola virus, we know that there have been new outbreaks with carriers, persistent carriers of Ebola virus. But also for the Zika virus, we know that there are some transmissions, sexual transmissions of Zika virus after months of recovery. So this is something which is not new, and there have been several publications about the persistence of SARS-CoV-2 in different body tissues. For example, in autopsy biopsies or tissue biopsies, RNA but also protein has been detected in different reservoir sites. And this is a very nice review which has already been published in 2023 with different tissues, but especially there are 3 publications in the gut in the gut tissues. And so I think what we have to discuss, which role this persistence could have, and how the reservoirs, the potential reservoirs, could contribute to the post-COVID symptomatic. For example, here, this could be one thing that we have a constant immune activation. This is what we have also discussed today with differentiation of T and B cells, but also genetic and epigenetic changes, and also dysregulation of the microbiome. Now I would like to present one project which has been supported by the BMBF. It's Too Long for COVID. And so we have different work packages in patients with long COVID. So we have one part just in the peripheral blood, and then also third part is epigenetic analysis. And the work package I would like to show today is the analysis on the viral reservoir and local immune responses. So why do we look to the gut and especially to the terminal ileum? I have here a nice figure, I think, where you see the total gut. It's really long. It's several meters long and different parts. And you see duodenum, jejunum, ileum, and the colon. And what you can see that the terminal ileum, we have the Peyer's patches. And this is the part where we really have, this is the largest lymphatic organ. And this is why it's really important to analyze this part. But you can imagine it's kind of difficult to reach this part. And I started to work on the gut-associated lymphoid tissue in the field of HIV. And when we talked to our ethical committee, they said, well, you can't do it. It's just too difficult for the patients to do a colonoscopy. And they asked us to do a mapping of the gut to see where we could have the most of the cells in different gut sites. Because they said, well, maybe you could just go to the rectum or the colon. And then this is what we did. It took several months, and then we went back and just showed the data that, well, the terminal ileum is a place where we have to look because this is where we have most of the cells. And so they accepted this, and this is why we always focus on the terminal ileum. So the study design is a cross-sectional controlled studies in patients with post-COVID syndrome and also in patients without post-COVID syndrome. They all needed to have a confirmed SARS-CoV-2 infections at least 3 months prior to study enrollment, and the patients the definition of the post-COVID syndrome was like the WHO definition. So we identified the patients. They were undergoing a colonoscopy until the terminal ileum. We collected samples, and then we just did the incubation of the tissues and collected the supernatant, etc. And at the same time, we also had peripheral blood of these patients. Then next day, we did a density gradient centrifugation, and we have an LPNC layer, so we could do a downstream analysis, flow cytometry, but also immunohistochemistry of all these samples. So our study populations, we had 20 patients with post-COVID syndrome and 23 controls. They were between 22 months post-infection and 15 months post-infection, the post-COVID negative group. Mainly female as usual, and they were around 45 years old. All the patients during the acute phase were just in the outpatient clinic, so nobody was on an intensive care unit. So what did we observe? First of all, we had high rates of spike protein expression in the gut of post-COVID patients. Here you have a nice figure where you see the S protein in a representative patient, and compared to the negative group, we have much more expression of the S protein. Then we also did an immunophenotyping of the gut tissue, and just an overview. So we have a higher T cell frequencies in PCS patients compared to healthy persons. Lower B cell frequencies in post-COVID patients. And especially if you look at the memory cells, we have more central memory cells in the gut compared to in post-COVID patients compared to healthy controls. Interestingly, also we have more plasmacytoid dendritic cells in patients with post-COVID syndrome in gut, and also more mast cells. Moreover, we took the supernatants of the gut and did some cytokine and chemokine analysis. And what we observed is in the supernatants of the guts of the patients with post-COVID syndrome, we had more MMP9, the matrix metalloproteinase 9, in the supernatant of the patients with post-COVID syndrome. So we don't really exactly know what it means, but there are differences which are really significant. So the key findings we have here is that we have a persistent detection of the spike protein in the gut of patients with post-COVID syndrome. We have definitely immune alterations in the terminal ileum with an increase of T cell frequencies and decrease of B cell frequencies, especially central memory cells and plasmacytoid dendritic cells are increased in the gut of patients with post-COVID syndrome. The elevated levels of MMP9 might indicate an ongoing inflammation, remodeling. We are not really sure. Maybe you have some ideas. And so maybe the gut could be a persistent viral reservoir and driver of immune dysregulation. And I think we should also look more for the gut and not only the peripheral blood, because the gut is the main target of the immune system. Happy to take questions.
Thanks very much, Clara. And we have again time for some questions. Christine is already coming up. Susanne is also coming up. Decide who wants to start.
Question is the expression of the spike in the gut that you see, is that spatially correlated with an accumulation of immune cells? And if you look into individual patients, does the amount of spike correlate with these increased immune cells, T cells, and dendritic cells?
Yeah, this is an important question. So we couldn't really correlate the expression of the S protein with an accumulation of different cells, although we couldn't do that. But of course, it's kind of difficult also because the S protein was done on with immunohistochemistry, and the others were with flow cytometry. So it's kind of difficult because maybe the slides are not really representative for this patient. So it's really a big limitation, I have to say. But still, it's there, and so you can really see that the patient with symptoms, they have more detectable S protein in the gut.
So similar to Susanne's question, not surprisingly, did you have a chance to look at the function, to do an IGRA or something like that, an indirect test, whether some of those T cells that you nicely, it's impressive that you have these samples, whether some of the T cells might be specific for a spike?
Yeah, we tried, and unfortunately it's really difficult because we don't have a lot of cells from the gut. So this is also a big limitation. So we tried, but we failed, I have to say. We failed, yes.
Very quick question, Clara. Did you try and did you manage to isolate infectious virus from your biopsies?
So we started with that, but we didn't detect anything, nothing.
Because it could be defective stuff that's still expressed.
Yeah, no, but we didn't detect anything.
All right, I think time's coming up. I think we should continue. I was told I should make sure to stay in time. Thank you very much, Clara. One more time. did my job. And with this, no break, we hand over to Klaus-Michael Debatin for the pediatric session.
Yeah, thank you. Thank you all for really having an exciting session today. Very interesting talks and also very interactive within the consortia that are already existing. I mean, the DZHK, German Center for Child and Adolescent Health, we are, from a pediatric perspective, we are still in infancy because we are just 10 months old, started last June. But several groups that are associated and integrated into the DZHK have already worked on corona, COVID-19 infection for quite some time. And just to mention, there are a few differences between adults and children. The major difference was evident from the very beginning. We all were prepared that the hospitals will be flooded with severely sick children, as we see each year in respiratory syncytial virus infections, influenza infections, but that did not happen. So the clinical course is different in children than it is in adults. That also includes the long COVID situation. And I already mentioned, and also thanks to Hans-Georg Greuslich, who initiated together with me and some other people in Baden-Württemberg, one of the largest family studies, also addressing immune responses. We clearly have shown and could see that in the families, the responses are different. The children, they make more antibodies, and what is more important, they make much more neutralizing antibodies. The response is sustained. They have a different response already in the upper respiratory tract with respect to innate immune system and interferon response, and that together may all explain the different causes. But nevertheless, there are, of course, situations where the infection becomes prominent and also be a disease with long-term effects. Most of the long-term effects, though, that we currently see have something to do with the social deprivation and the problem of closing schools for quite some time. And we have seen it also in terms of infection, because when the pandemic was over, we were overwhelmed by virus infections, severe virus infection in children, and the intensive care units in at least the southern part of Germany, we had really difficulties to distribute the children between the different ICUs because of the severe RSV infection wave that we had that was almost absent for 2 years. Now, with this introduction, we are already into the topic that is multisystemic inflammatory syndrome that was already mentioned during the discussion today, and Tilmann Kallinich from Charité will present the data.
Dear Professor Debatin, dear colleagues, thanks for inviting us for this very exciting symposium. I learned a lot, and I hope you get something from this talk. And it was already introduced by Christina Falk, the study which we have performed in a combined effort from the Charité and the DRFZ. The multisystem inflammatory syndrome, or MIS-C, was first reported in April 2020 by colleagues from Bergamo and London, describing an unpredictable accumulation of cases with a hyperinflammatory syndrome resembling Kawasaki's disease or septic shock. And these authors already described that the symptoms occurred 4 to 6 weeks of a mild or clinically inapparent SARS-CoV-2 infection. And this illustrates that the hallmark at that point was that people found a lot of cytokines. So it was a real hyperinflammatory condition affecting a lot of organs, different organs, especially the heart. And that led to that a lot of people needed supportive therapy on the intensive care unit. Some needed operation. It was really a dramatic time and a strong immunosuppressive therapy. So we, to elucidate a little bit the pathology, we started a multi-center study including 145 MIS-C patients around 4 centers in 4
continents. And we got excited about our first measurement of the cytokines and chemokines in the sera of this patient. What you can see here is that there is a strong elevation of is there a pointer? Sorry.
Here, there's the pointer.
There's the pointer, sorry. That there's a strong elevation of TGF-beta in the sera of these patients. It's just comparable to the levels found adult patients on the ICU, but you see that the sera of influenza-infected children or adults with flu-like symptoms, we did not find an increase in TGF-beta. And this was particularly interesting since we were able to show previously that the TGF-beta levels are also associated with the impaired NK cell function in severe COVID-19, and it's a predictor to be admitted on the ICU. And others have shown that the N protein of SARS-CoV-2 can directly, via the TGF-beta receptor, induce SMUT pathway and the phosphorylation, and this is shown in this slide. Now it's not working. Okay, it's this slide, and you can see that just the serum of the patients with MIS-C induces actually the phosphorylation of SMART2, meaning we are measuring the active form of TGF-beta and not the inactive form. To get a closer look into the immune pathology, we performed single-cell RNA sequencing on pre-sorted cell, meaning we sorted first by flow cytometry the activated T cell by the expression of CD38 and HLA-DR and the monocytes and the memory B cells of 11 patients with MIS-C, and controlled it to children who had COVID and developed no MIS-C after 4 to 6 weeks. And when we looked at the UMAPs, you can see that there are changes in every compartment, meaning the monocytes and the B cells. But I want to focus on the T cells, since we found the most dramatic changes, and there were 3 clusters clearly increased. It's a cluster of the proliferating T cells and the CD4 positive and CD8 positive activated cytotoxic T cells. Now, the next question was whether actually the TGF-beta imprints these T cell population, and therefore we use gene set enrichment analysis, which were previously developed in this paper. And it's a gene set which shows the TGF-induced gene sets, and indeed, exactly, it overlays with the 3 clusters which are also expanded. They are imprinted by the TGF-beta. So next we want to functionally actually address whether we can measure this TGF-beta, has it an effect on the cells, and therefore we use the ARTE assay, and the ARTE assay took advantage of the expression of rapid expression of certain molecules after the T cell is actually activated via the TCR antigen specifically. And with that assay, we can measure the frequency of specific activation of T cells. And for this, we took the PBMCs, paired samples from MIS-C during the acute phase and in the follow-up when they were in remission, and we stimulated that cell with a cocktail of different viral protein, and then measured the frequency of stimulated cells. And you can see actually there is a suppression of T cell activation in the acute phase, which restores after the follow-up. The next question was, is this actually due to the TGF-beta? And for this, we took the same assay, but this time we took the PBMCs from healthy donors and added a sera from acute MIS-C patient, and you can see that again the activation of the T cell is diminished, but we were able to restore it by blocking the TGF-beta. So this shows that the TGF-beta actually has also a functional role by impairing the T cell function in acute MIS-C. So I switched gear. At the beginning of the pandemic, it was quite rapidly clear that by these publications that children with MIS-C express a certain beta chain in the TCR. It's the V beta 21.3 chain. And this is found in most of the children with MSC. It's actually a hallmark, and we can use it as a diagnostical marker. When we looked in our population, that's a population from Europe and from South America, we nearly always found it when we looked on all T cell, but if we just looked on the activated T cell, we actually found it in every child. And the next question was, does this actually overlay again with the increased cytotoxic and proliferating T cell, which are imprinted via the TGF-beta? And you see that this is actually exactly this population. So the next question was, what do they recognize? At the beginning, it was always thought it's a super antigen, but we didn't find, when we just took the SARS-CoV-2 into the culture, we didn't see that there was a vast activation of these cells. So we thought it might be also a virus, and then therefore we performed again this assay, this after assay, using PBMCs, stimulating them with also the peptide pool of the viral peptides, did an enrichment, and then did an TCR sequencing. So we could sequence viral specific TCRs, and then we clustered them in this analysis together with the TCRs we found in the MSC patient. And you see that nearly all TCR which are specific for EBV cluster together with the MSC. That was the first hint that these cells actually are supposed to recognize EBV. We went back in the literature and found this paper where it was with the MHC-class II tetramer technology, found that some patients with a mononucleosis actually have a higher expression also of this V-beta 1.3 chain, and this chain was shown here that it actually detects a promiscuous peptide from the EBNA2 protein, and this was only found in some of the mononucleosis patients, and we thought we bring this on a broader range and looked in adults who had previously been were infected with the EBV, whether the addition of these peptides in two different forms leads actually to the expansion of the V-beta 21.3 chain-bearing T cells, and we could find this in every patient, in every subject we analyzed. So this is another support that actually this specific peptide is be recognized. And I want to make the story short because we did some other experiments to prove whether this is really true, but we also could show, for example, that the V-beta 1.3 positive cells compared to the negative cells, I have a higher capability to lyse EBV-infected B cells and have a higher capacity to degranulate. So this is other supports that these are actually really directed against this peptide. So if this is true, we thought we want to see whether there is a higher prevalence of EBV seropositivity in the cohort, and this is the cohort. This is a pooled cohort from different countries, and this is actually a cohort, a pre-pandemic cohort from the Berlin-Brandenburg area where the seropositivity is shown. And we did a very careful age-matched control, but found that this is significantly increased in the MSC population. But to show more directly the EBV reactivation, we did another approach. We again collected the B cells and plasma cells from 35 patients with MSC and did another single cell sequencing, and every dot you see here is a positive cell currently transcribing the EBV DNA, and this is actually every third 100 cell, and when we compared it to severe COVID-19, a condition where it is known that EBV is reactivated, it's quite the same actually. But it's not true for adults which are vaccinated against SARS-CoV-2 or tetanus, and also not true for healthy controls or mild COVID-19 affected patients. So I want to summarize it. So the TGF-beta mediates temporary immune suppression and EBV reactivation, and we think the child is getting, probably with a certain genetic susceptibility and an infection with EBV. Later it has a virus latency, but then it's getting infected with the SARS-CoV-2. It has this interferon gamma response, but directly through the SARS-CoV-2, also the induction of TGF-beta leads to a T-cell suppression and dysfunction, so meaning these cells, they can't lyse infected cells, but they are still actively producing cytokines and chemokines, and therefore there is a reactivation for EBV, and then the T-cell clone expanded and the hyperinflammation occurs, making the child sick like we have seen it during that time. And it has a potential impact also not for MSC, but probably also for severe COVID-19, and we discussed it before for long COVID and further other hyperinflammatory syndromes. And that is the most important slide showing all the people who are involved. And I want to mention Karl Götz, a clinical scientist who performed the studies in the first author, and the experiments were done in close cooperation with Mir Faschings-Mashregi at the DAFZ, in the third program area for systemic rheumatology, and also Pavel Durek performed all the biostatistical analysis. These are the national and international collaborations and the funding partners, including DZHK, BIH, and the Leipzig Pandemic Preparedness Initiative. Thank you.
Yeah, thank you very much. Interesting talk and an interesting concept. I was actually wondering, I mean, the TGF-beta is something that we already also heard this morning already. When I think about the transplant patients, bone marrow transplant, severe immunosuppression, we see EB virus reactivation, but not regularly. So what controls it in that situation and is obviously not functional in the case of this TGF-beta? Maybe it's a TGF-beta storm that does, in addition to a global immunosuppression, has another effect on the cells.
But there must be another individual reason, that's for sure. Because we saw it at the beginning, every 800 child getting affected, later every 4,000 child. So there must be some other genetically cause which controls it in the, luckily in the majority of patients.
Okay, I don't see any more question. Everyone is already close to be exhausted, but there are going to be two other talks that are interesting in this session, and the next one is given by Ulrike Ravens-Sieberer from Hamburg, and is about exactly something that I already described, that is the consequences of the corona pandemic for children and adolescents during and after the pandemic, which is not so much addressing TGF-beta, but other things.
Yes. Dear colleagues, thank you very much. It's nice to be here. It's already late, but I would like to ask you for a slight change of perception, because I'm not going to talk about cells. I'm not going to talk about proteins. I'm a child public health person, and for the last 20 years, we've been interested in what mental health and also the quality of life of children in Germany, and recently undergoing the pandemic. And so I'm going to briefly show you some results on this. I'm going to introduce to you the COPSI study. COPSI is short for Corona and Psychosocial Well-being, and just after the pandemic started, we were able to relatively soon assess the quality of life and mental health in children and their parents and families, because we had been doing this for the last 2 decades in cooperation with the Robert Koch Institute, who also did a health and examination and interview survey on German children and adolescents, the KICS survey. Some of you might know this. So what are we interested in? So what were our research questions? we wanted to know what is the situation with regard to well-being and mental health in the German children and adolescents, and specifically what impact do crises have on the mental health. So this is the health crisis like the pandemic, but also following crises like wars or financial crises. And then we also wanted to know, I have to put my glasses on because it's hard to see here, what are the main risk factors, and which children are most affected? And also we were interested in what are the resources and the resilience factors, and how can we protect children and adolescents from mental health problems. So here you see the timeline of the COPSI study. You see the baseline, which refers to data that were assessed 15 years before the pandemic, but continuously. And then we relatively soon started after the pandemic began. So the first time point was the first lockdown, the second time point was the second lockdown, and then we covered the whole range of the pandemic until the WHO said that it came to an end. And altogether we asked 2,800 families with children from 7 to 17 years old. And altogether, we also gave 1,700 children a voice. So that was the longitudinal representative cohort study with the different time points. Now, I would like to draw your attention to the pattern of this line, because you can see that when the crisis and the pandemic began, relatively soon, quality of life in the children declined at the first lockdown, and then at the second lockdown, and then while the pandemic continued, it recovered, but it never reached pre-pandemic level. And here I have some from these screening instruments, which are internationally validated. I have just some sample questions. And this is also true for the screening of mental health with the strength and difficulties questionnaire we used. Here you see the same pattern. You see an increase in mental health problems, and then it increases even more, and then it recovers, but it also never reaches pre-pandemic level. So after this, we can now say that at the end of the pandemic, and even now, we have a lot more children that suffer from mental health problems. And if you even look more specifically, like for anxiousness and for depression, you see the same pattern with these lines, although a lower prevalence. If you look over the whole time points, for example, for loneliness, which is a strong indicator that has recently been discussed for the last 20 years, you can see that we started, and then you see the pandemic where loneliness increases in children and adolescents, and then it recovered, and then it decreases again right now, and maybe we can talk about the reasons for this a little bit later. So at the moment, it's about 21% of children and adolescents who report that they very often are confronted with loneliness. You could argue that this is an interview survey, and that might not be true for diagnosis reported by doctors. And this is why we have also looked at secondary data from the health insurance companies. And what you see here is that the waiting time for psychotherapy, for example, doubled during the pandemic, and that the hospitalization among adolescent girls, for example, for anxiety and eating disorders and also depression, has been observed to go up and is almost double right now. We've often been asked how school closures have impacted this development, and with colleagues from the University of Konstantin, we did a study that could show that the impact of school closures on the mental health of children and adolescents is quite high. So they could actually show that each additional week of school closure led to a decline in quality of life and an increase in mental health issues like depression, and also an increase in psychosomatic complaints. Now, as public health researchers, we are very interested to know which children and adolescents are most affected and which suffer most from the crisis. So there is a vulnerable group, about 17% of children and adolescents being at a high risk. And these risk factors are low parental education, parental mental burden, migration, and limited living space. So we could actually show that if all these risk factors occur, there is a 2 to 3 times higher risk for suffering from mental health. And so social status has quite an important role, and it might not be surprising that we see that in most of the children from a low social status, we see the most frequent mental health problems. So there is a social gradient that had been first described by Michael Marmot in the United Kingdom for adults, but it's also true for adolescents. We see that throughout the pandemic, we can see this social gradient, but we do not see that there's a widening gap after the pandemic. So it is quite stable throughout time. And also we've been interested in which are the resources and the resilience factors, especially children with a high risk. And we see that there are some resilience factors, especially family cohesion. And if these apply, there is a 5 to 10 times reduced risk for those children that suffer from a high risk, so that they are not affected by mental health problems. So the question is, now that the pandemic is over, is there a relief afterwards, and is everything good now? And what we see is that the worries continue, but they change. So the children and adolescents are not worried about the pandemic anymore, but there are other crises like climate change, like war, like financial burdens that have quite a high impact. And this is also in line, these findings are in line with a paper from the Lancet Psychiatry Commission on Youth Mental Health. And they examined the development of mental health in 5 different countries like Australia, like England, and others. And you can see that throughout all these countries, there is a rise of mental health prevalence problems for boys and for girls and for all ages. So this is very much in line with our findings in Germany. So what about long COVID? I've not talked about long COVID so far because it's a population survey, but what we have done is in 2024, we asked the parents whether their children had undergone a COVID infection and whether there is a diagnosis for long COVID. And what we see is that in our population, nearly 80% of children underwent the infection, and more than 8% of the parents reported that the children had been diagnosed with long COVID by a doctor. So the question is, does that make any difference in symptoms? First of all, we see that on average the children with long COVID are older, and that they come from families with a lower socioeconomic status. There is no gender difference, and we see that they suffer much more from multiple health complaints like the ones we've heard about today already for adults. So this is fatigue, but it's also lack of concentration, it's lack of sleep and headache, backache, and others. So altogether we could say that even in the population sample, our analysis show that the children with long COVID diagnosis have significantly higher mental health problems. They suffer more from depression, they show more symptoms of multiple health complaints, and they have a lower quality of life, but anxious symptoms remain the same. Now the question is, what were and what are the political reactions to this data, because we have been the first cohort study in children that showed that the pandemic had an effect on the mental health, and more than 1.5 years after the pandemic started, there had been the first reaction, like the German Ethics Commission said that there should be solidarity with the children who did a lot to protect the older people, and other initiatives. And just recently, child and adolescent health, there was more focus on child and adolescent health, why the German Center for Child and Adolescent Health was supported. And also just recently, last week, there was the first symposium on long COVID in children and adolescents, and there's a research network, and so I know that in the next talk you're going to hear about that and about long COVID in children and adolescents. And with this, I would like to thank you for your attention, and if you would like to read all the results, there's this QR code, and I hope I haven't used my time up. Thank you.
Actually, in one of the data, we have shown that feeling lonesome during the was data from during the
loneliness
is much more pronounced in girls than in boys.
Yes, and depression also. So that what we see during the pandemic is that especially girls got hospitalized more in child and adolescent psychiatry due to depression and eating disorder.
Christine.
Thank you very much for the COPSI study in general, because I think this was really the first highlight that how the children and adolescents were reacting, and that they have really such a lot of socioeconomic problems was underestimated. So this is my first comment. My question to you is, you showed your survey in 2024, and you showed that only 80% were infected. Is that monitored at the moment? Because I think that basically it's sort of whether the children are tested for SARS-CoV-2 or whether it's just a normal flu might just depend on, I don't know, maybe just personal preference. So how do you know? Because my perception was that maybe all of the children at some point at least get infected once, but I'm not sure whether this is...
Yeah, absolutely right. Yeah, we would love to know that in more detail, but that was not possible within this survey. This is just parent-reported, administrated prevalences. So we need to rely on the report of the parents. But you're absolutely right. We would love to have had blood samples.
Giovanni Vardiero.
I learned before that the respiratory viruses are even more harmful for children and being focused on COVID, but what is the effect of these infections? Is there a difference in the perception also of these infections?
In the perception of these infections? I'm sorry, it's so hard to hear up here. Sorry.
Yeah. So the respiratory viruses, I learned from Klaus Knoch in the coffee breaks, are much more severe from the pathophysiology, means that the symptoms and all.
Oh, yeah,
but
okay.
they seem to be not
investigated. Yes, absolutely.
COVID is, of course, something everybody talks about or was talking about.
Yes.
While a severe infection is just, you have a flu.
Absolutely.
So maybe it's just also the perception of the children which makes difference, not the pathological impact. This is what I wanted to...
Yeah, you're absolutely right. The thing is that we looked at COVID and we looked at the COVID infection and could just take the reported outcomes. But what you say is really a plea for a much better health monitoring in children and adolescents. So this is hopefully going to be set up within the next couple of years by the Robert Koch Institute, and then these differences can be made. It's just not, with our study, we were actually happy that we could start at the first lockdown because we had the measures in place, because we had been doing it before, but it's not such a general health survey that we could conduct. But you're absolutely right.
Perception clearly plays a role. In our Baden-Württemberg study, we have analyzed 1 year after primary infection the families. And the symptoms, broadly considered long COVID, in the families match between adults and children. So if the adults have reports a pathology, children tend to report also the pathology. So there seems to be an effect. I mean, you can argue it's the virus that spreads within the family, but it's even children that have not been infected report on symptoms, so there is something going on in addition to just virus and TGF-beta and cytokines. Okay, thank you very much, Helene Ulrike. We're coming to the last presentation. By Nicole Töpfner von Dresden, who actually catches up in setting up a study on long COVID in children, just started, BMBF funded.
Thank you very much, and I'm happy to talk today about pediatric long COVID. And I'd like to hear a bit more about your background. Who actually is involved in pediatric long COVID care? Maybe can you just lift the hand? And who is involved in pediatric long COVID research? So maybe there would be many opportunities to cross-link this in future so that we come in interaction with each other. As you maybe all remember, it took very much longer for the WHO to define long COVID, post-COVID condition in children and adolescents compared to adults, because it was finally fixed in February 2023 based on an expert consensus, so that symptoms occurred within the first 3 months after confirmed or probable SARS-CoV-2 infection and have persisted for at least 2 months. So it varies a bit from the adult definition. Here you see data from the UK Coronavirus Infection Survey, self-reported frequency of long COVID in children, and you do see that the young adults reported a frequency between 1 and 1.5%, whereas the adolescents are around 1%. And frequencies between 0.2 to 0.3% of people reported significantly restricted daily activities. This age dependency was actually confirmed also by the US-American data, so that in the pediatric cohort, the young adults and the adolescents were mainly affected by long COVID. And these are data from our German cohorts, derived from the pediatric part of the Immune Bridge project of the Network University Medicine. Here the CORKID cohort from North Rhine-Westphalia, presented by Jakob Höppner. So that at least if you take all symptoms together, there was a differences if the children were either vaccinated or infected by SARS-CoV-2 measured by antibodies in comparison to children without any SARS-CoV-2 contact. In a time where this was still in discussion if long COVID actually exists at all in children and adolescents. Here are data from Dresden and the Pointed Consortium, Jochen Schmidt, and our pediatric approach to assess the relative risk of symptoms 3 and 12 months post-documented diagnosed SARS-CoV-2 infections in a very, very large control-matched study. But now I'm from pediatric in Germany. So based actually on the Cover Child project in the network University Medicine and on many roundtable discussions, it became more and more clear and consented that the prevalence in children and adolescents of pediatric long COVID was lower, but with a higher vulnerability, because the adolescents were mainly in the stage of qualification for final exams, for university degrees or jobs. So there were special psychosocial needs, but also existing special care structures, e.g. the social pediatric centers exist in pediatrics who could care or offer care for the severely affected adolescents with long COVID and ME/CSF. So based on a call of the Bundesministerium für Gesundheit on the model approach for long COVID, beside 3 other pediatric projects, PETNET LC got funded by 41 million euro, headed by Uta Behrens and me as a co-leader. And by now PETNET LC aims at a pediatric network for the care and research of post-acute consequences of COVID-19 and similar post-acute infectionation syndromes and ME/CSF. So just 3 days ago, there was a kickoff of PETNET in Berlin, and we just start the establishment to achieve a timely, customized, and sustainable state-of-the-art care for children and adolescents with long COVID-like illnesses through the use, evaluation, and further development of knowledge, experience, and infrastructure. PETNET consists of 20 CCCs, comprehensive care centers, with pediatric and child and youth psychiatrists involved, 2 pediatric pain clinics, 3 pediatric rehabilitation clinics, and 8 research institutes. And there's close synergy and involvement of healthcare providers, GPs, outpatient pediatricians, specialized association, professional associations as the BVKJ, the DGKJ, DGPI, patient organizations and foundations. Here you have an overview about all involved clinical and scientific partners. And there are a lot of the partner sites of the DZKJ also involved. And all DZKJ partner sites are involved to make up the base research and care structure for chronically ill children. There are also synergies with other DZGs like DZIF, as PETNET is actually based on the IMUC cohort of Uta Behrens, founded in DZIF long time ago. What is the focus of PETNET now? So we will focus from the pediatric side on complex long COVID with participation deficit, especially PEM and ME/CSF. Just to give you a short glimpse of the work package, besides general coordination, of course, there will be huge packets on patient, parent, and public involvement. We will set up a national CCC based on evidence, research, and knowledge translation to design FAQ sheets specialized for adolescents and young adults, SOPs, guidelines, education programs for staff, teachers, and patients. And we will perform a nationwide expert board for very complex patients, which are also discussed and need to differentiate it from child abuse and all other conditions, sometimes mixed up with a clear case definition of long COVID and ME/CSF. So there will also be federal and local CCCs established to adopt the local care to the national standards. There will be a huge school project involved to early assess the school attendant problems and to optimize it. There will be a telemedical infrastructure with existing structures established and specialized for long COVID care, so cross-sectional, the PET expert of the outpatient pediatricians, and intersectoral in between each other by telemessenger. There's a huge research infrastructure started to be established or already established and optimized now, so with this, that each study center, so each CCC will include all pediatric patients by the same case definitions into the register. And there will also be a biobank adapted to this register, where we are already in exchange with the DZIF SOPs and the DZL SOPs to also make a homogeneous biobanking for the children and adolescents. There will be a huge opportunity for register-based studies. By now planned, there will be a study on breathing disturbance and sleep disturbance on CMRIs and genetics. There will be the perspective of healthcare providers assessed and health economic analysis by linking the register and health insurance data. So furthermore, we also focus on synergies deriving, e.g. from the Baden-Württemberg funding, which Herr Debatin mentioned, or the funding in Schleswig-Holstein and Bavaria, or the Innofond project Kids Care PVS. So with PetNet LC, we aim on the dissemination of results and sustainability. We like to establish and maintain a cross-sector interdisciplinary interprofessional care network with reusable research and supply data and interoperability. We will provide information materials on long COVID and recommendation for actions in pediatrics and aim on nationwide health literacy for actually in the end hoping that we'll find the best and effective treatment for adolescents suffering from severe forms of long COVID and ME/CSF, to then go into discussions with social insurance providers that they maybe implement this in standard funding sometimes in future. So I thank all of the people involved in PetNet and the other pediatric projects in the BMG consortium now, and I'm happy to take your questions.
Thank you very much. So you appreciated that this has just started, but will be definitely an enterprise where we then get more information than what we already have on the long COVID situation in children and adolescents. Questions, comments? If not, then thank you very much again. Thank all of you for contributions of the day, and I hand over the mic now to Stefanie.
So thank you very much. We just need to prepare for the panel discussion. Let me thank all the speakers for the scientific sessions. And now in the last half hour, we will have in German a discussion with our patients. Dann würden wir auf Deutsch wechseln. Und wie gesagt, ich würde zunächst ganz herzlich unsere Panelists begrüßen und vor allem Frau Theobald, Johanna Theobald. Sie studiert in Mainz mit Medizin. In welchem Semester konnte ich jetzt nicht rausfinden, aber das erzählen Sie uns vielleicht noch selber. Sie war selbst betroffen oder ist selbst betroffen und sie vertritt aktuell als Sprecherin Long-Covid Deutschland. Sie ist Gründerin der Selbsthilfegruppe und hat jetzt auch sehr viele Aktivitäten unternommen, um insbesondere die Versorgungssituation von Long-Covid-Betroffenen zu verbessern. Und ich denke, ich gebe das Mikrofon einfach mal an Sie zunächst und lasse Sie sich kurz vorstellen. Und vielleicht können Sie auch sagen, warum Sie motiviert sind, heute hier zu sein und was Sie an Fragen an uns haben.
Ja, vielen Dank für die Einführung. Genau, wie gesagt, also ich studiere Medizin. Ich starte nächste Woche ins praktische Jahr. also habe gerade mein zweites Staatsexamen hinter mich gebracht. Und ich bin inzwischen nicht mehr betroffen, also ich habe zu den Glücklichen gehört, die früh infiziert waren und bei denen das innerhalb weniger Monate folgenfrei ausgeheilt ist, also nicht die Gruppe, über die wir hier eigentlich sprechen. Und aus dieser Erfahrung raus trete ich jetzt eigentlich als Vertreterin für Betroffene auf und nicht mehr als Betroffene selbst, die das hier wahrscheinlich gar nicht stemmen könnten, so einen Tag. Genau, ich habe die Selbsthilfegruppe in Mainz gegründet und in den letzten Jahren schon über 200 Leute dort begleitet, arbeite auf Landesebene an einer besseren Versorgung und eben für Long-Covid Deutschland auch bei Projekten, wo Hilfe gebraucht wird. Und erstmal vielen Dank an alle Sprecherinnen und Sprecher heute, an alle, die gekommen sind und sich für das Thema interessieren, an diesem Thema forschen. Es ist ein Thema, das bei dem absolut Handlungsbedarf besteht und es ist sehr ermutigend zu sehen, wenn Menschen zusammenkommen, die sich beruflich mit diesem Thema beschäftigen. Und ich denke, wir können alle gemeinsam daran arbeiten, dass dieses Forschungsfeld attraktiver wird, dass Hürden, die vielleicht noch bestehen, abgebaut werden. Und was uns als PatientInnenorganisation natürlich ein riesiges Anliegen ist, dass sie Betroffene involvieren in ihre Forschung, möglichst von Beginn an. Es gibt häufig PatientInnenbeiräte, vielleicht kommen wir später auch noch mal auf ein paar Details zu sprechen, aber das ist uns wirklich ein großes Anliegen. Das ist keine zusätzliche Bürde, sondern das ist eher eine große Hilfe auch für Sie in der Forschung, weil die Betroffenen sind natürlich die Spezialisten für ihre Erkrankung, die können Ihnen schon bei der Planung der Studien behilflich sein und damit dann auch letztendlich das Outcome verbessern.
Vielen Dank. Zunächst würde ich jetzt an Werner Seeger wieder zurückgeben. Vielleicht könnten wir noch ein zweites Mikrofon haben, dann wird es ein bisschen weniger schwierig. Nicht so gut? Okay, dann kriegen wir es auch so hin. Dann gebe ich an Werner Seeger, der unseren zweiten Panelisten vorstellt.
Ja, Martin Walter vorzustellen wäre ja eigentlich nicht nötig, denn er war wegen der neuroimmunologischen Forschung ja schon hier auf dem Podium heute. Alphabetisch habe ich gelernt. Ja. Halle. Eigentlich hätte man gedacht, ja, vielleicht Halle, Magdeburg, Jena. Aber nein, es geht alphabetisch. Das ist, glaube ich, das. Wo soll ich zuhalten? Hört man mich? Könntest du nur oder ohne Mikro, also das kriege ich. Also jetzt sind Sie hier ja in Ihrer Funktion als Präsident des Ärzte- und Ärztinnenverbandes Long-Covid. Und ich denke, die meisten hier im Raum, mich eingeschlossen, sind ja mehr so primär forschungsorientiert und natürlich DZG integriert. Wir wissen sicherlich relativ wenig, was dieser Ärztinnen- und Ärzteverband Long-Covid macht und vielleicht können Sie da einfach etwas mal zu sagen, weswegen, das ist ja schon klar, ist er gegründet worden, aber was macht er, welche Aktivitäten unternimmt er, einfach mal so ein bisschen, damit wir ein Bild davon bekommen.
Ja, vielen Dank, sehr geehrte Damen und Herren. Ich freue mich, den Ärztinnen- und Ärzteverband hier vorstellen zu können, der sich 2021 gründete, damals auf Initiative des Bundesgesundheitsministeriums unter der Führung von Frau Frommholt, Frau Scheibenbogen war ebenfalls mit dabei, Frau Lehmann haben wir heute schon als weitere Vorstandsmitglieder hier gehört. Wir haben uns zu einem Zeitpunkt zusammengefunden, als das Verständnis allseits langsam ein bisschen deutet, dass man klinisch auf jeden Fall etwas tun muss, dass es aus den eigenen Fachgesellschaften noch vergleichsweise wenig gab und dass es wahrscheinlich keine prädestinierte Fachgesellschaft geben wird, die es in besonderer Art und Weise insbesondere des Post-Covid-Themas annahm. Es war zu einer Zeit, wo auch noch sehr viel Unsicherheit war, handelt es sich wirklich um ein echtes Syndrom, was davon ist vielleicht eingebildet, übertrieben oder auch unter- oder überschätzt. Das heißt, wir haben uns in einem Zeitpunkt gegründet, um erstmal dieser Frage nachzugehen, was ist eigentlich dran, was kann man sagen und was sollte man bitte dann auch mit aller Klarheit sagen? Denn es gab ja auch sehr laute Stimmen, die das ein Stück weit in Frage gestellt haben und da ein bisschen ein Common Sense, ein bisschen Wissenschaftlichkeit und eine vernünftige Datenbasis auch in der öffentlichen Diskussion zu schaffen. Das war die primäre Intention und in besonderer Art und Weise die Interdisziplinarität hervorzuheben. Wir haben festgestellt, allein innerhalb der Ärzteschaft sind wir es gar nicht so sehr gewohnt, über Dinge zu sprechen, die wir nicht klar zuordnen können. Jede Fachgesellschaft, jede Fachlichkeit hat in gewisser Weise ihr Set an Erkrankungen, wo wir uns zuständig fühlen. Auch interdisziplinär wissen wir relativ klar, wo wir bei welcher Erkrankung was beizutragen haben. Ich bin Psychiater, weiß also auch, wo meine Grenzen sind. Und es kommt eine neue Erkrankung, bei der zu diesem Zeitpunkt die Patienten eigentlich gehört haben, egal welchen Arzt Sie gefragt haben, die Antwort war immer, bei mir sind sie falsch. Und das war zu einem Zeitpunkt für die Patienten sehr unbefriedigend und für uns als Ärzte auch ein Stück weit schwer zu verstehen. Ich als Psychiater bekam regelmäßig Patienten vom Neurologen überwiesen, der mir sagte, Mensch, ich als Neurologe weiß, das hier ist nichts Neurologisches, das ist was für den Psychiater. Und ich als Psychiater kann sagen, der sieht zwar depressiv aus, aber für mich ist der garantiert bei allem, was ich als Psychiater sagen kann, nicht das, was wir gesunden Fachverstandes als depressiv bezeichneten. Das heißt, wir sind ein Stück weit als Gesellschaft, als Vorstand der Frage nachgegangen, wie nähern wir uns letzten Endes dieser vermeintlich neuen Krankheitsentität, wie schaffen wir es, den interdisziplinären Dialog herzustellen, wie schaffen wir es auch ein Stück weit, die Kommunikation aus der Fachlichkeit in die Öffentlichkeit, in die Politik zu gewährleisten. Und das erklärt auch ein Stück weit, dass unsere Kongresse, vielleicht hat der eine oder andere davon gehört, wir haben 2022 und 2023 Long-Covid-Kongresse in Jena organisiert, die sehr partizipativ waren. Und ein Stück weit wurden sie auch dadurch partizipativ, weil wir in dem Moment, wo wir die Tür aufgemacht haben für Betroffene, Angehörige, politisch Interessierte, kam so ein Ansturm und so ein Wissensbedarf und so ein Bedarf an Austausch auf uns zu, dass wir festgestellt haben, das haben wir wahrscheinlich gar nicht so vorgesehen, aber das Maß an partizipativer Diskussion über das Thema, was kann die Wissenschaft der Öffentlichkeit sagen, was kann die Öffentlichkeit der Medizin als Handlungsauftrag mitgeben, das schien damals wahnsinnig wichtig zu sein. Und soweit ist ein Stück weit dieser Post-Covid-Kongress als Interaktionsforum wahrscheinlich auch ein bisschen unsere Aufgabe gewesen. Wir haben im Rahmen der Interdisziplinarität versucht, auch uns in Form von Statements zu äußern. Ich bin als Vertreter des Verbands auch beim runden Tisch regelmäßig mit dabei. Aber im letzten Endes ist, glaube ich, auch ein Stück weit die Aufgabe des Ärztinnenverbands weniger geworden. Inzwischen, glaube ich, wissen wir alle, wovon wir sprechen. Wir sehen alle Fachlichkeiten nicht nur selbst tiefer eingestiegen, sondern auch enger zusammengerückt. Insofern bin ich auch gespannt, wie wir uns zukünftig neue Aufgaben suchen können.
Ja, vielleicht darf ich dann die Diskussion eröffnen, nachdem wir die Vorstellung gehört haben. Ich möchte auch ganz deutlich das ganze Auditorium begrüßen, Fragen zu stellen. Also bitte nicht zögern, vor allem wenn hier noch Betroffene sind, gerne Fragen auch an die Panelists stellen. Ich darf vielleicht dann Frau Theobald die erste Frage stellen und die Frage nach dem heutigen Tag ist natürlich, was wünschen Sie sich für die Patienten, Betroffenen, was wünschen Sie sich besonders von den DZGs?
Ja, also wie eben schon angeklungen, natürlich sehr gerne bei allem, was Sie tun und forschen, eine Patientenbeteiligung. Das ist uns ein großes Anliegen. Es gibt schon im DZHK und im DZIF einen Patientenbeirat und ich weiß gar nicht, ob das allen bekannt ist, aber die stehen sehr, sehr gerne zur Verfügung, angeschrieben, angefragt zu werden, beratend zur Seite zu stehen. Und es wird auch ab Sommer im DZG einen Patientenbeirat geben. Daher wirklich die Einladung an alle, wenn Sie Studien planen und aufsetzen, Projekte, die Patientenschaft in alle Schritte zu involvieren. Wie schon gesagt, das sollte für Sie ein Benefit sein und keine Hürde. Ja, außerdem denke ich, können wir gemeinsam daran arbeiten, wie schon erwähnt, die Attraktivität des Forschungsfelds weiter zu erhöhen. Also Stigmatisierung betrifft oft nicht nur Betroffene, sondern auch Forschende. Und wir wollen ihnen gerne dabei helfen, Hürden abzubauen und sie dazu ermutigen, die Forschung weiter voranzutreiben, zu festigen über die nächsten Jahre und Jahrzehnte. Und es betrifft nicht nur die Post-Covid-Forschung, sondern generell postinfektiöse Syndrome. Für uns wäre es natürlich auch toll, wenn postinfektiöse Syndrome fest in den DZGs verankert werden könnten. Also wenn das Ganze ein festes Budget bekommt und nicht on top neu dazu kam in den letzten Jahren, sondern wenn es feste Budgets gibt, die ausgeschrieben werden und für die sich dann Projekte bewerben können. Vielleicht sogar als Querschnittsthema über mehrere Zentren übergreifend. Wir haben eben schon erwähnt, die Interdisziplinarität ist wirklich ganz, ganz hoch angesiedelt bei diesem Krankheitsbild und ganz wichtig. Und deswegen wäre die DZG eigentlich prädestiniert dafür, die Forschung zu koordinieren, zu bündeln. Ich könnte mir da vielleicht vorstellen, ein Koordinationsbüro in einem Zentrum einzurichten und auch so Treffen wie heute, wo Beteiligte in Austausch kommen können, wo Vernetzung stattfindet. Das wäre uns auch ein großes Anliegen, dass sowas einfach mit einer gewissen Regelmäßigkeit passiert, damit wir Synergien auch oder damit Sie Synergien nutzen können, damit keine Redundanzen entstehen von Projekten, die vielleicht doppelt oder dreifach irgendwo laufen, dass wir wirklich die Projekte auch gemeinsam zusammenbringen können. Das wäre uns ein großes Anliegen. Ich denke, Deutschland hat da schon eine wirklich große Rolle in der Welt und kann da wirklich Vorreiter bleiben und noch größerer Vorreiter vielleicht werden. Und da sehe ich das DZG eigentlich als Top-Stelle, um das zu bündeln.
Darf ich mal einmal nachfragen? Das interessiert mich jetzt mal. Sie sagten Stigmatisierung nicht nur der Patienten, sondern der Forschenden. Erleben denn Forschenden beide eine Stigmatisierung nach dem Motto, um so einen Quatsch sollte man sich nicht kümmern, ich übertreibe jetzt? Oder wie habe ich das verstanden?
Also ich bin selbst keine Forschende, ja, aber ich kann mir durchaus vorstellen, dass es eben auch immer noch ein Thema ist. Ja, wie gesagt, um so einen Quatsch sollte man sich nicht kümmern oder es sind Fördergelder vielleicht noch nicht verstetigt. Es ist immer noch ein sehr offenes Thema. Die Pharmaindustrie ist auch noch nicht so auf das Thema aufgesprungen, ja, sodass ich mir durchaus vorstellen könnte, dass es vielleicht im Vergleich zu anderen Forschungsfeldern, gerade für junge Forschende, nicht ganz so attraktiv ist. Also das kann ich mir schon vorstellen.
Ja, ich kann die Perspektive ein Stück weit teilen. Ich glaube, wir haben eine ganz kritische Phase ein Stück weit verlassen. 2022 würde ich sagen, das war wirklich ein vermintes Terrain. Da haben wir Vortragende mit Personenschutz zu uns ins Venue gelassen. Der Ministerpräsident von Thüringen musste durch den Hintereingang das Gebäude betreten. Wir mussten diverse Zugänge schützen. Draußen fanden 2 Gegendemonstrationen bei laufendem Schnee sozusagen statt. Diese Zeiten haben wir glücklicherweise überwunden. Aber auch bei der zweiten Post-Covid-Konferenz fanden im Vorfeld noch massive polemische Diskussionen auf Fachtagungen verschiedener Disziplinen kurz vorher statt. Ich als Kongresspräsident fand mich sogar mit Foto auf diversen Vorträgen, wo ich mich ein bisschen gewundert habe. Ich war dann das gute Beispiel dafür, wo schlechte Psychiatrie landen könnte. Auch das, hoffe ich, haben wir zwischenzeitlich ein Stück weit überwunden. Aber nach wie vor, glaube ich, ist Post-Covid nicht sexy. Also ich muss sagen, nach dem heutigen Symposium hat sich das ein Stück weit für mich gewandelt, mit dem Bekenntnis der DZGs hier klar die Forschung ins Zentrum zu stellen. Denn das hat ein Stück weit auch gefehlt, kann sich das auch viel selbstbewusster präsentieren. Bislang waren die meisten Post-Covid-Symposien entweder innerhalb einer Fachgesellschaft, wo die Hälfte sagte, glaube ich, und die andere sagte, glaube ich nicht. Aber nicht so sehr, dass die geballte wissenschaftliche Kompetenz mal sagt, was können wir denn aktuell formulieren. Und unsere Kongresse waren halt notwendigerweise partizipativ, aber daher zwangsläufig nicht sehr wissenschaftlich. Und das hat sich indirekt auf die Wissenschaftler übertragen, die natürlich versucht haben, sich auch so auszudrücken, dass die Öffentlichkeit sie versteht. Und das hat tragischerweise teilweise dazu beigetragen, dass partizipativ orientierte Kollegen als oberflächliche Forscher diskreditiert wurden. Und ich glaube, Sie haben heute hier allesamt mit dem Symposium dazu beigetragen, zu zeigen, dass es eben auch Spitzenforschung im Bereich von Postinfektionssyndromen geht, die man durchaus auch nicht nur in Spitzenjournals publizieren kann, sondern wo man auch wirklich Akzeptanz herstellen kann. Und ich denke, das ist etwas, das können wir nicht als Ärzteverband leisten, das können auch nicht die Betroffenen leisten, das muss durch die Wissenschaftlichkeit erfolgen. Aber ich finde, dadurch, dass man weiter partizipativ zum Beispiel auch die Angehörigen mit einbezieht, schaffen Sie sich auch ein Stück weit einen Leumund dafür, dass nämlich auch die betroffenen Verbände zukünftig besser unterscheiden zwischen akzeptierter Forschung und ich glaube, es macht einen großen Unterschied, ob auch ein betroffener Verband sagt, nee, wir waren da, das war durchaus sehr ansprechend formuliert und nicht jeder, der sich in irgendeiner Weise äußern kann, wird gleich gehört. Und ich glaube, das ist das, was aktuell gerade stattfindet. Das heißt, das Forschungsfeld wird erwachsen.
Vielleicht eine Nachfrage. Wir haben gerade gesprochen, Long-Covid, Sie sagten jetzt schon Postinfektionssyndrom. Wäre es nicht vielleicht auch eine Möglichkeit, sowohl für die Patientenvertreter als auch für uns als wissenschaftliche Community, nicht das nur als Covid-spezifische Sache zu sehen, sondern ein bisschen breiter zu denken und damit auch dem Forschungsfeld so einen gewissen Rahmen zu geben und auch aus dieser transienten Covid-Phase, will ich jetzt mal sagen, rauszukommen? Wie sehen Sie das als jetzt aus Patientensicht und aus Ärztesicht?
Ja, also aus unserer Sicht unbedingt. Wir treten auch schon dafür ein, dass quasi das Ganze nicht nur auf Covid reduziert wird, weil wir haben wirklich ME/CFS nach sehr vielen anderen Ursachen und es wird so sein, dass die nächste Pandemie kommt und auch die kann uns ähnliche Probleme machen. Dann sollten wir erstens besser vorbereitet sein und zweitens auch im Nachgang das Ganze besser begleiten können. Von daher wäre das von unserer Seite unbedingt erforderlich oder ja, sehr begrüßenswert, das direkt mitzudenken. Und wenn wir da Strukturen schaffen, zum Beispiel koordinative Strukturen oder Gelder, dass die direkt für postinfektiöse Syndrome inklusive ME/CFS geschaffen werden und nicht nur für Covid reserviert sind, unbedingt.
Also dem würde ich mich anschließen wollen. Wir haben zum Beispiel auch aus dem Grund bereits 2023 den 2. Kongress in seinem Titel erweitert und von Postinfektionssyndrom gesprochen. Ich glaube, auf der einen Seite ist es insbesondere dafür wichtig, dass die Haupterkenntnisse von Post-Covid vielleicht gerade anderen Diagnosen besonders helfen können, denn wahrscheinlich wird es neben dem Covid-Syndrom auch andere Infektionen geben, die in nächster Zeit sehr viel häufiger auftreten. Es gibt aus den Post-Covid-Zentren heraus gestützte Initiativen, die zum Beispiel dann Community-Acquired Pneumonias zum Beispiel auch als neues Modell nehmen, wo man bewusst sagt, jetzt gehen wir mal aus den Lehren von Post-Covid weiter und schauen, was wird uns in den nächsten Jahren in besonderem Maßen betreffen. Das halte ich für sehr sinnvoll. Ich als Psychiater, nicht als Infektionsforscher, frage mich ein Stück weit, wo ist die Grenze davon, sollte man sagen, naja, wir haben in besonderem Maß nun mal diese Riesenpopulation von Menschen, die innerhalb eines sehr kurzen Zeitraums nahezu gleiche virale Exposition hatte, die alle auch gleichzeitig angefangen haben und insofern schon eine spezifische Kohorte für mich darstellt. Und ich frage mich in Zukunft, wie bilden wir beides ab? Auf der einen Seite diese vergleichsweise homogene, kurz zum gleichen Zeitpunkt infizierte Kohorte, die man für sich mit Spezifika untersuchen kann, und auf der anderen Seite eben die Ausweitung auf das, was in Zukunft für die Leute klinisch relevant sein wird und auf das, was wir auch schon vor 20 Jahren, wie zum Beispiel bei ME/CFS, gesehen haben, auch wenn wir es so wahrscheinlich nicht untersuchen konnten.
Vielleicht kann ich einen Punkt direkt mal aufgreifen und dann würden wir gerne auch mal fragen, ja, ob hinsichtlich der Beteiligung, all diejenigen, die immerhin noch hier sind. Also diese Thematik Post-Covid oder postrespiratorische Infektionen mit aller, sagen wir mal, Wissenschaftstiefe und Power, die gegenwärtig verfügbar ist, anzugehen, ist alles andere als eine Kleinigkeit. Denn gerade weil es so interdisziplinär ist, ist es keine Kleinigkeit. Also immer wenn wir uns damit beschäftigen, und das geht sicherlich allen so, dann ist man sofort jenseits des eigenen Gebietes auch eben in anderen Gebieten. Und es ist, sagen wir mal, geradezu besonders anspruchsvoll. Und deswegen denke ich, gerade auch deswegen die DZGs, das sehe ich schon so, oder ich denke, das sehen wir so, oder Hans-Georg sehe ich hier, auch besonders gefordert, weil wir bei den DZGs ja jetzt schon auch diese Schwelle überschritten haben, über die einzelnen Gesundheitszentren hinauszusehen und genau diese vernetzte Forschung zu machen. Und Ihren Vorschlag aufgreifend, und Stefanie und ich, Hans-Georg, sprachen darüber, ich glaube, sonst ist im Moment jetzt gerade kein DZG-Sprecher mehr da. Doch, ja, Sie sind ja auch noch, also sind wir schon 4, ja. Wir haben ja den Innovation Fonds. Dieser Innovation Fonds ist ja ein Trans-DZG-Förderinstrument, was wir jetzt vor 3 Jahren zum ersten Mal geschaffen haben. Cell- und Gene Therapy war ein Thema, Mikrobiom war ein anderes Thema. Wir könnten uns vorstellen, das in unserer nächsten Diskussion für ein Jahr einzubringen. Das ist allerdings etwas, was dann erstmal mit einmaligen Geldern ausgelobt wird, quer durch alle DZGs, und die Voraussetzung ist sogar, dass mehrere DZGs sich beteiligen. Das hat auch sehr gut funktioniert, das hat zu der Vernetzung beigetragen. Das ist ja ein Par-excellence-Thema, um so gefördert zu werden. Also ich kann jetzt nicht sagen, wir entscheiden das jetzt mal hier, weil wir jetzt gerade zu 4 sind. Also wir werden das intern besprechen, aber das ist ein naheliegender Gedanke, den das aufgreift. Wenn wir allerdings dann über einen einmaligen Anschub hinausgehen wollen, dann müssten wir schon gucken, ob wir das vielleicht auch mit so einer gewissen öffentlichkeitspolitischen Unterstützung, weil das Thema ja schon auch immer politisch gefragt wird. Also wir kriegen schon immer Anfragen mal, die aus der Reihen der Abgeordneten kommen und dann sagen, was tut ihr da eigentlich? Ja, ob man dann das vielleicht sogar noch ein bisschen in eine Sonderkonstellation überführt. Darüber kann man nachdenken, aber der Gedanke wäre zum Beispiel so auf diesem Weg schon mal einen Einstieg zu finden. Aber ansonsten würde ich jetzt mal nach Fragen fragen. Ja, bitteschön. Jetzt haben wir alle nur ein Mikro. Also ich könnte auch ohne Mikro reden.
Ich habe eine laute Stimme. Ja, ich wollte noch mal anregen, dass man auch die prospektiven Kohorten nicht außer Acht lässt. Also ich denke da zum Beispiel an die NARCO. Wir brauchen ja präpandemische Proben, um wirklich auch weiterzukommen bei diesen ganzen Biomarkern. Und das wäre mir jetzt noch mal ein Anliegen, dass man das auch noch mal erwähnt. Wir brauchen auch, glaube ich, in der NARCO eine bessere Bestimmung vom Long-Covid-Status und auch anderen Syndromen in dieser großen Kohorte. Ich meine, da haben wir 200.000 mit vielen Proben und ich glaube, da sollte man auch noch mal dran denken, dass man auch dafür vielleicht gewisse Gelder bereitstellt, weil ich glaube, dass es da jetzt gerade nicht so richtig weitergeht, liegt unter anderem auch daran, dass da Gelder fehlen. Also das wäre mein einer Wunsch und der andere Wunsch wäre auch die anderen schönen Kohorten, von denen wir heute gehört haben. Ich denke natürlich auch an unsere, die haben jetzt sehr viel Daten, die haben sehr viel Proben und auch Laborergebnisse, aber es muss ja weitergehen. Wir müssen ja über die Omics sozusagen auswerten und dann wirklich auch über die verschiedenen Kohorten hinaus. Und da, glaube ich, wäre es auch gut, Geld dafür bereitzustellen, weil sonst liegen die ganzen Daten irgendwo und werden nicht entsprechend ausgewertet. Und wir brauchen gerade das jetzt, um wirklich weiterzukommen und die Blackbox jetzt mit Licht zu füllen.
Ich wollte noch mal kurz was zur Stigmatisierung und dann zu dem Thema sagen. Ich erlebe das gar nicht so. Das mag in der frühen Phase so gewesen sein, in der Forschung meine ich jetzt spezifisch. Als wir in Baden-Württemberg angefangen haben, das zu besprechen mit der Politik, aber auch in den Kolleginnen und Kollegen war die Bereitschaft, in dieses Thema einzusteigen, enorm. Und als die Epilog, die heute auch vorgestellt wurde,